帕金森病的治疗啊，一直是一项复杂的系统工程。传统的治疗模式呢，局限于患者到医院和医生进行面对面的沟通。同时 ，DBS 术后的晨控也需要患者频繁地往返于家和医院之间，这给患者和患者家属造成了身体和精神上的负担，增加了医疗成本，降低了医疗效率。当科技、医疗、互联网加作用于帕金森的时候，我想我们能够看到更多人的欢笑。无线远程随访系统的诞生，为患者和医生的术前诊断与术后随访、晨控方面建立起了一个新的生态。景域无线远程随访系统由患者端穿越宝和医生端远程随访系统两个部分组成。穿越宝连接网络即可与医生连接，医生在远程随访中心与患者的穿越宝建立联系，通过穿越宝看到患者实时情况，通过远程网络对患者的参数进行调整，同时也可以看到患者的病历资料、用药情况，设置预约门诊时间，管理患者资料。那么这个系统到底是如何运行的呢？
喂，客服你好，我是患者马强，我想约葛医生再帮我调整一下参数。
马先生你好，我是葛医生。
葛医生你好，
你预约了我们的晨控门诊，我正用穿越宝和你连线。你感觉现在怎么样？
有点抖，感觉有点紧。
你按我说的做，我看看你的身体情况怎么样。马先生，我需要给你调整参数。
好的。
好的，我看到你的参数了。我现在给你调整参数，你感觉一下。你现在感觉怎么样？
轻松了，也不抖了。
那你先休息，感受下参数。我一会儿再拨过来看一下你的情况。现在你站起来走几步看看。很好，那这次就这样。你如果有不舒服的话，就告诉我。
葛医生，下周我们公司有一个旅行，您看能不能帮我调一下参数，让我这个身体状态啊更好一点？
好的，我已经给你预设好了。
谢谢。
你自己用患者晨控器看情况选择。无线远程随访系统的诞生，解决了患者在路途劳顿、家人时间、门诊排队等各方面的难题。它的出现产生了极大的便利。自此，未来应该有所不同。
This is CIRC, a cost-effective portable arm system that provides assistance in a variety of neurosurgical procedures. Its full integration with BrainLab navigation leverages established workflows, setups, and instrumentation. Lightweight and compact, CIRC easily attaches to the table side rail
Құрметті қонақтар, әріптестер және серіктестер. Қазақстан Республикасы Президенті іс басқармасы медициналық орталығының атынан және өз атынан әлемдік жетекші сарапшылар инсультке қарсы 7-ші халықаралық пікірталас нейрокурсының қатысушылары мен қонақтарын бүгінгі шараның басталуымен құттықтаймын. Dear guests, colleagues and business partners, let me welcome and thank our honored partners, European Society for Minimally Invasive Neurological Therapy, and colleagues from NEUROADDICTS Society and Society of Vascular and Interventional Neurosurgery and Neurology, CASNEURO, for support. The 7th International Discussion NEUROCOURSE is a significant event in the scientific and practical sphere, not only in Kazakhstan, but also in the entire global scientific community. The dialogue will allow us to attract participants of medical communities from near and far abroad to share best practice and discuss innovative approaches. The frames of 7th International NEUROCOURSE discussion, leading experts from Kazakhstan and international experts in neurosurgery, neurology, interventional neuroradiology will participate in interactive consultations and hold discussions with live broadcast and masterclasses. Within 3 days, international specialists will demonstrate unique experience, scientific developments, and effective ways of treating stroke in other vascular brain pathologies. Dear colleagues, we have an opportunity to compare our priorities, identify the main directions, and discuss the current issues of modern neurosurgery. I am confident that this event will give all participants and organizers the opportunity to demonstrate potential, strengthen scientific and practical business ties, and expand the horizon of cooperation for the benefit of the health of the citizens of our countries. Барлық қатысушылар мен қонақтарға нәтижелі жұмыс пен сәттілік кәсіби әріптестік салаларын кеңейтуді тілеймін.
От имени Центральной клинической больницы разрешите поприветствовать вас на данном мероприятии. Хотел бы отметить, что проведенный дискуссионный нейрокурс стал традиционным для нашей больницы. С 2017 года он проходил в таком интересном формате, когда в операционном зале идет операция с демонстрацией онлайн, а в конференц-зале проходит ее активное обсуждение участниками. Проведенный нейрокурс проходит при активном участии организации Центра нейрохирургии и его руководителя Мажалты Салавича. Благодаря таким мероприятиям устанавливаются партнерские отношения с коллегами из разных стран, идет активный обмен профессиональным опытом и обучением молодых специалистов. С каждым таким нейрокурсом география стран-участников расширяется. Разрешите пожелать всем вам результативной дискуссии и получения новых знаний и навыков. До ближайших
Thank you, Konstantin Mishich. And now we will start our scientific part, and I don't see Professor Chapeau and Guilherme Pirot, and I asked Marcus to moderate the first session, and Mikhail, if you can join. Yes. The first presentation, I think Demetrius is waiting online, and it's 6:30 in Qatar, and I think we can allow him to present.
Yes, so thank you very much. Good morning, everybody. My name is Markus Mühlbuch from Heidelberg, Germany. Thank you, Münzel, for inviting me. It's a great pleasure. Actually, it's the second time for me to be here. So we start right away with the first session, as you have already heard. And the first speaker, I think, will be Vitor Mendes Pereira from Toronto, Canada. And he will give a talk about AVM treatment first, and afterwards about robotic surgery. I've heard Vitor is not online, so first we go for Dimitrios Lopez from Chicago, US.
Good morning, how are you?
Good morning, Dimitrios.
Good morning, and I really appreciate the invitation. Thank you so much for the introduction, and I wanted to share with you a topic that I think Vitor for sure will be together showing today what's present future of robotics in neurointervention. And I would like to say that today we have a system that this is one of the systems that's available, and it's called a core path. It was originally developed for the use on cardiology, and but it can be used for different types of systems, and in terms of allowing us to do also neuro procedures, even though in the United States it's not yet FDA approved for that concept. What's interesting about this is that you have the ability to have, for the first time now, a system that allows the use of at least two devices, a catheter and a wire, and you have here, for the most part, also not a complete remote experience. You're able to do this, but you are shielded from the X-ray. You can see here, you can be in a room, in the room, and you can have a protection and control. Sometimes you can be in the control room, and the system is able to do coronary procedures and neuro procedures at this point. Now, the initial experience with this, it's been, I think, very positive, because this is a paper that was first prospective and a trial that was demonstrated at ESMINT, and this trial was mainly European and Canadian centers were doing aneurysm treatments. So for the first time, you had neurointerventions done with a robotic system, and interesting enough that everybody was extremely, I guess, excited to see this initial experience, to know what exactly this future could look like. And slide here that demonstrates a little bit of how much the operators that were used to do this procedure, just open or regular endovascular techniques without using robotic systems, how they were able to perform this in a very skillful way, and actually have a tremendous high rate of success on performing the procedure. There were few device malfunctions, so this is, I remember, first generation of robot being used for neurointervention, and so the stroke rate, the complication rates, and especially aneurysm rupture rate was 2.6% on the study. And if you compare this to other studies that were doing no robotic intervention, like HELPS, MAPS, and Cerecyte trials, you can see that it really compared very well from a thromboembolic standpoint in intraprocedural aneurysm rupture. But interesting enough is this issue here, Raymond 1 scores on coiling with robotic system. There was a high rate of Raymond 1, and this was a bit surprising, and maybe we can extrapolate why this is happening. You're able to maybe place more coils or more effectively occlusion of the aneurysms to a Raymond 1 on the first treatment, and that was definitely probably one of the most exciting things we saw on this. Now, moving from here, this is the first step. You saw now an aneurysm, elective surgery, but how about when potentially could make a huge difference is when you do these procedures now as a remote type of situation. So some of that we have done in cardiology, and there's actually a trial now that's starting to look into coronary intervention at a remote type of robotic setting. And so you see here a little bit of some of the setups that have existed today, or how far you can be. In neuro today, we have Iacono system, and with the Iacono system, we're able to do this with having the not only the robotic system, but also the ability to use the control of the machine, so the C-arm and the table in a remote way. So you have the remote robotic system doing the procedure, but you also have to test the ability to move the table and the C-arms and remotely, which would make us then probably ready to go to an intervention in this fashion. We're talking about now an acute procedure such as a remote robotic thrombectomy. Another component with current system of robotic that we have is that we had to develop the right aspiration catheter for it. And I have to say, MIVI, and I think Walid can comment a bit on this, but it was amazing how the Super Q system, and here goes a little bit of the characteristics of this catheter, but I will go into fast to say that the summary here is that this is a catheter on a stick, basically. So you have an aspiration catheter that basically will bring your guide catheter into the intracranial circulation, but the idea is that you are not actually filling the whole lumen of the guide catheter. You are just complementing that by an extension of that, and inside of your guide catheter is just a wire. Why this is ideal? Well, because with the current CorePath system, the only way you can move this device inside of a guide catheter is by having the ability to the robotic system grasping into the wire. So it became very important to have a catheter on a wire to be able then to do the concept we're trying to do. And so I want to share with you a few videos now, and of course invite you to come to Rio de Janeiro April next year for WNC. I think really looking forward to have everyone attending to this one. But let me share with you now a video that will illustrate where we're going with this here. And I think this is a concept that we wanted to be able to do and kind of prove the concept first. And then, so this is the idea, what you would be showing the ability to do a thrombectomy without being on site. So you're basically, this is the animation of this concept. We started by looking, you have a hub and spoke system, and imagine that the stroke arrives about 20 miles away from your hospital. And you have, you understand that this patient has no collaterals, and also it's called what's a fast progressor. So here's the diagnosis. Basically the local team places the access, so the sheath and the guide catheter have to be placed by a local team. Could be cardiology, an IR, or whoever is set up on that hospital for you. And then through cameras, you'll be able to actually monitor the ability of this team to get the initial access to the carotid artery or vertebral artery, and then connect the system into the current CorePath. This is very much what happens. You're now connected your guide catheter to that, to the robotic arm, and now you're going to load the wire, and you can see here the MIVI catheter, the aspiration catheter, on the side port. So you now have two wires. One is the wire to lead the access, and the second wire is the wire that pushes the catheter into the anatomy. So you can see that system of basically you're coordinating first going, the right hand here is pushing the wire forward. So this is a regular wire, either we use a Scientia wire 18 or 24, and this wire can be pushed back and forth and rotate the wire. So you can see that with the center command, the hand on the right side, that's the one that's pushing the wire to the anatomy. So now you're getting access to the clot, and then with the left hand, this lever, you're able then to push the MIVI aspiration catheter into the clot. So basically this is a technique that we call an aspiration technique for the treatment of acute stroke. And then with this, the local team will then connect the aspiration catheter into the aspiration system into the aspiration catheter, and then the thrombectomy starts. You leave this for about 2 minutes, the catheter keeps aspirating, and then you're able to remove the clot from the anatomy. So that was the concept, and that's what we were hoping to do. And it was really exciting. You see here now the blood vessels open after aspirating that. And this can be done potentially, as we describe here, in a remote way once we get all this wiring sorted out and so forth. But the idea of that happening today is becomes very possible when you look at a system like this. Now, I want to show you my last video before I'm done here. And this is basically now our ability to do this in the lab. And this was definitely work of a big team that was able to get this together and share with you this. So let me get here the system. So this is now our lab setup, and then this is obviously in vitro model of acute stroke. You can appreciate the left MCA occlusion here, and we have some ready opaque markers in the clot. You can see the clot here, and we have now a system that you're controlling everything from outside of the angel suite. You have the ability to control. You can see our setup here, that we're not in the room, we have no lead on, and you have now the ability to control the wire as we showed in our animation. This is now a real case that you're going a silicone model, and you can see that we are controlling also the table. You can see here, you can move your table and C-arm without having to go into the room. So literally, there's nobody in the room. You can see in this picture here, this case is being done with no folks in the room attending that patient. For the procedure part, you're monitoring, of course, in theory, vital signs and so forth, but you don't have to be in the room. In this case, we get a little bit of purchase distal to the clot, and then we're advancing with the left hand, the aspiration catheter. Once we go find the interface, we advance a little bit further beyond the interface of the occlusion, and then remove the wire from the aspiration catheter, as you can see here. And then you start now, the local team will go and connect the aspiration catheter to the aspiration system. As you can see here, we have also a clot pod, a trap to grab the clot when it's coming out. The camera system here is essential to be able to see all the operation, how the C-arm is, how the patient is, as well as the ability to see that you capture the clot or not as it's being aspirated. You can see that the clot has disappeared. You don't see much inside of the catheter anymore. So of course, this visual is helpful in the in vitro case. You can actually appreciate when the clot is in, or you can see through your camera system that the clot now is in the clot trap. And you can see gradually after 2 minutes of aspiration, you remove the catheter, and all that you can see here, nobody's in the room, and you're being able to control C-arm, you're controlling the table, as you can see here, and you're controlling your catheter in a remote fashion. And then after the aspiration is done, we do the follow-up angiogram and confirm the occlusion, that the occlusion is gone, and you have a successful thrombectomy. So this is what I wanted to show you. I wanted to show you this concept of that we're probably moving from the current state of treating elective cases like the aneurysms, and you saw the great results from the European Canadian trial. But now I think we are seeing the possibility to do potentially a remote robotic case, and of course, a lot of things have to be worked out. This is also first generation. There are new systems being developed, but the ability that we developed over COVID of having cameras and proctoring cases at a distance, it really increased our chances to be in the room without being in the room. And so I think that that's what I wanted to share with you as an exciting development in our field, and that's potential to reach thrombectomy into places that we couldn't go before. Thank you so much for your attention. Minzo, congratulations in the organization of the meeting, and I really appreciate being part of NeuroAddicts, and I wish everyone to have a great meeting. Thank you so much. Bye-bye. Thank you.
Topic in the neurointerventional field, which is CSF venous fistula. So can you connect to Walid, please?
Can you see my screen?
Not yet, Walid. So give us a couple of seconds. Yes. I think.
All right, good.
Yes.
Sorry. All right, we'll go back to the beginning then. All right, so I'll kind of be brief about this topic, but yeah, so I'll be talking about my experience with embolization of CSF venous fistulas. We have a very large referral, practice here at Mayo, and we've done a few hundred cases now. First of all, none of this is possible without a good team of neurosurgeons, neurologists, neuroradiologists, neurointerventionalists, and neuroophthalmologists. Obviously, in the U.S., this is off-label. It's off-label everywhere. These are my disclosures. So I'll talk a little bit about what these fistulas are, how we evaluate for them, a little bit about techniques for embolization, and talk about some of the clinical results that we've had so far. And then this part, due to time limitations, I'll skip over. But mainly the goal today is just to kind of introduce the whole concept to everybody at the meeting. So as many of you may know, spontaneous intracranial hypotension, it's actually not that rare. Our disease incidence is close to 5 to 10 per 100,000, which is just a little bit lower than the incidence of aneurysmal subarachnoid hemorrhage in the northern U.S. in Minnesota. It is more common in women, and it typically affects people in the prime of life between 30 and 50 years old. The clinical presentation, classically, orthostatic headaches, but in some cases, patients can get gait disturbances. Cognitive dysfunction is fairly common, as is hearing loss and tinnitus. In very rare cases, we see coma. Chronic subdural hematoma is also seen in about 10 to 20% of these patients. Our typical imaging findings, we see pituitary engorgement. We can see ventricular collapse. We can see dural venous sinus engorgement as well. Obviously, brain sag is a very common imaging finding in these patients with effacement of the suprasellar cistern, prepontine cistern, cerebellar tonsillar ectopia. That cerebellar tonsillar ectopia results in many of these patients being misdiagnosed as a Chiari, and a lot of the patients that I have seen have undergone Chiari decompression, as a mistake, really. Chronic subdural hematomas or hygromas are fairly common in this patient population. And another imaging finding that we see is pachymeningeal enhancement. There's a few ways to diagnose this. Now, in some cases of patients, if they don't have the brain sag, so I'd say 10 to 20% of patients don't have any of the imaging findings in the MRI. In those patients, if they have the clinical presentation, we have them undergo a radioisotope cisternogram, where we inject indium-111 tracer in the thecal sac and then image them over the course of 24 hours. If you see no radio tracer uptake at the vertex of the skull, that means that they probably have a CSF leak somewhere. So here's just an example of a patient that had a left T8 CSF venous fistula, and you could see how even at 24 hours, we didn't see any radio tracer uptake in the cerebral convexity. So what do we do to evaluate these patients? In addition to the brain MRI and or cisternogram, we have all patients undergo a whole spine MRI. The purpose of the whole spine MRI is to evaluate for the presence or absence of an extradural fluid collection. If you see an extradural fluid collection, then the patient has a dural tear somewhere in the spine, and you have to do a CT myelogram to figure out the location of that dural tear. If they don't have the extradural fluid collection, then that means that they likely have a CSF venous fistula. And in those patients, we do lateral decubitus digital subtraction myelography. So what is a CSF venous fistula? It's basically direct connection between the intrathecal space and a vein in the neural foramen. Kind of looks like this. Often it's associated with a nerve root sleeve diverticulum. It was actually first described in 2014. And, as we start doing more and more of the digital subtraction myelogram, we're identifying these with increased frequency. Interestingly, patients often report a sudden onset of symptoms, but overall, the mechanism of these CSF venous fistulas, of their formation, is pretty unclear. How do we diagnose the actual CSF venous fistula? We used to do MR myelography, but even in patients with bad brain sag and symptoms, our diagnostic yield was only 14%. We used to do traditional CT myelography, and we saw our diagnostic yield of close to 7%, so pretty low. We switched to digital subtraction myelography in 2017. It's basically a procedure where you image them in the lateral decubitus position, right side down, then left side down. We use a standard biplane room, and our table has a capacity to tilt up to 15 degrees. So we have them on the table, and then we tilt them, generally around 5 to 10 degrees, to have contrast go down the spine and in the nerve root sleeves. What does a CSF venous fistula look like? So this is like a really good example. There are some examples that are harder to see, but this is a nice example. There's contrast here in the thecal sac, and you can see where this diverticulum is. You'll see how the contrast escapes from the nerve root sleeve and enters into the venous system. I know it's in the venous system because it's in this linear area, and you can see how the contrast is getting washed away. Here's that is again. Here's another nice example of a CSF venous fistula. But our diagnostic yield for patients with a high probability of CSF leak is close to 70%. And I'd say it's even higher now that we've gotten more and more experience. Now, how do you treat a CSF venous fistula? Surgery, it was kind of like the mainstay of treatment initially. In our series of 44 patients that underwent surgery, well, first of all, a lot of patients, we had them all undergo blood patch ahead of time. And only one patient that we had that had a CSF venous fistula that got blood patch had any persistent improvement beyond 3 months. 42 patients underwent surgical nerve root and nerve root sleeve ligation, as well as cauterization of the veins in the foramen. And of those, about half were cured. About a quarter were better, much better. And another quarter, there was no change. And the ones that did not have any change, it may be due to the presence of multiple CSF venous fistulas, or recurrence of CSF venous fistulas. But I think more likely than not, these patients probably had multiple CSF venous fistulas, because that's something that we're seeing now in close to 20% of our patients. Importantly, anytime somebody's talking about headache, there's always a risk of placebo effect. Of the patients, though, that had a postoperative MRI, 23 had resolution of brain sag and pachymeningeal enhancement. 7 had no change. So, we see objective and subjective measurements of improvement. Blood patch has been tried in these patients, but the efficacy rate is around 10%. It's really not effective. It's a good thing to start with, though, because it's so low risk, but the odds of the patient coming back for definitive treatment, either embolization or surgery, is pretty high. So we described our experience in treating these in 2020. It was our first 5 patients, and we saw complete resolution of signs and symptoms and radiographic findings in 4 out of 5, and partial improvement in 1 out of 5. Here's one patient with a subtle but definitive CSF venous fistula. This was the initial brain MRI. Patient had a pituitary cyst also, but so you can see how the brainstem looks deformed, and the cerebellar ectopia, pachymeningeal enhancement. And we did the embolization. Brainstem gets normal, and so does the pachymeningeal enhancement. Another patient, large CSF venous fistula, here at right T4. You can see mammalopontine distance, suprasellar cistern, prepontine cistern, way too small, pachymeningeal enhancement. We treat the fistula. Imaging findings completely reverse. So what does the procedure entail? Typically, these are found in the thoracic spine. I don't know why. Maybe it's because there's 12 levels in the thoracic spine and only 7 in the cervical and 5 in the lumbar, but we see a vast majority, 89% in the thoracic spine. Do azygous vein catheterization. Then we do the venogram, paraspinal venogram once we navigate a microcatheter into the target vein. And then we embolize the vein with onyx. So our typical case is a fistula in like the right mid to lower thoracic region. So you'll see the video here. The azygous vein is located right above the right mainstem bronchus. So I point a vertebral catheter or hockey stick shaped catheter posteriorly. And then I advance the wire into the azygous vein. Then I advance my vertebral catheter deep into the azygous vein. Following that, I advance like a benchmark catheter or envoy or chaperone or any, 5 to 6 French guide catheter into the azygous vein. After that, we do a venogram to confirm our location in the azygous vein. And you can see here that these are like the paraspinal veins right here. So then after that, we proceed with catheterizing the paraspinal vein using a microcatheter, microwire. It's similar, getting into these veins is similar to getting into the intercostal veins when we're doing spinal angiography. They're just that there's valves that you have to fight with sometimes. But you can see here, finally, we get our wire into the vein, and then we're going to advance our wire into that paraspinal vein. And then eventually we get the wire underneath the pedicle, which means it's close to the foramen. And once we have that, we basically confirm our location with the venogram. You can see here, I confirm my location. And then, if you're using a balloon catheter, which is not a bad idea because, the flow is against you anyways. So, to keep the onyx from refluxing into the azygous vein, it's nice to have a balloon present if you can. And then we proceed with the embolization. So when we do the embolization, we want to see some onyx in the epidural venous plexus. We want to see lots of onyx in the neural foramen, which is underneath the pedicle. Here you see some's getting epidural. And then I like to see some in the paraspinal vein and some in the intercostal vein as well. That means then the CSF venous fistula has nowhere to escape to. Our series of 40 patients was published at JNIS this year. Similar demographics, 3-to-1 female to male ratio, 50s was the mean age. We measured headache improvement on a 36 to 75 point scale called the HIT6 score, significant reduction in headache severity. Minimal clinically significant difference is 6 points. We saw a 26-point drop. Most patients reported that they were very much improved following the embolization procedure. The severity of brain sag also reduced significantly. And there were some minor complications. Local site pain from the onyx is very common. Rebound intracranial hypertension is a very common, complication. Often can be managed simply with Diamox. What is rebound intracranial hypertension? You can imagine a patient, chronic CSF leak, they're leaking CSF. The choroid plexus now starts to overproduce CSF to compensate. You close the leak, but in the process of closing the leak, the choroid plexus loses its capacity for autoregulation, and they get a buildup of CSF, and then they can get the opposite of what they had before, a headache that gets worse lying down, better standing up. But that's typically managed, in some cases it gets really severe. They can't sleep, and they, like nausea and vomiting. In those cases, we typically do like high dose Diamox. Onyx emboli to the lung, sometimes we do have some little bit of onyx reflux. It's always been asymptomatic though. This is a nice article that's accessible to anybody. It explains how to get to any neural foramen, to treat CSF venous fistulas or anything. I found this technique to be useful to treat like epidural fistulas as well, like epidural arteriovenous fistulas, and I've used it to treat a spinal dural arteriovenous fistula type 1 on one occasion. This is just kind of like I just want to maybe I'll just show maybe one more video. But basically, the beautiful thing about veins is that there's multiple ways to get to any particular location. So, one of the areas that I found to be extremely challenging initially was the veins of the upper thoracic spine. And I would find myself, you get into the azygos vein, and then there's a vein that comes off immediately once you get in, called the supreme intercostal vein that goes to T1, 2, 3, 4. And I found it really hard to make that turn. There's really no catheter that's designed for that, and the microcatheter would herniate out. But then I discovered that if you get into the vertebral vein, you can navigate into the cervical epidural plexus, and from there basically get to any neural foramen. This video will show a nice example of that. Here you see just advancing the wire up, and where is the vertebral vein? If you've ever done today I was doing a venous sinus stent, and I'm just pushing the wire up to get into the jugular vein and break the valve, but sometimes the wire goes medial towards the cervical spine. When it does that, that means you're in the vertebral vein. So here you can see I'm trying to get in. This is severely accelerated, but you can see how the wire went medial towards the spine. It's actually in the foramen. It's in that C7 foramen. Then I do the venogram. You can see the epidural venous plexus right here. Okay. And then I basically, this is severely accelerated, but, try to, this is all acceptated, but eventually I made it underneath the pedicle into the cervical epidural plexus. Then I'm navigating the wire down the cervical epidural plexus and out the foramen of T2. So now I got my microcatheter in the foramen of T2, little bubble there. And then, just proceed with the onyx embolization from there. So if you're having trouble getting into any foramen, maybe try to foramen above, foramen below, go in the epidural plexus and navigate above or below. It's a nice technique. For the left-sided thoracic ones, we access the accessory hemiazygos vein. So again, I'm getting the azygos vein right here. I'm now finally into the azygos vein. Do the venogram, and this is the accessory hemiazygos vein. Okay, so it's like the left-sided, right? So then I advance my micro-wire, and I'm trying to get into that foramen, and I'm able to get my microcatheter into that foramen, do the venogram to confirm the location, and then proceed with embolization. This, is, it's a little bit harder than the right lower thoracic ones, but it's definitely feasible. And then, another thing that I've done sometimes is for the left lower thoracic is to get in the ascending lumbar vein, which is that vein right here, comes off the left common iliac. You can see that right here. And then I just navigate from the ascending lumbar vein into the lumbar epidural venous plexus, and then navigate all the way to the foramen that you need to. So the epidural venous plexus is like a beautiful pathway to get into these neural foramina. And also it's engorged in patients that have SIH. They have low CSF, so the venous plexus engorges, just like the dural venous sinus engorges. Just so you know, I have done cases all the way down to S3 and all the way as high as C1. So, regarding future directions, I'm working on designing a randomized trial. This is to help mainly to get some evidence for the procedure, but also to help convince payers in the U.S. I'd say maybe like 2 to 3% of the patients that I've treated, I've had some like issues with insurance, but usually when I tell the insurance company that the alternative is an open surgery, they say, okay, you can do your procedure. There's maybe potential role for newer liquid embolic agents, and in other areas of like a prospective clinical registry might be interesting. These are some references. Happy to take any questions.
There's one.
So thank you very much for your fantastic presentation. So what kind of complications we can have after the procedures?
Yeah. So the big complication that I've been scared of that hasn't happened yet has been like some spinal venous ischemia, because you're putting lots of onyx in, and you don't know where the great radiculomedullary vein is draining ever. But I think there must be lots of redundancy for the venous drainage of the spinal cord, because as of yet, I've not seen any patient that's had a venous ischemic myelopathy, but that's something that I'm certainly scared of. Some things that I've seen, like intraoperative technical complications. I've had a few cases, probably more than a few, where I've perforated the epidural vein. Now, perforating the epidural vein initially, I was thinking, when I did that, the first time I noticed it, I immediately did a CT and tried to figure out, did I do something bad going to happen? Are they going to have a terrible epidural hematoma? But if you think about it, the venous pressure in the epidural venous plexus is extremely low. It's 2 to 3 millimeters of mercury. And the interstitial pressure is much higher. So none of these cases have I seen like a epidural hematoma. The most common like real complication that I see is the rebound intracranial hypertension. In some of these patients, it can be really challenging to deal with. In some of these patients, they can get florid papilledema. And I've had 3 patients that after embolizing a CSF venous fistula, they were severely symptomatic from their hypotension, but then it became severely hypertensive, severe intracranial hypertension. 2 patients I had to treat with the venous sinus stent, and then 2 patients have had to undergo shunting. So that's the main complication that you see.
Well, thank you very much. It's Mikhail Grigorian. Fantastic presentation. Really quick question.
I saw that you were speaking on your microphone, but I didn't, there was no sound.
Oh, I'm sorry. Can you hear me now?
Maybe somebody could put the question in the chat.
Okay. Yeah, I guess you can't
hear us. I hear you now.
Can you hear me?
Mm-hmm.
Is there any need for general anesthesia during these from the standpoint of patient comfort, or do you do them all under moderate sedation?
I do most under moderate sedation. I'd say 80%. I would do it under general anesthesia if the patient is very anxious. And some of these patients are essentially chronic pain patients and can be very anxious. But I'd say 80% are done under sedation, and 20% are done under general anesthesia.
Thank you very much, Walid. Great presentation. Thank you. We're going to move forward to Vitor Mendes Pereira, who I think is ready now, and he will be presenting next. Thank you.
Thank you.
Guys, are we able to connect Vitor, or shall we move to Adnan Siddiqui's lecture instead?
So the other option would be, if we cannot get Vitor, we can go to the presentation from Adnan Siddiqui, which is a pre-recorded session.
Alı'daki?
Of course, how do you like to change? We have two options. I think we can turn on our presentation. Are they ready, or should we go for Adnan's presentation? Yeah, go for Adnan's.
Okay, we continue with the recorded session from Adnan Siddiqui, and he is going to talk about flow diversion treatment for intracranial aneurysms.
Hello, everybody, my dear friends and fellow neuroaddicts. It's a delight for me to be able to talk to you. I wish I was with you, but I look forward to making that trip again for the next year. I apologize, but unfortunately, I have to be at the finals of the Soccer World Cup. And so it was very difficult for me to take part in a conference or watch the final. So I hope you all understand, and I appreciate Minjil very much, your hospitality, and I look forward to availing myself of that next year. That said, let me get down to business. To talk to you about flow diversion and to talk to you about what's next. Here are my disclosures. So flow diverters really started as an evolution of a concept. A.J. Waklu was doing his research and clinical fellowship here in Buffalo when he paired up with Barry Lieber and noted that when you put a stent across an aneurysm, there was a disruption of flow within the aneurysm, and that resulted in a redirection of flow, or flow diversion from the aneurysm back into the parent artery, and that bore fruit. This was confirmed through hemodynamic simulation. So in this case, you put in one flow diverter, you get a significant reduction in the velocity within the aneurysm, you get an increase in the turnover time, and you lower the wall shear stress. This is true for all stents, but even more so for flow diverters than anything else. And if you put in multiple flow diverters, the effect is amplified. The end result is that when you deploy a flow diverter across such as an aneurysm like this paracroid aneurysm, very typically we'll see the flow stasis, and typically that translates into an occlusion in more cases than previously we were used to. So this is a beautiful example of a multi-segmental distal cavernous disease with multiple aneurysms, difficult to treat. With flow diversion, restored the anatomy, and the aneurysms are gone rather quickly. Initially, it was approved for uncoilable aneurysms under the PUFS trial that we participated in, and then subsequently, Ricardo and a wonderful team did the PREMIERE trial that, again, we participated in, resulting in a wide expansion of indication criteria, demonstrated as smaller aneurysms, the most common ones, paraclinoid, treated with a singular flow diverter with complete remodeling. So current indications are for all aneurysms up to the ICA terminus, and they have subsequently been expanded beyond pipeline to SURPASS from Stryker and FRED from Microvention. They're all different iterations with a stent within a stent or flow diverter within a stent with the FRED device. There are other devices not available in the US that are globally used. P64 has been very popular as well, which is a nitinol-based braided device made by Phenox and works very well. Pipeline embolization was modulated to a new called Flex, and most recently into a Shield, and even more recently into Vantage, essentially the same chromium cobalt deployment, which can very nicely accommodate vessels in tortuosity, as noted in this cone beam CT. So when you look at the meta-analyses that have been done with flow diversion, this one done by Dave Kalmus and Waleed and the Mayo Group, really noted that there was a pretty good result in terms of complete aneurysmal occlusion at 6 months, with a 5% morbidity, 4% mortality. There was some delayed subarachnoid hemorrhage and ipsilateral and contralateral intraparenchymal hemorrhage, which remain major complications. But stable, good results can be achieved, such as in this ruptured dissecting aneurysm treated with flow diversion and coiling. You can see beautiful remodeling of the vessel with flow diversion. This is a giant thrombosed MC aneurysm treated very nicely with coils. This is distal vertebral aneurysm treated with stent and coils with great remodeling of the aneurysm and with long-term cure. So you can certainly consider adjunctive coiling in cases where you're concerned about aneurysm rupture, or to stabilize the construct in very large devices, or to take care of saccular components. But let's talk a little bit about where this field is going and a little bit of the evidence that we have thus far. So when distal aneurysms are concerned, we're concerned that the vessel caliber is smaller. There are more perforators that might be located there. There's an issue with sizing, there's an issue with delivery, there's an issue with porosity, and side branches. And so the concern is if you undersize, you may have trouble with occlusion. If you oversize, you may have a problem with occlusion of the aneurysm and the side branches. So there's a lot of data that has accumulated. There's one that we participated with 65 patients with very good results in the A2, M2, and P2 distribution. The problem remains the delivery catheter. A lot of this is the pipeline data with 27 microcatheters, but I believe that's going to change with things that, again, you all might be used to with Silk Vista Baby and others, which are much nicer delivery systems with smaller microcatheters than the traditional pipeline 27 system. I think that might change with Vantage, but again, we don't have experience with that yet. There is a slightly higher complication rate than other locations, which are more proximal, but occlusion rates seem to be very good. The Silk Vista Baby certainly appears to be a very good favorite with very good occlusion rates and complications being comparable to larger vessels. Another one with Fred Jr., again, similar results with complications being slightly higher in the posterior circulation. So let's take a look at this case. It's a right PCA aneurysm. This is a patient who comes in with an MRA showing a dissecting aneurysm of the distal PCA. Certainly could stent coil this, but I believe this is just a very straightforward aneurysm to treat with flow diversion. Microcatheter is delivered. Once we are there, then you take a flow diverter and deploy that reliably across that. And smaller devices almost invariably open very easily with a very good rapid deployment with immediate stasis evident in the aneurysm with great results. So I think that certainly can be helpful. Here's another example of a complicated case. This is somebody who presented with subarachnoid hemorrhage, large aneurysm, PCOM 7 years ago, had a craniotomy, clip ligation, and intracerebral hemorrhage evacuation. And subsequently, the aneurysm came back and was coiled and comes back now again with re-rupture. So there's large recurrence of the aneurysm. You can see the hemorrhage. You can see the coils have been placed. And now the patient's back, not ruptured, with a large recurrence of the aneurysm. And so in this case, again, we go ahead, and the first challenge is the fetal PCOM, true fetal PCOM. So in this case, how do you preserve that? And the idea here is we use a little Simmons technique to be able to cath this vessel. There you go. And once we have that, then we deliver a microcatheter through that, confirm we are there, and then drop an Elvis stent into the ostium of this vessel. There is the Elvis stent's been placed. Once we have that, then we go ahead and place a flow diverter in the ICA there that's being deployed. And once the flow diverter is in place, then we jail a microcatheter. And so there's the flow diverter, there's the Elvis, and now we can put in coils protecting the ostium of the fetal PCOM. You can see the great stasis that is there. And we go ahead and we coil this, and the aneurysm occludes very, very nicely. This is the immediate result after the procedure. Here's another case of what we call a matricidal aneurysm. This is a thrombosed paraclinoid aneurysm, but now has a growing PCOM associated aneurysm. And here you can see when we go through the PCOM, there's a flow-related aneurysm because that's how the MC is filling. So there you can see the aneurysm. So in this case, we go ahead and we confirm that this is IC is completely occluded, and we have some flow from the across, but primarily the flow is from the PCOM. So we go ahead and we size this, and then we go through the PCOM, and this is pipeline being delivered from the MCA across the PCOM into the basilar. And certainly this is difficult because this is the old classic design, and this is after the flow diverter is in place and has been placed, and this is sort of the final result, and the vessel remodeled very, very nicely. Moving on, distal bifurcation aneurysms, we have some great result from our Turkish friends who really have been the biggest proponents of this for the longest time, with the flow diverter placed across the larger branch with remodeling. They have a whole classification, Ishil and Saru, to describe this beautiful deployment across the bifurcation aneurysm and progressive remodeling and complete resolution. You can see from this aneurysm down here, really just models very nicely. There is some stenosis of branch vessels, but it appears to remodel adequately with collateralization without long-term consequences. For typically very difficult aneurysms, this is a perfect example of one, the flow diverter resulting in gradual remodeling. And people have looked at it from a variety of different ways with very good long-term occlusion rates, slightly higher complication rates. So when we really look at all the data that are there, I think the complications are relatively higher than anticoagulation, larger vessels. But I think when alternatives are complicated, this is something to be considered. Moving on to ruptured aneurysm. Clear, and lots of studies have been done. Most aneurysms that were treated were blister and dissecting with fairly good rates. So can we do something else? Here's an example of 36-year-old comes in with likely a dissecting aneurysm of the A2, probably caused by the adjacent falx. So we go ahead and treat her acutely with balloon assist coil with very good result. But progressively, you can see the aneurysm starting to recur. So we bring the patient back for treatment, and the aneurysm's even bigger in just a few days. And so we go ahead and place a flow diverter across this aneurysm with very good deployment. And this is the final result. And you can see delayed results look fantastic. In Buffalo, we have done a few others for blisters. This is a 49-year-old presents with a small, likely dorsal carotid wall blister aneurysm. There you can see it. And we go ahead, deploy a singular flow diverter. There you can see the aneurysm very nicely. No coils, dropped across the aneurysm, and complete resolution of the subarachnoid. The final controversy to talk about, posterior circulation. Certainly, fusiform aneurysms. We know posterior circulation aneurysms have a higher risk because of the perforators, but particularly what to do about dual equectatic holobasilar large fusiform aneurysms. When we first wrote about it, initially when we first got our hands on flow diversion, we ended up really not changing the natural history at all, and 50% of patients died as almost as a consequence of the procedure. So we became slightly less ambitious, left the holobasilars alone, did some smaller aneurysms and with segmental disease, and we had much better results, stroke rate of about 10% without complications. So the question was what to do about these holobasilar aneurysms, and They are problematic because there are perforators which still arise from the diseased wall. They're atherosclerotic aneurysms. And so that is why we thought maybe try to do something different. So we recently wrote this paper with AJ and others, which looked at triple therapy for dual-equectatic holobasilar aneurysms. And this is a perfect example. This is a holobasilar diseased vessels, all atherosclerotic with triple therapy. And this is the dual antiplatelet therapy cohort. Again, very similar diseased vessels. And really, there was no big difference in the age and mostly predominant male symptoms or disability or aneurysm size, quite similar, with very similar intrasaccular thrombosis. But when we look at the actual intraprocedural complications, rather rare. Ischemic complications were there in both, but much higher in the dual than in the triple therapy. Hematomas were about similar, and you've got to be careful about the Foley catheter, and we recommend radial access if possible because of groin complications. And so the other thing to keep in mind is that when you really, this is the most important finding, is that overall modified Rankin score decline, which is natural history, was very common. 69% had a complication with progression in their modified Rankin score disability, compared to only 7% with triple therapy. Higher rate of hemorrhagic complications in triple therapy, not enough to cause a modified Rankin score decline. Complete occlusion was more common in dual antiplatelet therapy, rare in triple therapy. But when you look at the delayed follow-up rate here, these people, we're changing natural history by using triple therapy. And I think that is a really important part to keep in mind here. And so who needs higher occlusion with a patient who's not alive or much worse? So I think that this may be something right interesting, and you can see these are really delayed follow-ups, well over a year. So dual antiplatelet had higher occlusion, but more acute ischemic progression of symptom leading to overall worse disability. And so it's much better with triple therapy, lower occlusion rate, but less strokes, and manageable and usually non-aneurysm related. So I think certainly it's better to not go for acute or rapid angiographic cures, and therefore it's more important to consider longer stroke-free survival for these patients with gradual remodeling using triple therapy. Here's a quick example. 67-year-old comes with mid-basilar fusiform with holobasilar disease. You can see ectasia up to the SCAs, placed on dual antiplatelet therapy, single pipeline placed with great contrast stasis. Post-procedure apixaban was added, and MRS follow at 900 days, MRS of 1, and this is the progression. This is what we started with, day 445, day 720. You can see gradual remodeling of the vessels. There's a 68-year-old, again, holobasilar disease with lower basilar fusiform, single pipeline, aspirin plavix, apixaban after the procedure. This is the result with some stasis and MRS 0 at 660 days. Again, look at the difference. This is what we started with at 210 days, really not much different, but gradually at 700 days, so 2 years later, it's really starting to look like we're finally getting somewhere. Final topic, early evidence that there may be some value in surface modification. We have SHIELD, now we have VANTAGE, we have HPC P64, and the FredX is now available as well. What remains to be seen as to what the value is of these technologies. In conclusion, flow diversion has been revolutionary, no question about it. Started on the bench top, delighted to say that Buffalo at least provided host, while the genius was Barry and AJ Wako's. They really changed the landscape for how we treat aneurysms. Certainly, we're starting to expand the original indications in a variety of different conditions, We have growing evidence in these places. We have new tools, better delivery systems, and blister aneurysms, we believe, should ideally be treated with flow diversion in the ruptured category, as well as potentially dissecting aneurysms. And then posterior circulation remains a challenge, particularly dolichoectatic, with maybe triple therapy something to consider. And we await the introduction of surface modification and the data to support that, because I think that would be a wonderful thing to move forward. Thank you very much. I'm delighted to be able to talk to you, and I hope you will all enjoy Minjil's hospitality and enjoy the beautiful country of Kazakhstan and its cuisine and culture, and my very best to you. Thank you very much.
Thank you. I think now it's time for the first live case. So can we connect to the Angus suite, please? I think.
Yes. Could you hear me, Marcus?
Yes, we can hear you.
Okay. Today we have patient, 60 years old, female. She had a ruptured MC aneurysm on the right side and has another 2 aneurysms on pericallosal artery on the, I think it was the right side, and the MC aneurysm on the left side. Firstly, at the time of rupture, she was coiled in emergency hospital in Almaty, and it was partially coiling of the MC aneurysm, and then our colleagues coiled the pericallosal aneurysm. Months ago, we did the half T-stent assisted coiling for the right partially occluded MC aneurysm with the half T-stenting. I think you have my screens, yes?
Yes, we can see your screens.
Marcus?
Yes, we can see your screens.
You can see. Okay. Now I use this nice possibility from the Siemens. It's a Flex Vision. The name is Flex Vision, yes? This white screen, yes. Laran is also with us here. We are in the hospital with Professor Speil, with Daulet, he is assisting me, and Bakht is our nurse, and the anesthesiology team. And Evgeny are supporting us to transmit this case to the YouTube and the conference room. We did a half T-stent assist coiling. At the end of stenting, Leo baby stent was placed like this. We compressed at the neck level. And
can we switch back
this
to
part,
the
we have a stent
screen, please?
here, and the remaining part of the aneurysm was coiled with the balloon assistance in this branch, and the stent was partially opened at the upper branch. This aneurysm was coiled in emergency hospital. And at the same time, we saw the aneurysm on the MCA.
Minjil, can you wait?
Yesterday, I heard this case in NEUROADDICTS, and I asked for some opinions, but as usual, no opinions, because so many options could be used in such an aneurysm. This is trifurcation. Yes, Marcin Miś from Poland said that it's possible to use a teddy bear technique. He already published in 2015 or 16. Yes, now we have a presentation on Zoom, but I think it's no need. Patient already had a craniotomy on the right side for the hematoma at the bleeding time. And she is pre-medicated with Brilinta, 90 milligram twice a day. We didn't waste the time, and we placed scepter 4x20 in frontal branch, going to the motor area. And now we place the headway duo into the lower branch. First of all, we tried to place the headway duo to upper branch, but the angulation and this dome of the aneurysm usually not allowed to put the catheter. It's all the time technical tips and tricks needed. Now, headway duo in this shape through the aneurysm went to this branch, temporal one, and we plan to use Comaneci for this branch, and we will open the Leo Baby 2.5 by 35 from this point till this point. We'll compress at the neck level and place a couple of coils inside the aneurysm. Yes, the alternative option could be placing the Silk Vista 3 by 25. Marcus?
Yes, so thank you for your explanation. I think your strategy is clear.
I have voice in the operating room and I have my microphone. Okay?
Okay, good luck.
And about the screen, is it enough? Could you see these images?
Yes, we can see.
Okay. This is headway duo in the temporal branch. Now I will straighten the headway duo. It's straight now. Comaneci veriniz? Comaneci. Comaneci. Leo Baby 2.35. Okay, I will take the instrument. Okay, and for the coiling, I will use headway 17, and we have two wires. It's a Chikai Black and the Traxxas 14. Okay.
Marjel, can you hear us? Hello, Mincy. I suggest that we discuss here
the application of Philips to measure the length of the stent. Simulate, it's difficult. Okay. Okay, person. Okay. Professor Spell did a perfect simulation of the wire navigation with the Philips. I think in between we will ask Professor Spell to repeat this. At no need? Maybe, yes. Так, this is it. Comaneci aşağı. Гепарин veriniz? Гепарин я в шприц наберу. Yes, Comaneci will prepare with heparin. Heparin, berkubik. Okay. Now we have little baby inside the scepter.
It's
it was an option strategy. To use Eclipse double lumen balloon, but it was problem last time with the long stent. Time to time, it's not working. Devlet. Интересно. Круто. Okay, we introduced the little baby inside the sector. Now I prepare the Comaneci. It's a braided stand-like device, and it's a stand balloon.
It's an interesting combination to use the balloon and the Comaneci, because when there are two balloons, both are likely to displace. But I don't know if the Comaneci is going to be able to make that acute angulation.
René, hello.
Hello, Minsil. We're trying to discuss here a little bit on the technique.
Yes, with Comaneci in this acute angulation could be a problem, but I'm expecting the coil is not, will try to go closely to this branch. We will use the flow diverter-like possibilities of Leo BB. And also there is a option, we may place flow diverter in second session if it's needed. I think my colleagues has experience with flow diverter in such kind of MC aneurysm. What would be the follow-up result? Okay. Nader, are you in the room? And Professor Spell, what do you think about the follow-up results for?
Maybe a class 5 occlusion, which means that the aneurysm is still there.
Hi, Minzil. It's Nader. I'm in the room.
Nader, hi. I'm happy you finally leave the France, Paris.
Me too.
This time, all companies, including Germans, delaying. Okay, Comaneci in place. Able to control run. And now I will try to push Leo baby. About FD in MCAs. Flow diverters in MCAs. What could be the occlusion rate and complication rate for side branches?
There's no series for that.
You can speak here.
There is no series, so it's difficult to answer this question. I have no answer.
Yeah. For me, it's like a Professor Moret in the operating room, and he all the time say, I have no answer for this. And also this aneurysm is ugly shaped. Yes, he liked this word, ugly shaped aneurysm. We are waiting for Professor Moret for the afternoon session. Okay, baby is coming. 2.5 by 35 is time to time very hard to push. And the problem, we have no chapeau table. All instruments on the patient. Okay, the stent is arrived. I think AP is more. I especially took the balloon for security, and I learned from Professor Chapeau, it's better to have 2 parachutes when you do parachuting. And I little bit modified these sentences, idioms. It's like an idiom. It's better to have condoms when you have unsecured sex. Yes, embolization is all the time have some risks. And it's better to have the balloon inside the patient than on the table. Okay, this is headway 17 coming. It's a shipping. When one instrument is inside the vessel, the second is trying to go to follow.
Is there a way we can?
Coming from Essen, yeah.
Is there a way we can improve the focus? Because the pictures are a little bit out of focus and it's hard to see with so many microcatheters and devices there. Can we play with the focus a little bit?
The quality of the image, yes. You have also the unsubtracted images on upper screen. Could you see it, Mikhail?
When they get magnified, they lose the focus. We can see the images, but they're out of focus. Just to recapture for the audience, you have a guide catheter, you don't have a distal access catheter, and you have 3 microcatheters in there doing different things. Is that, did I understand correct?
Just a second.
Just to go over the setup so that everybody's on the same page as to what you're doing. Okay, that's a good quality. Now it's clear.
Asahi Hyperion, coronary Judkins right, 3.5. And then we place the scepter balloon to this parietal branch. And now we open partially the Leo baby till this point. And we place the headway 17 inside the aneurysm. Now tip of the microcatheter with the Chikai black inside the aneurysm. And this is a tip of Comaneci device. Here is starting the Comaneci, and this is the end of the Comaneci. This is headway duo for the Comaneci 17. Now it's clear?
Absolutely. Now the pictures are great. And to comment your point, I think 3 catheters are difficult to be brought through an intermediate catheter, which is then the ratio.
Yeah. I fully agree. Now I will overexpand the Leo baby. And then it would be 3 millimeter stent. 3.2. I think now is better. Then we have another 5 millimeter anchor. Maybe we can a little bit pull it back, but then stent could be a little bit unstable. I will do run.
I think we will all see better if we just have one screen of unsubtracted images rather than all. the AP view.
Evgeny, I will ask my technical colleagues to do it. Спираль аспиранс, Туртион, Оптима. Женя, можно будет сделать верхние две, показать? Вот эти две верхние. Да.
Там никак. Получается полностью ваш экран берем.
Okay. Just a second, I will adjust the monitor. Optima 31. Отделился бересонс. I think this one could be better.
Much better.
Could you see me?
Yes, it's very good like this.
It's better?
Yes.
Then we can put like this. Женя, надо будет нашу картинку вниз спустить, направо. Да. It's a beauty of Philips, but this function available only in Almaty. Thanks to Philips team. And thanks to Philips team, we got this module for taking all screen for the streaming. I waited for 2.5 years and finally done. The first coil would be Optima 4x20. I think we can do like this, it's more better. Lateral, I think, this is better. The main projection is AP. A second. And this option of smart mask is very good, and I think on Icono is also Professor Chapeau is using mostly this roadmap, smart mask, from the DSA. It's more precise. The coil is coming. Now I will inflate the Comaneci. It's mainly inflated inside the branch.
Не знаю, как это работает, но работает все более-менее. Все нормально.
Yes, angulation could be the problem. Now it's better. Now we have Comaneci inflated. Do you see this? Гипериндекс. Yes, гипериндекс. Yeah, perfectly. I can see the Comaneci. A second. Professor Chapeau, do you see this?
Yes, we see now that the Comaneci is expanded, and you had to reposition it a bit and probably to increase the level of expansion, but now it's doing the job properly. The baby Leo seems to be a bit overexpanded. Is this correct?
Yes, I overexpanded for the purpose. I will try to coil the right part of the aneurysm. Just a second. We'll expand more the little baby.
It's a very interesting and tough procedure.
I think I need to bring. No, it's better. It's a little bit at the back side of the aneurysm. Maybe this coil is too big. 8-8 бересің. 3. Yes. Maksat is saying it might be a little bit big coil. Okay, I will measure the 8-8 жоқ па? It's a beauty of Azurion. You can measure in the operating room with the mouse. Just a mouse and no joystick. That's why I like the Philips. Nice. This one. 2x 6 бересің. I think 4 is a little bit big because the Leo baby expanded till half of the aneurysm diameter. Yes, it's too big. And also we discussed yesterday the possibility of bypass of the opercular branch and the temporal branch and then just clip the aneurysm. But it's also a little bit complex surgery. I think in the room we have microsurgeons, Serik Dishembi from Astana, our very experienced microsurgical colleague. He used to work in China for several years, and now he's working in Astana. And also Rabbi Jangeldinch from Karaganda. I deflated Comaneci because I think the coil is going through the Comaneci. Now I will reinflate. Okay. This is 3 millimeter coil. Okay, after that we have this option number 3. We can use telescopic Leo baby for this aneurysm and finish the case. Then it would be like a FD treatment. It's possible to use the 2 Leo babies. Possible to use 2 Leo babies in telescopic. Yeah. Okay. Yes, all coil is going to that point. This is too small. That was too big. Okay. Just a second, I will look for the coils. Maybe we need a helical one.
Yes, and what about taking a first coil which would be quite stiff, something like an 18 coil, because the aneurysm is quite large and the chance for coil number 1 to be displaced by coil number 2 is probably not that small.
Axiom. Yes, I will try to use Axiom. It's a stiffest coil. Because Optima is too soft in this case.
But definitely there is no hurry, and it's better to take your time to make sure that the first coil is properly placed.
Yes. Now it's Axiom 4x12, but it's also 3D coil. We'll see. I started my career with the Medtronic Axiom coils, AV3 at that time, and its old enemy is better than new one. Enemy or friend, yes. Okay. But on lateral, if you see the lateral, all coils is going to the front side of the aneurysm. Just a second. Let's see this 3D. Okay. If you see this aneurysm, this branch coming from the top of the frontal branch, and now coil is coming to this point. I will try this projection. 116 cranial 5. It's nearly like this. This is on AP and this is on lateral.
It seems to be good.
I think the coil is not reaching the upper branch.
Do you want to deflate the Comaneci and reinflate to make sure that there is no coil loop which is caught inside?
Okay, yes. But firstly, I will recoil because one loop is going a little bit up. The first loop. Now it's better. Yes, now it's better. Yes, I remember the case with the loop of the coil inside the Comaneci. Like this. Okay, now we will deflate. Yes, so on the lateral view, you can see the upper branch is clear and protected with the stem. Here, yes, branch is coming from this point and it's covered with stem.
Yes, it's very
And
clear.
the common edge is deflated, yes. It's a little bit small room here. Maybe I will replace the coil. Yes, Professor Chapeau. I think this loop is going a little bit closer to the temporal branch. It's very close. It's too close to the temporal branch. I think now is better. This coil is not touching the common edge and also the upper branch is secured. I think we can detach the coil. Okay. Yes, and axiom detachment is like a Valabi coil. It's by hands. Тройка минут, двойка минут. Пересмысленно. One notice from the Optima coils. In small size of coil, the Bolt company changed the introducer hub, and now it's a little bit complex to introduce. It's soft, too soft. The second coil is 3 by 6. Optima, 3 by 6.
So we have a confirmation that Optima is softer than the Axiom, so that coil number 1 was not displaced, which is a good thing.
The next coil, 2 на 6. 2 by 6 Optima. ECD6. Soft. Okay. The next coil would be 2 by 8. I think this is better. Еще блин. Microplex var. XD6, XD8. Yes, for the next coil, I asked the microplex. One more. Отделялся береси. XD6. And in the program, we scheduled 2 live cases, but we prepared 4 cases for today. It would be the 2 intracranial stenosis and 1 more brain aneurysm with new FD stent from India. New flow diverter. It would be the case number 3. And for the stenosis and aneurysms, we will connect at the time of the main part of the operation. And I will ask technical team to put the operation to the second screen during the second, third, and fourth case. Женя?
Yes.
Женя, можно будет потом вторую, третью, четвертую операцию?
Can we case number 2, 3, 4 put on the second screen? Can we?
Control Andrew. Maybe it's enough. Do you think we need more coils, Laura?
The lower branch is enough. There is a problem on the lower branch.
Because of combination. Yes, Professor Spellis noticed enlargement of the lower branch because we dilated with the combination maybe after angioplasty. Who would like more coils or it's enough?
Measure, we want more coils.
Usually the last coil is extra coil. Okay, we'll see. 2 на 6. I think we need to do CT before taking out the combination. Okay. Next coil is microplex 2x6. And with the microvention all the time, sometimes it's problem to take out the coil from the tube. Yes, and the beauty of Comaneci, you can inflate and forget about it. I think one more, no? Тағы біреуін бересіңізші. This would be the last one. I think it's enough, and we can deflate the Comaneci, and we'll do the control CT for the lower branch. It was not detached, and now I can see. It's not detached. Okay. Let's see again. Тағы біреуін берші. Yes, it's detached, but yes, now it's detached. I took out the headway 17 from the aneurysm. We'll inflate the Comaneci, deflate the Comaneci. It's not expansion, it's overlaying two branches, yes. I will show you. This is, you see the lower branch looks enlarged. And when we deflated the Comaneci, we nicely see there is a bifurcation. You see? Okay. Okay, I will retrieve the Comaneci. Yes, it's a beauty of headway dual. I like this microcatheter. Yes, Comaneci outside of the aneurysm. Now we can detach the baby. Yes, now we give the birth for new baby inside the patient. And you can see the stent is nicely opened. Okay, I will deflate the balloon. This balloon deflated. A couple of minutes, we will do control run, and then we will do control CT, and I think in which point we can continue the presentations, Marcus?
I think now it's time for a coffee break. So let's say now it's 11:23, so we go to coffee break until 11:45, and then we continue. Is that okay for you?
It's okay, but I think you can give me only 2 minutes or 3 minutes. We do expert CT to show everything is okay, and then I think coffee break is okay.
Okay.
Okay? I will just take out the headway duo. Yes, if it's failed, this treatment, that's why important to have only one instrument. There is 2 headways, and I went to the 17 with the Traxxas. Yes. We have already the Comaneci inside the duo. I will just take it out. And patient will continue Brilinta for next 6 months. And control first MR would be after 3 months, and angiography will turn in next 6 months. And for the next 5-6 days, we will keep patient on anticoagulation with the Clexane twice a day, 0.4 milligram.
Manjil, can I ask you a question?
Yes, yes.
Since we're waiting, just to facilitate discussion, if you were able to catheterize the temporal branch so early and put Comaneci so easily and put Comaneci in there, why not stent that branch too? She's going to be on aspirin and Brilinta anyway.
Yes, then we can call it T-stenting, or it would be Y-stenting, and then we will increase the potential complication rate for maybe twice.
You think the stent will thrombose?
We can provoke the thrombose with this. And if there is a Y stenting, and if this treatment fail in 6 months or 1 year, then it would be problem to do FD treatment delayed. I think it's options from this kind of.
I think it's a very nice result. Of course, the aneurysm is not completely done, but you cannot take the risk to put more. And it may continue to further thrombose, which would be great. Otherwise, you always have the opportunity to add a flow diverter inside the baby Leo. So it looks very good.
So please come back to the room at 11:45. Thank you.
You can keep the video on for the 1 minute and then we will finish. So you are all live or
Нету, да? Раз, два, три. Раз. Да-да.
This is CIRC, a cost-effective portable arm system that provides assistance in a variety of neurosurgical procedures. Its full integration with BrainLab navigation leverages established workflows, setups, and instrumentation. Lightweight and compact, CIRC easily attaches to the table side rail, saving valuable footprint in the OR. With its fully integrated computer unit, CIRC is ready for use in a matter of seconds. Grip sensors release computer-controlled brakes and enable movement in 7 degrees of freedom. The robotic module adds another 4 degrees of freedom and offers precise trajectory alignment. Sensors ensure correct mounting of the kinematic. CIRC is now ready to perform a cranial biopsy. After moving CIRC towards the trajectory, its robotic module precisely and automatically completes the approach. Sharp teeth anchor onto the bone for secure stabilization of the drill guide. All brakes are securely locked while navigating the biopsy needle safely to its target. CIRC unites intuitive human guidance with the precise execution of robotic alignment.
Работа интервенционного нейрохирурга, конечно, очень интересная, но и довольно сложная. Это постоянное облучение, работа в рентгенооперационной, а также ночные операции, ненормированный график. Но самое сложное – это невозможность помочь пациенту вовремя. При остром ишемическом инсульте, когда закупорился сосуд головного мозга, лечение очень зависит от скорости проведения операции и реканализации сосуда. С помощью ангиографической системы ARTIS-ICONO мы, как врачи, имеем возможность сократить время пациента, проведенное внутри больницы, от поступления до самой операции от 30 до 60 минут. Это увеличивает шансы благоприятного исхода для пациента на 12%. Меня зовут Давид Саакян, я эндоваскулярный нейрохирург в медицинском центре Эребуни в городе Ереван. Немаловажное значение имеет именно скорость проведения самой операции. На ARTIS-ICONO есть возможность использования так называемой системы Case Flow. В зависимости от процедуры я могу заранее запрограммировать позицию стола, трубки, положение детектора и настройки экранов. Таким образом, просто нажатием одной кнопки я могу выбрать необходимый протокол, и аппарат автоматически, начиная от стола до рентген-трубок, встает в нужную мне проекцию. Одной из особенностей ангиографической системы является стол, который имеет возможность наклона в разных проекциях, что позволяет использовать его также при гибридных, открытых и эндоваскулярных процедурах. Ангиограф дает широкие возможности нейровизуализации. Это относится и к плоскодетекторному интраоперационному КТ, и к 3D и 4D ангиографии, и к перфузионным исследованиям головного мозга. Так называемая система оптик значительно снижает радиационную команду врачей и пациентов, но при этом сохраняет постоянное качество изображения.
Приходит, нет? Ну,
мы очень сильно зависим от оборудования и очень сильно зависим от инструментов, которые мы используем. И я выбрал для себя ARTIS-ICONO, потому что он позволяет расширить мои возможности в оказании своевременной и качественной медицинской помощи моим пациентам.
11, 12, 13. Раз, два. Раз, два. Что?
Представляем рабочий процесс для диагностики и лечения ишемического инсульта в рентген-операционной на одном аппарате ARTIS-ICONO Biplane. ARTIS-ICONO Biplane поддерживает рабочий процесс механической тромбоэктомии с 3 новыми этапами рабочего процесса. Он сводит к минимуму переходы между модальностями и может сократить время от двери до области паха за 34 минуты. Сначала необходимо определить, нет ли кровотечения. Чтобы повысить качество визуализации, в ARTIS-ICONO используются 2 ротационные наклонные траектории для 3D-сканирования, помогающие преодолеть появление артефактов от костных структур, окружающих базальную часть головного мозга. Второй этап также важен, как и первый. Теперь ангиографическая система оснащена режимом динамической визуализации коллатеральных сосудов, что позволяет сканировать 10 объемов примерно за 60 секунд. Третий этап соответствует действующим рекомендациям по тромбоэктомии о проведении перфузионной визуализации для выбора лечения в течение 6-24 часов после появления симптомов. Программный режим Dyna-CT Multiphase предоставляет КТ-подобные карты перфузии, позволяющие определить области головного мозга с нарушением кровотока и сниженным объемом крови, а также с задержкой поступления контрастного вещества непосредственно в ангиографическом кабинете, что сокращает время до начала лечения. Не покидая рентгеноперационную, мы можем выполнять механическую тромбоэктомию и документировать ее результаты, используя гибкие возможности биплановой системы. В частности, после тромбоэктомии можно выполнить цифровую субтракционную ангиографию. Клиника Базельского университета добилась значительной экономии времени благодаря новой системе, о чем свидетельствует доктор Мариус Психагиус.
Теперь мы проводим все диагностические исследования в рентгенооперационной. Для пациентов с подозрением на окклюзию крупных сосудов и оценкой NIHS больше 9 это может сэкономить от 30 до 60 минут времени внутри больницы.
Imagine that when you switch from one plane, then two planes, and then 3D space view, you have a clear understanding of the anatomy, not only the anatomy, but all the relationship with the environment. So honestly, 3D was just, being blind and coming to light. And then came all the process of the 3D picture that we have today. This reconstruction, the MPR, the slicing, the overlapping, with the CT.
Okay, so I think it's time to start with the next session. So, as you know, my name is Markus Möllenbroek from Heidelberg, Germany, and I'd like to present you the LIQUID trial. So what is the LIQUID trial? So the LIQUID trial is an investigator-initiated observational prospective multicenter study on the treatment of high-grade dural AV fistulas treated with the embolic agent squid, which is from the Bald company. So, and we looked, of course, to the safety, i.e. permanent morbidity and mortality, and the complete occlusion rate at 90 to 180 days after treatment. So as usual for GCP trials, the study protocol was published in the clinical trials database, and an ethics approval was given by the committee. So here you see the different inclusion criteria. So as I mentioned before, we only included high degree dural AV fistulas, so Lariboisier or Cagnard type 3, 4, and 5. And of course, the intention was to use the squid as the main embolic agent. And all the images afterwards were core lab reviewed by the University of Lübeck from Dr. Boppel and Professor Schramm. So here you see the patient characteristics. We included 53 cases with a mean age of 60. The majority of patients were male patients with different comorbidities, as you can see here. 19% of the patients presented with an intracranial hemorrhage, but they had also other symptoms like headaches. Some of the patients were asymptomatic, or some presented with an initial seizure or with neuropsychiatric symptoms. Here you see the distribution between the centers in Germany. So the majority of cases were included in my center in Heidelberg and at Alfred Krupp Krankenhaus in Essen. Here you see the different characteristics of the dural AV fistula. So the majority of the fistula were located close to the superior sagittal sinus or to the transverse sinus or at the region of the torcular or tentorium. The main feeders, as usual, when we talk about dural AV fistulas, were middle meningeal artery followed by the occipital artery in 1/3 of the cases, and then you have different arteries like the posterior meningeal artery, the ascending pharyngeal artery in less than 10%, but in close to 30% of the patients, they had bilateral feeders coming from both sides. So here you see the distribution of the grade of the dural AV fistula. So more than 50% of the patients had a grade 3, and 40% had a grade 4 dural fistula, and 2% had a grade 5. You see that we performed 55 treatments in 53 patients. So there was one treatment in more than 96% of the patients. In the majority, we used squid 18, and in 1/3 of the patients, squid 12. So in some of these patients, it was a combination of squid 18 and 12. Here you see the different volume and the procedure time. And as usual for dural AV fistulas, in most of the cases, the middle meningeal artery was used for the embolization, followed by the occipital artery and other arteries. The microcatheter, which was used for embolization, was in more than 60% the marathon, followed by the septal balloon or other microcatheters or balloons like the Eclipse 2L, for example. And additional coiling was only performed in less than 6%. If we look to the adverse events, so then we observed in 10 adverse events, so in 80% of the cases. So 2 were intraprocedural, so there was 1 dissection and 1 microcatheter rupture, and we had 8 after the procedure. So there were 2 groin hematomas, a seizure, 1 case of an intracerebral hemorrhage, 1 pulmonary embolism, and this was unfortunately fatal, 1 pneumonia, and 1 visual disturbances. So 7 out of 10 recovered without any sequela, while 1 recovered with a sequela. This was the patient with an intracranial hemorrhage. One did not yet recover. This is the patient with the visual disturbances, and one patient unfortunately passed away. That was the patient with a pulmonary embolism almost 1 week after the treatment. So this treatment was performed in acute stage of intracranial hemorrhage, and this patient had a long history of different diseases, so there was no embolic material in the lungs. This was confirmed on CT. So at the end, we had a permanent morbidity rate of 3.8% and a mortality rate of 1.9%. Regarding the occlusions, you see immediately after the treatment, a complete occlusion was observed in 94% of the cases, and after a mean follow-up of almost 6 months, this was confirmed with a complete occlusion of 93% of the cases. So here you see some case examples. This is typical dural AV fistula located at the level of the superior sagittal sinus. So here the middle meningeal artery was used for embolization. You see that we are very close to the fistula point. I'm not sure if I'm able to, let me see if so the fistula point is right there, and then you see at the venous outflow two venous ectasias or aneurysms, and this is the unsubtracted view after embolization of the fistula point and the venous ectasias, and this is 6 months follow-up control within complete and stable occlusion. Here you see another patient with a dural AV fistula located at the posterior fossa. So he complained of headaches, and you see here, this is the mastoid branch coming off the occipital. Unfortunately, the pointer is, it's difficult to use. So this is the occipital artery, and then you see here the mastoid branch which was used. Here you see in yellow the course of the microcatheter. This is a marathon. And after embolization with squid 18, the fistula was completely occluded, and this is the 6 months follow-up with a stable occlusion. Here you see a more complex dural AV fistula. So you see branches coming from the middle meningeal artery. You see branches from the inferolateral trunk, from the ICA. You see branches from the ICA. So this is the labyrinth artery, for example. And here, again, we used, as usual in most of the cases, the middle meningeal artery for embolization. And this was a combination of squid 18 first, and then at the end, we continued with squid 12. And this is the 5 months DSA control in this patient with a complete and stable occlusion. Another patient, he presented with an intracranial hemorrhage, and you see a dural AV fistula in the posterior fossa again. So here you see that this fistula is fed by bilateral branches. This is an example for this, and here we used the hypoglossal division. So this is an anatomical variation. So usually this is the branch, or one branch from the ascending pharyngeal artery, but in this case, this branch is located on the occipital artery. And again, here you see in yellow the course of the microcatheter, which is very close to the dural AV fistula. And then again, a combination of squid 18 and 12 was used in order to embolize this fistula completely. And here you see the 6 months follow-up DSA, and the patient recovered to an MRS of 2. I think this is the last case. This patient presented with an acute stage of SAH, as you can see here on the CT. And again, this patient had a dual AV fistula located at the posterior fossa, and in this case, we used a dual lumen balloon catheter, and because of the control of the reflux, in this particular case, we used immediately squid 12, and you see here the casts after embolization, and this is the 5 months follow-up DSA control with a complete stable occlusion, and this patient recovered to an MRS of 0 at follow-up. I'd like to thank all the participating centers, which you see here, and you know obviously a couple of names on this list. And I'd like to thank for your attention. Thank you. Do you have any questions for the use of squid in dual AV fistula embolization?
Yes, I have a question. What is your technique when you inject squid from the occipital? Because, you know, penetration is very difficult. I'm just asking this for the audience.
That's a very, very good question. So if you use the occipital artery, my experience is that if you use the creating a plug technique and then you like to push the material, this quite often doesn't work. So you have to control the reflux by either using a balloon or to create a pressure cooker. So that's my experience. Using the plug and push technique from the occipital artery, especially from the mastoid branch, doesn't work because usually with your microcatheter you are still outside of the skull. And the branches going through the skull, they are very, very thin. And for this you need an almost 100% control of your reflux. Otherwise, the material will go in the occipital artery and you are not able to penetrate the fistula. I think you have the same strategy, Nader, right?
Yes. I started to do this with the balloon, double lumen balloon. I prefer it as a pressure cooker because it's mobile. So usually you have several branches along the occipital. So I start with the distal one, I deflate more proximal. So
we do.
I think it's very practical.
Yeah, I think so too. We do almost the same. Yeah.
And now we use also the Scepter Mini for smaller branches like the middle meningeal or something like this. Sometimes we use the Scepter Mini that goes in very small branches.
Yeah, there's one, I think, important...
Recording in progress.
One important notice, so if you like to use a balloon, sometimes the balloon can move more proximal during the embolization if the pressure is getting higher and higher. And one trick to prevent this is to place the balloon inside a curve, if it's possible. I think in the meningeal arteries, it's quite often possible, or in the occipital one, and then this can at least somehow prevent the movement of the balloon more proximal. Not in 100% of the cases, but I think many times. Any further questions?
Yes, your choice finally between 12 and 18. Is there any rationale to use the more diluted?
It's a good question. So when we looked to the data, we saw that over time the centers started to use 12 more and more. So one important point, of course, is the level of experience. And the other point is if you have a full control of your backflow, of your reflux, then of course you can start with 12 right away. But if you don't have the control of your reflux, I think it's not a good idea to start with 12 first, because then creating a plug only with 12 could be very, very difficult or almost impossible. So then you have to start with 18 and afterwards you switch to 12. You can take my microphone.
Sorry, thank you so much for the very advanced techniques to deal with very complicated AVF. I'm asking a question about one of your patients suffer from intracerebral hemorrhage. Because I think that it is maybe the penetration of the pile draining, retrograde draining veins may be sacrificed. So I'm asking what is the cause of your bleeding, intracerebral bleeding from AVF? Post-operatively.
Yeah. So usually in dual AV fistulas, the bleeding comes from the venous side. So basically the idea is to close the we call it foot of the vein. And this is what you usually do if you do an open surgery. You just close the starting point of the vein, and that's it. And of course, this is the same idea if you go by endovascular approach. And it's usually not necessary to occlude venous ectasias like in the first case, but in that case, it was very simple to do, and we thought, okay, we should continue until the venous ectasia, because in this patient, we thought this could be the bleeding point, because the patient had a rupture 1 month before. Okay, so if there are no further questions, I think we can continue. Laurent is not here, so René, would you like to continue with your presentation? Thank you.
Take the microphone. Okay. So let's switch on the presentation. Okay. So I've got the pleasure to share some thoughts on the treatment of AVMs. And definitely AVM treatment is on one side rather reducing, because all the expectations to cure AVMs by the arteries are somehow disappointing. Since 40 years, AVMs are treated by the arteries, and the cure rate is far from surgery, far from radiosurgery. Radiosurgery, an AVM up to 25 millimeters has a cure rate of 70–75%. The cure rate in the literature for usual results of embolization is 30%, something like this, with a high level of variations according to the place. So I had a good idea to bring my computer to plug it in, but it seems to be a bit difficult. I hope that it will work at some point. So what did change a lot is the introduction of venous embolization. Embolization by the vein is a way to increase the risk, because once you occlude the vein, you're obliged to succeed. You cannot say, whenever you don't know anymore, it's safer to stop, which is what is always done in the artery. When to stop transarterial embolization? When you reach a point where you don't understand anymore. And when you don't understand, then you say, it's enough, which is a very safe way of handling. But unfortunately, if you go by the vein, you don't have this option. That's why if a treatment is done by the vein, it is logical to have an AVM which is not too large, because the more there are vessels and shunts to occlude, the more it will be difficult to be able to occlude all shunts. So if you did not have up to now an experience with transvenous embolization, the good candidates are the ones that are the worst candidates for any other treatment, which is deep AVM, because deep AVM, nobody wants to treat them. Deep AVM are bad for transarterial. Deep AVM are bad for surgery. And deep AVM are bad for radiosurgery. Yeah, just the window was to be taken off and the presentation is coming. But with increasing experience, you may find a way to understand how the veins are all connected. And if you understand how the veins are all connected, then you may go on vein by vein, as if you would be in a tree and cut a branch. And finally, I think that AVMs are very similar to trees. So we don't need slides for this. If you just think of a tree is made of leaves and branches. The leaves are the arteries, the branches are the veins, which means that most of an AVM, oh, I don't need the slides anymore. No, of course, I take the slides, please, leave the slides. Hold on, I've got a mouse here. Maybe I can put it off, okay. So if you consider that the leaves are the arteries, it's not because you take off the leaves of a tree that the tree is not there anymore. And we've been treating yesterday or the day before some patients with incredibly high amount of transarterial embolization with acrylic glue. And I think that we should be aware that acrylic glue embolization just does not work. It does not occlude the vein or an uncontrolled way. Thank you. So let's try to this one here. Okay, it was not a good idea to do it this way. Can I have next slide? The idea was to have, okay. So what is the nidus? The nidus is, next. Okay, definitely I take a USB. So this is the usual picture of a nidus. Is there anyone in the room who understands here the AVM? Ooh, Jens points on. Marcus. Okay. So what do you understand here? It's a joke. You see the vein, you see the artery, and all the important thing, how the connections are, is absolutely not visible. And that's why all the drawings are the same. Next picture. You see here, one artery was red, then it becomes blue. I guess you can see the difference here. Do I have a pointer? No. But you see there's a change, but you understand nothing. But this is what you find in all our books. This is how to understand AVM. In other words, understanding is zero, nada, yet. So next slide. So nidus means I don't know if it's an artery or a vein, because AVMs are made of arteries and of veins. Next. So, and if we do a partial embolization, when we do a partial embolization, we reduce, we make a hole, just like a cheese where we would make a Swiss cheese, but I talked about trees, so I found this picture of a tree. Do we understand how the branches are connected? No. We don't understand. Next. So next. So I do the postulate. AVMs are only made of arteries and veins. I don't think that there are lymphatics, and I don't know which other vessels should be there. So arteries and veins, and we should talk when we occlude a vessel if we have an artery or a vein. Next. To make it very simple, because it may be not simple. Everything what goes to the AVM is an artery. Everything what comes from the AVM is a vein. It seems a bit too simple, but quite often it's true. Next. The so-called nidus is, in my opinion, a venous segmentation. Most of the nidus are only veins. So arteries may be somehow hypertrophic, but just look at anatomy and how veins are made. Veins have a wall which is much less strong, so they may dilate a lot more than the arteries. So all the nidus is in fact made of veins. And how those veins do connect is the most important thing. Next. And this is here a patient that enabled me to help to understand. Next. Next. And next. Okay, next. Here you may see what you don't understand in the middle, and then the vein that goes out, probably a lateromesencephalic vein joining the cavernous sinus, or the uncle vein as its posterior. But we don't really know how those vessels are connected inside. Next. Next. This is a rotational angiogram through the microcatheter. We turn around, but we don't see inside, so it does not explain. Next. Now a catheter has been brought inside the origin of the vein. By the way, if you navigate through the cavernous sinus, it's always a pain. It's really tough to get access to the veins that join the cavernous sinus because there's an anti-reflux mechanism. It works, but usually it's a good hour before you can reach the vein. Next. And this is a transvenous injection. That's a key point. So now it's just a moment where onyx is being injected inside the vein, and you will see the primary veins connecting to the main vein. You see what goes down is a primary vein, what goes up is another one. And if we wait a little bit, we will see all the veins, smaller veins arriving in the large vein. Here you see the main vein which is being filled, and here you see the division branches. So usually it's when you embolize the vein through the vein that you have the best understanding how the different venous branches arrive in the main one. And something which is absolutely not visible by another way becomes visible here. So usually I show this on an accelerated way when my computer is on my side, but you can see here, you can see one primary vein, you can see another one, you can see another one. I mean, you have all the branches arriving in the main trunk. Next. So if this is the main trunk, next. Here are the primary veins, next. Next. Surrounded by arteries. There is nothing more than this. It's not complicated. It's just that our way to look at AVM does not enable to understand what it is. Next. Next. So, how to get to the shunt? Why should we go to the vein and not to the artery? We all have the habit to go through the arteries, so it's supposed to be better because we're doing this and we're not used to do something else. So it's always changing the habits that is the most difficult. But maybe this patient is going to help to change thinking. Next. Look at this AVM. Located somewhere in the centrum semiovale, just beyond the deep ganglia. You have 1, 2, 3, 4, many lenticular striates. 1, 2, 3, 4, 5, 6 lenticular striates and one vein. Is it possible to go through an artery? With some efforts. Next. So if you take a balloon, if you take a magic, if you're patient, after 1 hour, you can get the magic up there. Next. And you see that the magic is at the origin of the vein. My question to you, are we going to cure the AVM? Who says yes? Please vote. Nobody? Who thinks that we are not going to cure the AVM? So, in other words, how sure are we if we inject 1 drop of glue or 10 drops of glue that we're going to kill the whole AVM? The answer is quite unpredictable. We have just 1 catheter. We cannot make a pressure cooker. So we cannot force, which means you start to inject a liquid embolic, whatever it is. It starts to go to the vein. So you reduce speed, you continue to inject, and then rapidly it comes down alongside the catheter. And you don't want to trap your magic, so you have to take it out. So if you don't want to occlude the vein, you may inject a coil in the vein. And this is what we did. Next. Next. You see now there's a catheter in the vein. Navigation in the vein here took less than 10 minutes. Navigation in the artery took more than 1 hour. And in the artery was much more difficult and dangerous. Next. So you see the tips of both catheters are very close the one to the other. Next. And here's a liquid coil, a Bernstein liquid coil that has been injected at the origin of the vein to make sure that if you inject glue, it will stop there. You don't want the vein to be occluded far away. Next. And that's injection. So I did my best. I diluted quite much in order to be able to diffuse. I got the origin of the vein and then started to reflux. And then you stop and then you re-inject and it reflux and then you have to take it out. Is the AVM cured? Next picture. Not really. There's still some flow. So now there are two hypotheses. Favorable hypothesis, atrial thrombosis, and the AVM will be cured in the next day. So negative hypothesis, you have some arterial flow, you don't have a good venous outflow, and it bleeds. But there is a catheter which is in the vein, you've got a control of the vein. So here safety was to bring a catheter in the vein, then to inject 1.5 drop of onyx. Next. And then the AVM is cured. What is better? To use the vein or not to use it? Obviously, it makes sense to use the vein. Next. Okay, next. Yeah, next slide, please. Next. Definitely, it's occluded. So here, I have no doubt that placing a catheter in the vein was an additional security and not I put a catheter in the vein and I do dangerous things. Not to put a catheter in the vein is dangerous. Next. So how to access to the shunts? Sometimes, as in the example we just saw, venous navigation may allow better access than arterial navigation. Next. But it's not because we do a venous embolization that we don't need to put a catheter in the artery. And for many reasons. Because it's the only way to get a selective roadmap of the vein. If you make an injection through the guiding catheters, you will have all the veins and too many things. To make a proper roadmap, you need to have a catheter in the artery, and this may be a lot of effort. The other reason, which is a major reason, when to stop. That's the usual question. You've been doing something, but you don't really know when to stop. Because when you start to embolize, you lose the vein, and then you don't know whether you filled the whole AVM or not. The only way to have an idea whether you filled the whole AVM or not is to have a selective injection to a feeder, which shows if the feeder is continuing and progressing up to the AVM or if you have no flow anymore. And this difference is visible and is quite clear, but it means that at the end of embolization, all the different arterial feeders must be selectively examined, catheterized, and identified. Otherwise, it starts to be dangerous. So it's a lot of efforts. And another reason to have a microcatheter in the artery, if something goes wrong, because the catheter in the vein is blocked, because the vein has a weak wall and it ruptures, at least if you have the artery, you can save the situation. So you need security and a catheter in the artery. Problem, if you go to the vein, you must be sure that all the shunts are accessed, which means you decide if it continues and if you bring it to the shunts, and not the reflux decides. So what we do in atrial embolization, we inject a little bit, and then we have reflux, and we wait, and in the end we have reflux, so we stop. No, this is pure gamble. We must be sure that if we want to continue, we're able to continue. And this is not possible without any plug technique. Next. And plug technique, you do the same for the arteries and for the vein. So just for fun, we call it the pressure cooker somehow, because you can inject under pressure. And you know that French people always talk about cooking. So next. So the retrograde venous pressure cooker, the main limitation, you need 2 microcatheters in the vein and not only 1. And 1 may be some efforts, 2 is more efforts than 1. So the fact to control with a plug avoids to have extensive venous occlusion. When I see patients treated without a plug mechanism, the usual comment is, you can occlude the vein, it's not a problem. Who knows? How can you say that you just can occlude veins? Of course not. The veins should not be occluded. The less vein you occlude, the better it is. Point 2, the amount of injection must not be limited by the reflux. And if you want to continue, you decide. Point 3, next. So here's a drawing with the venous segmentation, with the artery. Next, you bring 2 catheters, both with detachable tip, because it's very easy. You use detachable tip catheters. Through the detachable Apollo, you can inject barricade coils or Kanika coils. Next, some coils are being placed. Next, you start to inject onyx. Next, and you see when the onyx starts to go through the coils. Next, you inject histoacryl. And histoacryl should be injected in several layers. If you start to inject a little bit, half of the vein is filled. So it must be done. Next, and then once you get a plug, then you determine how much you do. Next, next, next. And at some point, you saw the last picture, you go also to the arteries. Of course, there are connections from the arteries to the vein. If you embolize the arteries, you go to the vein. If you embolize from the veins, at some point, you reach the arteries. So that's why you need to control your arteries to know how far you go. Next. Next. So the best understanding is usually while you do the embolization. Next. Next. But there is one technique that we've been working on and developing that we call the 6D, which is a way to fuse different 3Ds, and this helps a lot. Next. So you all know those pictures. You make a DSA, you make a rotational angiogram, and then you've got MPRs. But the analysis on MPRs is difficult. Of course, you see that this here is a vein because it's super large. So the super large thing is a vein, and this is an artery. But to identify each vessel is really difficult. Next. If you take 2 rotations and you put a different color, then it's something that helps. By the way, this is available on all Siemens systems since 15 years. Next. Next slide. So here is an AVM fed by MCA and ACA. Next. If you do the left ICA, you just see the anterior cerebral artery. Next. Here is the...
Chapeau.
Yes.
René.
Mitchell.
Yes, Professor Chapeau, sorry for interrupting. We are ready to show for nearly 3 minutes, if you allow us. We already prepared everything, and just we need to place the stand.
Yes. Okay, but we can stop at any time. So if you have your patient going on, we'll follow the procedure and perfect.
Okay, thank you. Thank you. Sorry for interruption. And we had a patient. Extracranial vertebral artery stenosis, calcified one. And the second stenosis in V4 segment of the main vertebral artery. The stenotic segment is 1 millimeter and the distal is 2.8. This cavernous part of the right ICA was stented 1 month ago. This is after stenting, and it was coronary ultimaster stents from Terumo. And the same stenosis in left ICA, we scheduled for the we did a 3D, it's not important, and we did guiding catheter, and then we can place the protege 8x40. We did angioplasty, but there is a remaining stenosis in the ostium, but it's okay. Then we went with the narrow speed balloon 2.5/8. We already done angioplasty with the narrow speed in 3 segments of the stenosis because it's too short, 8 millimeter. I asked Akandis to produce, especially for Kazakhstan, 15 millimeter narrow speed. Distal marker of the stent here, proximal marker, and the middle marker of the stent is here. I will flex high radial force. In Europe, you call it credo stent. It's not coated by Hill technology, it's just a Clinoflex. And now we will place the stent and we'll do the post dilatation, just 1 minute, and you will continue the case. You will continue the presentation. Thank you. Just a second. The very good point of this reposition.
Münchel, do you always post-dilatate the credo or Aclino stent afterwards?
The Aclino after, yes. It's a little bit went up. I will take it a little bit down. Yes, with Pegasus and the Neuroform Atlas, it's not possible. But with Aclinoflex and Credo, it's possible to resheet, reposition. And this is a quite straight segment. That's why we can go. Yes, the blood pressure is a little bit high because of local anesthesia, and the patient has a. We can. And I will do the control run. Go. I will take out the roadmap and I will try to go inside the stent. I think it's not recommended by the company, but we have a lot of experience with these devices. more than 100 neurospeeds and Aquino placed in stenosis. The nominal pressure of the balloon is 6, but we will inflate till 10. 12 is okay. Because we undersized the balloon diameter. Stands, the radial force is not comparable. This is post dilatation. Okay. I think it's okay. Maybe a little bit in the middle part, we will a little bit over inflate the balloon. Smart mask. I think in stand could be displaced. 16, we'll wanted to take 5, but I think 4 is okay in this case. Yes. Now is okay. We will do control angio and control CT, but patient is awake and no pain, no other symptoms. And we will finish the case. Thank you, Professor Chapeau, and I think we can continue with the presentation.
Thank to you, Minchil, for this nice demonstration.
Thank you.
Okay, so we switch back from intracranial stenosis to 6D imaging. So here we have a 3D of the MCA and a 3D of the ACA, anterior cerebral artery, which is fed by the contralateral carotid artery. So, go. So this is here the anterior cerebral artery as to be seen only by the left side. Next. And if you give a different color, here orange is MCA, blue is MCA, and then you can see which part of the AVM is fed by what. The veins appear in a different color. It's a greeny stuff, a mixture of both colors. And you can see, this is really amazing because in blue is MCA to AC. You see where those connections are that you usually don't see. So it becomes very interesting. And I was just in sagittal, this is coronal. You will see the same. At some point, the level between one and the other one. Next. So if 3D MPR is black and white, and you have the polychrome 6D, the number of information you have is a lot more. Next picture. Just like black and white TV or color TV. It's really this level of added information that you may get. Next. Next. So this is a very simple, I will present this and then I will stop because otherwise it could continue. This is a small AVM, very, very simple, But I think that here we should be in a situation to understand the interest of giving different colors. Next. Now the rotation angiogram. Next. You have two temporal branches, and you see somehow where the AVM is, but you don't see more. Next. Next. This is the injection of the best feeder. So here is something which is well accessible, and from here you can certainly occlude this part by using onyx, no doubt. Question, is it all of the AVM? Next. Next. So here we did a rotational angiogram of the internal carotid artery and of the feeder. So we will be able, next, oh, now you must go on all the time. Next, there are 60 pictures, so continue progressively, continue. Yes, yes, yes. So you see orange is a selective view. We just had something in, go back. Can you go back? Back. Here are fusion of two veins, back again. The shunts that are here are not colored. So you see that you have part of the AVM which is not filled. Next. Okay. Next picture, continue to scroll progressively. Continue. Yes, go on. So here we see the part of the AVM, which is the one which is selectively accessed, but we are sure, by looking at those pictures, that part of the AVM is not accessed. Continue, go on. There are 60, 70 pictures, so just press. Same thing on sagittal views, where we would see in orange where the microcatheter is. And progressively continue. Now we see in blue something which is part of the AVM that we did not access to. So it's quite simple. You know that if you embolize from here, and if you occlude the vein, you're not sure whether you're going to diffuse in the AVM, and this may induce bleeding. Next. We can show it on a different way. This is maybe more simple. You change the phase of the mask. And this is a dual injection through the microcatheter and through the guiding. And you see the part of the AVM where the microcatheter is, which is white. And the black is the part where we did not have access to. Next picture. And indeed, while searching, we find the second feeder, but the second feeder is much more difficult to get. We're not able to go selectively inside, far away. Next. And that's why we decide to go by the vein. I could not move with the mouse. You should have seen at some point that you have the vein that receives two primary veins. It's quite easy to be understood if you scroll 2 or 3 times up and down. Next. Okay, that's access. Oh, sometimes, yes, to bring the guiding in the straight sinus or in the temporal vein, you need to do a PTA with a 3 mm balloon to allow usually it's a Fubuki 7 French to be placed selectively in the outflow vein. And no, that does not seem to be the straight sinus, it's a temporal vein. Next. So this part here is the one that was selectively accessed. Next. And now, next, you may see on both pictures that a microcatheter, a sonic with a detachable tip, has been brought to each division vein. So we get access to each division vein, and then the third catheter is going to be brought here to make a plug. But because of the images we did before, we understand this. It becomes clear, and if it's clear, you can bring a catheter in each vein. Next. Next. And here, the late phase, you recognize the late phase for each side. Next. So occlusion of one first compartment. Here, this is what I wanted to show. You still have a very distal artery, the one which is there, this here, which is still going to the AVM. And you see this, it may be not completely occluded. You cannot leave it like this. Next. 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 Okay, next. Further injection. Next. Now the other compartment is being occluded. Next. Some plug is being added when you start to have reflux, which was quite late. Next. Next. Still the artery to be seen. You see here on the lateral view. Next. Next. So this could be a potential remnant. Next. And some further injection, and after further injection, then you don't see the artery anymore. So because you've got a selective catheter in place, you're able to recognize whether you have reflux or not. Next. And indeed, now it's done. Next. Okay, and I will stop it here. So here are some thoughts on the treatment of AVMs by the vein. The risk of bleeding is the main concern. This rate is something in our experience between 5 and 6%. We've been doing now between 500 and 600 transvenous. We just reached the bench of 550. And I think that the risk is quite small, considering the fact that most AVMs that are treated are grade 3 to 5. So I stop it here. Thank you.
Are there any questions?
Thank you, René. Just a brief question. You explained that the nidus are veins, yeah? Basically
Yes.
veins. So we have the idea that treating a dural fistula means we need to treat the vein. We occlude the vein, we occlude the fistula. For AVMs, we have the idea of occluding the nidus, but in fact, we need to occlude the veins and the primary veins, but in fact, veins. This means that for years, we have been treating the arteries just because we had access through the arteries, but not because we had to. So we did everything wrong?
Yes, obviously. I mean, we must admit that the results of treatment of AVMs is bad. The rate of cure is bad, and most physicians treat less and less AVMs. Aruba and any study tells us that we should not do. The main difference between dural fistulae and AVMs is that in AVMs there is no foot of the vein. And we've been speaking for years of a foot of the vein in an AVM, which shows that we missed this point, that you cannot occlude a vein, which anyway results from many others. And whenever we make a focal venous occlusion, the chance to create a bleeding, I think, is very high.
Any other questions? René, in your last case, how did you deliver 3 microcatheters? Because I have seen only one Fubuki, and usually you can only deliver 2 microcatheters.
No, 7F Fubuki
I was a
enables.
7F.
It's a 7F. Standard is 7F. That's the reason also never to use an intermediate catheter. The intermediate catheters are our worst good friends. It makes the situation easy, but you just can take one catheter. You cannot work with one catheter. I mean, coiling with one catheter was done in the 80s and 90s, but the level of result you obtain with this is quite poor. You don't control. For aneurysms, we always have more than one catheters, and whatever we do, the more we have hands, the more we can do different things.
Okay. Thank you very much. So we go on to the next speaker, and this will be Guglielmo Piero from Italy, and he's going to talk about AVM treatment after gamma knife.
Hello. It works. Thank you. It's difficult to speak after René Chapeau about AVMs. I'm sorry. Okay. In our hospital, we have all possible chances to cure AVMs. So in ruptured AVMs, the first choice is always surgery, and we can do some embos in presurgically for deep feeders occlusion, or to occlude the staged occlusion of the AVM to staged reduct the flow to avoid venous thrombosis after surgical removal of the vein of the AVM. Or gamma knife is the other first choice when surgery is not possible, and we rarely do some embos in high flow fistulas or to occlude pseudoaneurysm, in this case of ruptured AVMs. Some cases we do direct endovascular occlusion of the AVM, but they are very rare, and are also in ruptured AVMs the occlusion is endovascular occlusion is rare. And for ruptured AVMs, again, the first choice is surgery. We can do some occlusion of the deep feeders or pseudoaneurysm. In gamma knife, we can do, in ruptured AVM, we do target embo of the bleeding points. But about direct embo, it's a case we did in a ruptured AVM with this small AVM. Sorry. Okay, this very small AVM. I cannot use it. And what we did was placing a microcatheter in the anterior cerebral artery. The feeder was too big, too small for the MAGIC, so we had just an injection from the pericallosal artery, and then we put a microcatheter transvenously, and then we injected onyx from the venous way, and it was the occlusion. This was before and after the cast of onyx, and at the end the AVM was occluded. This is the cast of onyx. Again. Another case with a singular AVM, and this is the angio, single vein. So when we do direct embo of AVMs are very small AVMs with mainly with a single vein. This is the AVM. Injection of glue before from transanteriorly, 2 injections to reduce the AVM and to have more control. Then we place another micro in the artery. Okay, always the same. It's useful to see that. Injection of the onyx, going on. Okay. And It's at the end. Okay. So gamma knife. In our hospital, we do before gamma knife occlusion of the bleeding point, of the point of high risk of bleeding or fistulas. And this is a case. This is a man with an AVM who was planned to do gamma knife, but he had this varix here, this varix. Okay, so this is the one, the varix, angio, and this is an high flow fistula with the microcatheter inside the artery and the injection of glue. So we occluded the fistula, and 2 days after, for the gamma knife, this is the MRI, and the fistula was occluded, and also the it's not so easy, and also the varix there. The same guy came back after gamma knife, and this is why I put this case, because after gamma knife we do some residuals of the AVM. We occlude mainly transvenously, and this is the same guy of before, 5 years later, and this is the residual AVM with this vein. This is the MRI, and MRI vein, and this is the an angiogram from an arterial microcatheter. And, yes, thank you. I don't know who's moving the mouse, but can I use it? No. 3D angio from an injection of the microcatheter, and it's very useful to understand the vein and to understand what we are seeing, and also the white and black angio to understand where is the AVM and the connection with the other veins, because in this case we had a problem that the main vein of the AVM went to the cavernous sinus, but we understood that there was also connection with a cortical vein, and it's much more easier to navigate a cortical vein. So the microcatheter from the vein and from the artery, and this is an injection firstly by transarterially and then transvenously. And this is the cast of onyx, and there is some residual AVM, and we occluded it by injecting glue. And this is at the end of the procedure with no more residuals. And this is the cast of onyx and also the glue inside the arteries to occlude them. Okay. This is another case, a guy, we started treating him in 2010 for this AVM, and it's not what we do now, because in this case we started doing some embos, some embolization with glue. We reduced the AVM, and this was at the end of what we can do, injecting glue. And then we decided to do gamma knife, and this, after 5 years, this was the residual AVM, very small, with a single vein. And what we did was we put a transvenous microcatheter and also an arterial microcatheter there, here, okay. And then we injected just onyx transvenously. We had some reflux of onyx, and it's not very good. I know it. But the AVM is occluded, and the guy is very well now. Other case, cerebellar AVM, big cerebellar AVM, gamma knife with both branches, and this was the AVM, and this was the residual AVM at the end of after 5 years. Transarterial microcatheter, injection. This is the 3D. Again, the other branch, injection of onyx. And this is the results, including all the AVM. And this is 2 years later, the control. This is another guy with, who had cerebellar hematoma due to an AVM that was operated, but he also had another AVM on the other side, occipital AVM, so we decided to do gamma knife, again the hematoma, the AVM. So we did gamma knife, and after 5 years or 6 years, probably 6, see, yes, 6 years, the AVM seems to be occluded, but if we look closer, we see that there is a very small vein here. Here, sorry. Okay. So we decided to occlude it transvenously. This is an injection by arterial microcatheter with very good visualization of the venous and the residual AVM. And so we did transvenous catheterization and injection of onyx, and at the end of the procedure, we didn't see anymore the venous, the vein of the AVM. These are 3 veins, 1, 2, 3, normal, draining normal parenchyma. Okay, these are. So after gamma knife, we usually wait at least 5 or 6 years, and we think that a gamma knife simplify much better if there is a residual, and it occurs in about 20-30% of cases. The residual are more simplified than an AVM in the origin, but sometimes the residuals are too small and we cannot treat them. And I don't know if it could be a problem, because we have to follow these patients and to understand what we can do, and because they can bleed again, and we saw also patient bleeding after 6-7 years for very, very small residuals of the AVMs. Thank you.
Very nice. I have a question. We wait 2 to 3 years maximum after gamma knife, but we don't see any changes between 2 to 5, 6 years. Do you see that any things evolve in this period between 2 to 5 years?
We usually wait 5 years because between 3 years and 5 years, some AVMs continue to occlude. And we know that after 5 years, the rate of the occlusion of what is remaining is very, very low. So we consider the occlusion of the AVM, embolization of the AVM after gamma knife after 5 years, because we know that between 3 years and 5 years, they can occlude. We saw also some AVMs occluded between the 5th and the 6th year. So
Can you give us an idea of the rate? Is it 5%, 10%, or 1-2%?
No, I think it's between 3 years and 5 years.
Yes, after 3 years.
What we see after 3 years, I think that if the AVM is changed and is very small now, after 3 years, and we wait, at least 50% they occlude. If the AVM didn't change after 3 years, I think there is no chance to do nothing. But if you have to consider if the AVM changed after 2-3 years, you understand that probably after 2 years you can understand that if the AVM has some reaction to the gamma knife, to the radiosurgery, and if it's smaller after 2 years and going smaller, we prefer to wait. If the AVM after 2 years, it's always the same. We know that whatever the time we wait, it will never occlude. It's a switch off.
Okay. When you propose to do the treatment with gamma knife, you schedule for first the gamma knife and then to embolize if there is some residual, or you embolize first? Because I asking this because of the problem of the onyx becoming like a shield. There are some controversy saying that maybe the product of the onyx works as a shield, and the effect of radiosurgery will be less.
We never do onyx embolization to occlude the AVM before gamma knife. When we do embolization before gamma knife, we always do inject glue, and we do always a small, very small embolization to occlude a pseudoaneurysm or to occlude a fistula, not to occlude the AVM. What I show of the guy with the large AVM, it's what we don't do now anymore, because we understand that we have a high risk of complication during embolization with glue or whatever, and we know that the occlusion is always not complete, so we prefer to start with the gamma knife. Sometimes we do 2 or 3 sessions of gamma knife, and we do what René call 6D, 3D, 6D MPR, because we can select which part of the AVM treating in every session. So if the patient has feeders from the anterior cerebral artery and middle cerebral artery, we start with one section coming from one artery, and then after 6 months or 1 year, we do the other section of the other feeder, and then we wait after 5 years after the second session. Obviously, if the AVM didn't change in 2 years, we know that it's a problem, because it will never respond probably.
Okay, thank you very much. So we go to the last talk to Professor Serik Dusembi from Kazakhstan, and he will talk about microsurgical treatment of intracranial AVMs. Please.
Firstly, thank you so much for a great talk today. We have learned a lot from endovascular treatment. Talking the microsurgery, it is difficult in front of so many giant endovascular surgeons, but just Professor Chafford stated that endovascular treatment still have a low cure rate. So microsurgery is still a method of treatment for the, not this slide. No, another slide, can you? No, not this slide. Another one. No, I miss. Not this. Another one. So this is especially sure, brain arteriovenous malformations are rare, but they represent some of the most formidable and complex lesion encountered in neurovascular practice and can be cause of morbidity and mortality. Ruptured or unruptured brain AVMs are the focus of considerable debate regarding the optimal management, including endovascular treatment, gamma knife treatment, and in some instances, the decision for the treatment can be controversial. So treatment debate is special marked in grade 1 to AVM, treatment choice microsurgery or embolization, because a lot of endovascular, especially for a transvenous approach, can cure some AVMs. Also availability of microsurgery and embolization technique has the same center. Also the hybrid neurovascular surgeon or team may be also important. Most importantly, we cannot find the skillful neurosurgeons and the neuroradiologists at the same center simultaneously. So cerebrovascular malformations include arteriovenous malformation, cavernous malformation, and dural arteriovenous fistula, developmental venous anomalies, and capillary telangiectasia. So statistics, this is the symptoms, so I just skip this. Diagnosis, everybody knows this diagnosis, CT, CTA, MRI, plus MRI. Angiography is the golden standard, and also functional MRI is helpful for approach choosing and the protection of the neuronal pathways. So I am always very optimistic about endovascular treatment. So observation only is still grade 4 to AVMs, but microsurgery is for less than special grade 2 AVMs is very good results. Embolization special 1 or 2 cure. Embolization plus microsurgery for special grade 3 or 4. Cure embolization, maybe it is possible in future by transvenous technology, and the understanding of the architecture of the AVM is possible, maybe even more high-grade AVMs. So this is the endovascular treatment in multimodality management of brain arteriovenous malformation. Report of the Society of Neurointerventional Surgery standards. They think that this microsurgery is still the method of treatment, and endovascular treatment is evolving so fast, especially endovascular transvenous endovascular techniques. So they still need more improvement. So I want to show some cases. 21 years female, suffer from headache and epilepsy for 6 months. Diagnosed with AVM of left parietal lobe, special marked in grade 3. Treatment plan is partial embolization, AVM, and microsurgical removal of the AVM nidus. So I am a lot of controversy about this nidus, because Dr. Trafford said the nidus is almost the vein. But intraoperatively, we find some small T-angled vessels. It is different from arteries and veins. So it is called AVM nidus in neurosurgery. But in radiology, maybe it's different. You can see these pictures is, sorry. So this is an AVM. Left, right, this is a big AVM. So partial embolization of the deep feeders, because we are going mostly from the arterial side, because we are not experienced in transvenous embolization. So we should first embolize the deep feeders to the AVM. It facilitates the removal of the AVM on the second session. So this is the after embolization. So this is after the partial embolization of the AVM. We can clip these vessels, but only we can clip these vessels because it's the feeders to the AVM. So incoming vessels are arteries, of course. So we firstly stepwise clipping of the feeders first, but not we incise or coagulate these feeders, and only clip these feeders and then go around the AVM, and then we can remove this AVM completely. And after the removal of the AVM, we can remove the clips. So this is the post-operative picture, but you can see the onyx cast is still behind the AVM. So it looks like inside the AVM nidus, but the AVM, a lot of veins is outside the nidus. So you only remove the nidus, you can cure the AVM. So follow-up after cerebral angiography, after 3 months after surgery, you can see this AVM is totally removed. No residual AVM. So this is a post-operative MRI picture, follow-up MRI after 3 months follow-up. So second patient is 40 years old male, headache and contralateral hemiparesis for 8 months. AVM of the left front parietal area, also special Martin grade 3. Approach is also, this is a hybrid operation. We intraoperatively temporary clipping of the feeding arteries from M1 intraoperatively and the microsurgical removal of the nidus. Sometimes it is not accessible, the feeding arteries, deep feeding arteries is not accessible from the surface of the brain. But we can approach this from the MCA segment, Sylvian feature. We can approach this, and then you can see this branch is very lenticular straight arteries going up, but we tried to embolize this, but the catheter cannot move forward. So we choose to open the Sylvian feature first, and then put a clip on this perforator, and then we dissect the AVM. This AVM is a little bit difficult because you can see, sorry. So this is a post-operative CT. We remove only the nidus. You can see this is a very straightforward. You only remove this nidus, not the veins, not the arteries. So patient, 41 years old, male, headache and epilepsy for 4 months. AVM of the left frontal lobe. It is near to Broca, special Martin grade 3. Also, this patient goes for partial embolization. And this is also partial embolization. You can see some of the small perforators, lenticular striate arteries feeding this AVM. Also, we call this the AVM nidus because it is not vein, not arteries. So we remove only this nidus. So we remove this nidus, and the onyx cast left behind. So this deep, one of the deep feeder from this lenticular striate artery is clip it. So we control bleeding intraoperatively. So last patient with 47 years female, headache epilepsy for 10 months, AVM of the left frontal lobe, special Martin grade 2, partial embolization of the AVM and the removal of the AVM. This is also it is not an eloquent area. So for maybe sometimes we want to try to embolize this AVM completely through arterial approach, but we are not succeed, so we go for microsurgery. So this is after partial embolization. So this is the post-operative picture. So this is the post-operative follow-up after 3 months. AVM is completely obliterated. So this is can you play this video? So it is video for especially for young doctors, because AVM, if you find the AVM, it is so many vessels on the surface of the brain. So you cannot differentiate which vessel is the artery, which vessel is the vein, which one is the nidus. So you should first find this arteries first, dissect it, and then clip it. We are clipping the artery from the anterior cerebral artery, step by step. But you will not cut, you just clip it temporarily. So you can see a very big draining vein goes forward, and the circumferential dissection. So I will show some vessels like this. These vessels we call AVM nidus. These vessels, not the arteries, not the veins. These vessels you should protect through the Galeal dissection plane. You should dissect it away from the brain, and then you can remove the nidus. So you should meticulously hemostasis. Bleeding from the, when you remove the AVM, the bleeding from these tangled vessels is difficult to control. If you rupture these vessels here, it can difficult to control. If it is bleeding from the artery or maybe branching arteries, it's not difficult to control. So just remove. So you cannot see any tangles of vessels on the surface of the brain. Next slide, please. Thank you so much. If you have any questions.
Burning question?
It's not a burning question, but you know, I saw wonderful results that you showed, and some of them were embolized previously, like partial embolization followed by your surgery. I found that all of the embolized patients had very small part of the AVM which was embolized. So was that by choice that you decided, both of you sit together and decided that this is the part that you would like it embolized so that it helps you in surgery, or it was done in a random way? I mean, did you decide that I need this part of the AVM embolized previous to my surgery?
Yes, thank you. If the AVM, the last case, the AVM is small, we want to cure the AVM through the endovascular treatment, but we failed, so we transferred to the microsurgery. Usually, we want to reduce the blood flow during the surgery because AVM is complicated. AVM is complicated, especially for the parietal lobe. AVMs is hyper shunting and hyperdynamic. It is difficult to control if you have bleeding. If you have bleeding, you have complications. Maybe it's not goes for mortality, but you have complications. Your clean surgery, hypodynamic surgery inside the AVM nidus make a safety pathway for your good outcome. So you really choose, if this AVM is located on the frontal or temporal lobe, it is not non-eloquent area, we choose direct surgery or direct microsurgery, of course. Thank you so much.
Okay, thank you very much. I think it's time to close this session, so enjoy your lunch.
Precise in terms of action.
And we did a CTP program. And what we saw was
帕金森病的治疗啊，一直是一项复杂的系统工程。传统的治疗模式呢，局限于患者到医院和医生进行面对面的沟通。同时 ，DBS 术后的晨控也需要患者频繁地往返于家和医院之间，这给患者和患者家属造成了身体和精神上的负担，增加了医疗成本，降低了医疗效率。当科技、医疗、互联网加作用于帕金森的时候，我想我们能够看到更多人的欢笑。无线远程随访系统的诞生，为患者和医生的术前诊断与术后随访、晨控方面建立起了一个新的生态。景域无线远程随访系统由患者端穿越宝和医生端远程随访系统2个部分组成。穿越宝连接网络即可与医生连接，医生在远程随访中心与患者的穿越宝建立联系，通过穿越宝看到患者实时情况，通过远程网络对患者的参数进行调整，同时也可以看到患者的病历资料、用药情况，设置预约门诊时间，管理患者资料。那么这个系统到底是如何运行的呢？
喂，客服您好，我是患者马强，我想约葛医生再帮我调整一下参数。
马先生你好，我是葛医生。
葛医生你好，
你预约了我们的晨控门诊，我正用穿越宝和你连线。你感觉现在怎么样？
有点抖，感觉有点紧。
你按我说的做，我看看你的身体情况怎么样。马先生，我需要给你调整参数。
好的。
好的，我看到你的参数了。我现在给你调整参数，你感觉一下。你现在感觉怎么样？
轻松了，也不抖了。
那你先休息，感受下参数。我一会儿再拨过来看一下你的情况。现在你站起来走几步看看。很好，那这次就这样。你如果有不舒服的话，就告诉我。
葛医生，下周我们公司有一个旅行，您看能不能帮我调一下参数，让我这个身体状态呀更好一点？
好的，我已经给你预设好了。
谢谢。
你自己用患者晨控器看情况选择。无线远程随访系统的诞生，解决了患者在路途劳顿、家人时间、门诊排队等各方面的难题。它的出现产生了极大的便利。自此，未来应该有所不同。
This is CIRC, a cost-effective portable arm system that provides assistance in a variety of neurosurgical procedures. Its full integration with BrainLab navigation leverages established workflows, setups, and instrumentation. Lightweight and compact, CIRC easily attaches to the table side rail, saving valuable footprint in the OR. With its fully integrated computer unit, CIRC is ready for use in a matter of seconds. Grip sensors release computer-controlled brakes and enable movement in 7 degrees of freedom. The robotic module adds another 4 degrees of freedom and offers precise trajectory alignment. Sensors ensure correct mounting of the kinematic. CIRC is now ready to perform a cranial biopsy. After moving CIRC towards the trajectory, its robotic module precisely and automatically completes the approach. Sharp teeth anchor onto the bone for secure stabilization of the drill guide. All brakes are securely locked while navigating the biopsy needle safely to its target. CIRC unites intuitive human guidance with the precise execution of robotic alignment.
Музыка параллельно идет, да? Или там на каком экране? В эфире? Музыка может параллельно играть, ничего страшного. Да. Уникверс. Уник. Это верно. Смартовка. Аневризма. Аневризма. Правильно. Уник. Уник. Назад. Так, а в зале там кто-нибудь есть, интересно? А мы опять там полэкрана занимаем. Конечно.
Қозғалмаймыз апа. 1 секунд. Біле керек сияқты. Жоғары жағы жақсы.
Ну, уник. Угу. Вот так. Ну, там. Так, боковой нормально. Массаж. Слушайте. Так, в зале кто-нибудь появился? Три человека? Я... Он қолыңыз кімге атқарыңыз? Қолдың басын қимылдатып көріңіз. Қысыңыз қолын. Жақсы, аяқтың басын қимылдатып көріңіз. Жақсы. Мы подключились. Кто-нибудь есть в зале? Okay, I see the Professor Moret. Hello, Professor Moret. Just after the lunch, Он видел, да? Okay. This is a patient, 76 years old, lady. And on months ago, she experienced ischemic stroke in left hemisphere. And нету? Сейчас, подожди, не нажимай. Just a second. I need to adjust the monitor. Okay. I made the MR control and the MR. They asked to do consultation for this patient. And today we made a DSA. There is small stenosis in right ICA. Intracranial is okay. It's okay. And there is a basilar bifurcation aneurysm, very wide neck. But it's unruptured incidental finding, and I think there is no need to touch this aneurysm. We will follow for 6 months. It will need the remodeling and stent assistance or FD treatment. On AP, you can see there is a stenosis, and also we prepared this patient. It was expected some intracranial stenosis, but on this DSA, the stenotic segment is 2.6, and there is a post-stenotic dilatation. It's like aneurysm in communicating segment, and also MC bifurcation, small aneurysm, which we will also follow. It's on temporal branch, and we decided and 0.5 millimeter. We placed Pronder protection device from left brand. Now you can see after the stenting, the artery is okay, intracranially is okay, and also we made a CT control, and CT is also clear. Just a second. I will show you this. I think you have my screen. Yes, this is aneurysm. The left side, I think this is aneurysm. There is some calcification. I will do like this. Yes. Patient. And now we decide to stop. We will not touch the aneurysms, and we are waiting for the people will come from the lunch and the field auditorium. And Professor Jacques Moret is on Zoom waiting, and I want to say hello to Professor Moret. Yes, it's very sad we have no your in Almaty in person, but Professor Laurent Spel is in this operating room. We did already, this is the case number 3, and the last case would be on aneurysm also. Then we will join the conference together with Professor Spel. With your children and with your wife, and Merry Christmas. We will finish this case. Thank you.
Работа интервенционного нейрохирурга, конечно, очень интересная, но и довольно сложная. Это постоянное облучение, работа в рентгенооперационной, а также ночные операции, ненормированный график. Но самое сложное – это невозможность помочь пациенту вовремя. При остром ишемическом инсульте, когда закупорился сосуд головного мозга, лечение очень зависит от скорости проведения операции и реканализации сосуда. С помощью ангиографической системы ARTIS-ICONA мы, как врачи, имеем возможность сократить время пациента, проведенное внутри больницы, от поступления до самой операции от 30 до 60 минут. Это увеличивает шансы благоприятного исхода для пациента на 12%. Меня зовут Давид Саакян, я эндоваскулярный нейрохирург в медицинском центре Эребуни в городе Ереван. Немаловажное значение имеет именно скорость проведения самой операции. На ARTIS-ICONA есть возможность использования так называемой системы Case Flow. В зависимости от процедуры я могу заранее запрограммировать позицию стола, трубки, положение детектора и настройки экранов. Таким образом, просто нажатием одной кнопки я могу выбрать необходимый протокол, и аппарат автоматически, начиная от стола до рентген-трубок, встает в нужную мне проекцию. Одной из особенностей ангиографической системы является стол, который имеет возможность наклона в разных проекциях, что позволяет использовать его также при гибридных, открытых и эндоваскулярных процедурах. Ангиограф дает широкие возможности нейровизуализации. Это относится и к плоскодетекторному интраоперационному КТ, и к 3D и 4D ангиографии, и к перфузионным исследованиям головного мозга. Так называемая система оптик значительно снижает радиационную нагрузку для команды врачей и пациентов, но при этом сохраняет постоянное качество изображения. Мы очень сильно зависим от оборудования и очень сильно зависим от инструментов, которые мы используем. И я выбрал для себя ARTIS-ICONA, потому что он позволяет расширить мои возможности в оказании своевременной и качественной медицинской помощи моим пациентам.
Представляем рабочий процесс для диагностики и лечения ишемического инсульта в рентген-операционной на одном аппарате ARTIS-ICONA Biplane. ARTIS-ICONA Biplane поддерживает рабочий процесс механической тромбоэктомии с 3 новыми этапами рабочего процесса. Он сводит к минимуму переходы между модальностями и может сократить время от двери до области паха за 34 минуты. Сначала необходимо определить, нет ли кровотечения. Чтобы повысить качество визуализации, в ARTIS-ICONA используются 2 ротационные наклонные траектории для 3D-сканирования, помогающие преодолеть появление артефактов от костных структур, окружающих базальную часть головного мозга. Второй этап также важен, как и первый. Теперь ангиографическая система оснащена режимом динамической визуализации коллатеральных сосудов, что позволяет сканировать 10 объемов примерно за 60 секунд. Третий этап соответствует действующим рекомендациям по тромбоэктомии о проведении перфузионной визуализации для выбора лечения в течение 6-24 часов после появления симптомов. Программный режим Dyna-CT Multiphase предоставляет КТ-подобные карты перфузии, позволяющие определить области головного мозга с нарушением кровотока и сниженным объемом крови, а также с задержкой поступления контрастного вещества непосредственно в ангиографическом кабинете, что сокращает время до начала лечения. Не покидая рентгеноперационную, мы можем выполнять механическую тромбоэктомию и документировать ее результаты, используя гибкие возможности биплановой системы. В частности, после тромбоэктомии можно выполнить цифровую субтракционную ангиографию. Клиника Базельского университета добилась значительной экономии времени благодаря новой системе, о чем свидетельствует доктор Мариус Психагиус.
Теперь мы проводим все диагностические исследования в рентгенооперационной. Для пациентов с подозрением на окклюзию крупных сосудов и оценкой NIHS больше 9 это может сэкономить от 30 до 60 минут времени внутри больницы.
Imagine that when you switch from one plane, then two planes, and then 3D space view, you have a clear understanding of the anatomy, not only the anatomy, but all the relationship with the environment. So honestly, 3D was just, being blind and coming to light. And then came all the process of the 3D picture that we have today. This reconstruction, the MPR, the slicing, the overlapping, with the CT, with the MR. You can even do it during the procedure.
3D is absolutely fundamental for me, meaning that if I arrive in an angio suite in which you don't have the 3D, I'm paralyzed. And I always say to the young doctors, if you don't see, you don't understand. And if you don't understand, you cannot treat. And 3D is the key tool.
I will trust and base my treatment on all the 3D measurements because we live in a 3D world, it's 3D anatomy. So I need this perspective and this understanding that is brought by 3D. Then I can adapt myself. I can work in 2D, but I will work in 2D based on the 3D knowledge.
No, I cannot imagine working without 3D. Today it's mandatory to have 3D array to benefit from the maximum information.
I would consider this as an essential step. I think it's extremely hard for us now to consider treatment without understanding the 3D images.
You always have the fear of a trap that you have not seen, a side branch, a protrusion of the neck which you don't control, a protrusion of the device that you have not understood.
It can be very helpful during the navigation. For example, in an AVM, why you cannot catheterize a small branch? It's always the same rule. Come back to the 3D, change the position, understand better to do better.
Now that the 3D is fully doable and also manageable inside the angio suite with this pad, I think it's also a big push for people to use 3D in very concrete fashion into the angio suite. When a physician is understanding better, you are always safer for the patient.
Каждые 2 секунды у кого-то в мире происходит инсульт, и начинается забег на опережение. Каждая минута без лечения – это гибель почти 2 миллионов нейронов. Упущенное время – это гибель мозга, поэтому в протоколе лечения инсульта мы должны учитывать каждую секунду. 2015 год стал поворотным. Исследование MR-Clean доказало эффективность механической тромбоэктомии при лечении ишемического инсульта. Теперь большее число пациентов с инсультом могут получать эффективное лечение. В 2018 году дополнительные исследования подтвердили, что для отдельных пациентов тромбоэктомия может быть эффективной в период до 24 часов после инсульта. Это расширяет круг пациентов, которым показана тромбоэктомия. Каким образом медицинские учреждения смогут соответствовать этому запросу? Мы уверены, что концепция поступления пациента напрямую в рентгеноперационную Direct to Angio Suite способна ускорить лечение пациентов с подозрением на инсульт в период терапевтического окна в течение первых 6 часов. Для пациентов с высокой вероятностью окклюзии крупных сосудов. Мы работаем с ведущими инсультными центрами по улучшению качества изображений и оптимизации рабочих процессов с целью сокращения времени до начала реперфузии после ишемического инсульта. В целом, эти факторы значительно повышают потенциал инсультных центров осуществлять лечение быстрее и большему числу пациентов, тем самым улучшая клинические результаты. Обычно, когда пациент с инсультом попадает в отделение неотложной помощи, он проходит КТ или МРТ-обследование. Если поставлен диагноз ишемического инсульта, дальнейшее лечение проводится в интервенционном отделении в рентгеноперационной. Подход Direct to Angio Suite означает доставку пациента напрямую в рентгеноперационную, минуя КТ или МРТ-обследование. Данные литературы показывают, что этот подход в маршрутизации пациента позволяет значительно сократить время до начала лечения и улучшает его результаты. Для оценки влияния подхода Direct to Angio Suite на результаты лечения пациентов с инсультом компания Philips начала крупномасштабное рандомизированное клиническое исследование под названием WeTrust. Это не имеющее аналогов многоцентровое рандомизированное исследование. Исследование WeTrust позволит получить наиболее полную на сегодняшний момент оценку влияния технологий Philips и модернизации рабочего процесса на время до начала лечения и на неврологические исходы лечения пациентов. В итоге все сведется к оценке одного пациента, одного решения в единицу времени. Мы уверены в перспективах подхода Direct to Angio Suite. Это дает нам неоценимый ресурс – выигранное время для каждого больного, остро нуждающегося в механической тромбоэктомии. Это то, что мы называем «здоровье без границ».
The Excelsior 1018 microcatheter is designed to provide a stable platform for coil deployment. The Excelsior 1018 microcatheter has 0.019-inch ID and compatible with all Target 360 XXL detachable coils. The Target XXL detachable coils have a 0.017-inch primary coil diameter and long lengths, which are designed to bring an effective and efficient coil embolization. Target XXL coils are soft to enable physicians to achieve tight packing and provide flexibility in sizing. All of Target family coils are developed by the Target platform, which is known to be a smooth and stable delivery wire technology. Through the distal 2D loop and 360 shape of Target, physicians can anchor and frame the coils to the desired location.
To achieve a CSF tight adaptation, an overlap of about 1 centimeter must be included in the cut size. After partial hydration of the biomatrix, the piece of tissue dura is placed on. The hydrated tissue dura is fitted. Fixation of the briefly hydrated biomatrix along the sinus edge with 3 The tissue dura is carefully lodged under the dural edges without forming any folds. The subbase is filled. Insertion of the bone cap. At the end of the procedure, the bone cap is attached with bioplates. First post-operative day show the radical resecumulation in the
precise in terms of
and we did a CT view, and what we saw was
think in the room the people are coming from the lunch. It was a little bit delay in the morning session, and as usual, Kazakh cuisine is very tasty.
Sorry, I will wake them up.
Yes. I think after your presentation, they will wake up a little bit and
for sure.
Yes.
Believe me.
Thank you.
Believe me.
And also the Vladimir Kalusek from Zagreb is also waiting.
Okay.
They connect. Let's wait nearly 5 minutes and
yeah, okay,
we can start.
It's okay. Not worry. Fine. Yeah, -4. Yeah, but it's very sunny.
Yeah, sunny.
It's very sunny. So it's a nice weather. And you know the countryside around Paris. I am only 11 kilometers from Paris.
Yes.
And look at the trees on the back of me.
Oh, it's in summer now. It's white.
Yeah, this is a picture of summertime, but it's the same today. There is no snow. It's very sunny, and now it's a picture from the summertime.
Oh, it's nice.
Okay. And what's the temperature? Definitely. But the big advantage is you have gas and you have petrol, so it's easier.
Yes. Vlado is also connected by sound. Vladimir, może? Yes. Now we are waiting for Professor Moret's presentation, and immediately after him, you will be online. Okay. Tegus. It's a quite nice system. Anybody in the conference room? My friends? Hello, colleagues. Anybody in the conference room?
So yes, so we are back, people coming back in the room, so I think it's a good time to start.
Heidelberg. Professor Moret?
Yes?
Yes, could you see the...
Now I see the room. Now I see the room.
It's a conference room. Okay, now I can see the Gavrilovich Vlad, Andrei Petrov, Marcus, Professor Chapeau, Anil, Jose, Chiki, Nader, and also Luisa Biskoitov also in the room, in the conference room. Okay. Can we start?
Yes, I think we can start.
Actually invited Professor Moret to give his talk on brain AVM. I know many people in the world learned how to deal with brain AVMs, and he have huge experience, and I know that the brain AVM, it's not all the time. It's just a fun, but sometimes it's very painful treatment, and I think Professor Moret can tell us his own experience and some tips and tricks how to live together with this.
Professor Moret, do you hear us?
I hear you.
So now we hear you, so I think you can start, please.
Okay, you hear me clearly?
Yes.
Do you hear me clearly?
Yes, we hear you.
Okay, so I go. Good afternoon for you. I think it's a good afternoon, everybody. Don't worry, I will speak about brain AVM, but I will give you a very disturbing talk. So please. Of interest, which is not too much interesting. And this is the topic I'm with team. This is my own way of thinking and my own way of speaking. Acknowledge. Acknowledge is a contraction of ignorance and knowledge. Basically, I think it's a social network disease, and this is definitely a big concern about what we are facing today. Acknowledge is also very frequently associated with show-offing. So what is show-offing? Show-offing is the worst description of show-off. It's much more pejorative because acknowledge and show-offing, you are basically right in the middle of what's happening today. Specifically the topic to speak about acknowledge, because there is so many things that we don't know about brain AVM. And basically, if the question is endovascular treatment close to curing all AVM? Definitely, if you ask me this question, I would say, of course. But why do I say that? Maybe because we have been looking at all what we have been doing, and maybe we have an opinion. We'll see. Look at that. This is an AVM that was treated in 1990. And this is a control angiogram after the treatment. There is a little bit remnant of the malformation there. And 1 year later, there is still a little bit of the malformation visible with, again, the vein, which is visible at the same time. We didn't know exactly what to do. We didn't want to send the patient to radiation treatment for some reason that I don't know. But basically, we did, oh, why don't you come back a year later? So now it's in 2000, and the patient came back in 2000. And as you can see, in 2000, there is still a little bit of the AVM, which is visible. And the vein draining very slowly, the remnant of the malformation. So we said the patient will come back later. Okay, so let's have a look at this case. The patient came with a bleed, and we noticed that time. It was also a long time ago. And now this is what's left. There is a tiny little vein that is still visible there, as you can see here. So the patient came back 7 months later, and 7 months later, there is a blurring effect, some kind of a cloud of little thing that looks bizarre, but we don't know exactly what it is. But basically, the vein is still visible there. Okay, so we asked the patient to come back 14 months later, and 14 months later, without doing anything, what do we see? Nothing special, nothing special, nothing special. Decided to not come anymore. But he came back 5 years later with a big bleed, and as you can unless it's wrong, I don't know, the venous occlusion has led to the complete occlusion of the malformation. So this is something that we learn probably. Whatever the way you occlude the vein from the artery to the nidus through the vein and then you reflux to the nidus, or from the vein, then you start occluding the vein, then you reflux to the nidus and you get an occlusion of the malformation. This is the option that is definitely depending on the local situation. So for example, this patient has a deep located AVM. We did a selective injection of the thalamoperforator. But fine. Okay, so we are very happy with that. This is a wonderful result. Very successful. It was before, after the first session of treatment. And this is now after the second session. You can see the cast, you can see that the vein has been occluded, and you can see that the malformation is gone compared to what it was before. So definitely we are 100% convinced that this is the way to go. So yes, endovascular treatment is close to curing all AVM. Supposing we know which AVM should be treated, do we know that? We can probably agree on the fact that, this can be an assumption or an affirmation. Is it a desire for who knows about that? And the most important, and with the patient, whatever, it's pretty much difficult. So we can probably agree on the fact that this AVM is definitely not a good option for endovascular treatment. I'm sure that most of the people will agree on that. But we don't have the evidence for many things we think we know. And this is a major concern. We don't have the evidence for many things we know. And as you know, no ignorance is useful. So it's a big trap. We don't know exactly where we are. So probably we have an opinion which is strongly, something that belongs to you, your knowledge, your experience. And an opinion is something which is intermediate between knowledge and ignorance. So this is the definition of. So now this is all the words, the sentences, the proverbs, the dogma that you will hear the whole day during all of the presentation. All those sentences will come more or less and frequently or not that frequently, depending on who is speaking. So is it something that is true or is it something that is wrong? Is it in between? Is it your way of thinking? I don't know. Many things will be pushed, will be emphasized, but basically the past is the same for all. The means to react, the goal varies with the traveler. This is something that we have to keep in mind. So keep on going. This is again what you will listen frequently. All those China is a way of doing porcelain at the same time. Okay, so what's the difference between an AVM and a romance? Anybody can get into one, but how to get out? This is the trick. And this is exactly what we are facing when we deal with AVM. It's easy to get in, but it's not easy to get out of it. So it's like a romance. Let's be a little bit romantic. He who confesses his ignorance shows it once. He who tries to hide it shows it many times. Keep that in mind. He who wants to do something, find a way. He who wants to do nothing, find an excuse. So this is all this kind of way of thinking and understanding of what we are doing. You can put this kind of description and it fits with what we are doing exactly. The why. Why post-embo hemorrhage and edema? Why post-embo and nothing? Do the open skull neurosurgeon have the same concern? These are all the questions that we have to find an answer, and for the time being, we have opinion, but we have no scientific answer. Who cares about the true supply of the brain? Everybody knows the pile arteries, which are called the intrinsic innervation. Everybody knows about the intrinsic parenchymal arteries. This is nice to know it. Everybody knows that for a long time in the textbook. And we can even see those perivascular space in the Schwann, the Vino board, or the SWI sequence in the MR. But we can also see that. But the new understanding of what's really happening in the nervous conduction between the neuropil, which is the area where the dendrite and the axon collateral ends, and the neuroglia, which is interstitial tissue, understanding that there is a new concept, which is a neuroglial transmission. To be clear and to try to summarize something, it's exactly the same difference between the RG45 wire, the same cable that we use for internet, compared to the Wi-Fi. The neuroglia is the Wi-Fi, the RG45 wire is the neuropil. This is the brand new concept, which is only existing since 2015. It has been published in this journal, the Physiological Review, about be organized with a stable environment of the brain. So the concept of the volume transmission as opposed to the wire transmission is something which is extremely important but we have no understanding of what's happening with that. So we are going towards the light, but here we are, far away from the real light and the real understanding. And now let me show you why we know very little. Let's have a look at weird and strange phenomenon. Look at this AVM. Who knows about this AVM? Who wants to do this AVM? Who wants to jump on it? Well, the patient had a very, very disturbing cerebellar syndrome. So we tried to do something and we glued most of the direction. Okay, so we reduce the shunt. Looking at the picture, it's not that bad. And then we asked the patient to come back later. 15 months later, he came back, nothing, gone. Definitely gone. So there is something that has happened, and something that has happened is probably related to the venous occlusion. Probably it does confirm what we start understanding. Why does it happen? Why the patient is asymptomatic? Why the patient is asymptomatic despite diffuse venous thrombosis? Let's have a look at this patient who was treated now 12 years ago. He was treated by the venous occlusion from the venous side, and we got the complete occlusion of the malformation from this, which is not surprising. We know that everything. Okay? So this is the for the patient or not? Do we have to do something on that? Do we move to removal surgically of this little remnant of something that we don't know? No, we didn't do anything, and the patient is fine for 11 years. Let's look at this patient. He came with a bleed, and we had a lot of trouble to find the malformation. So we found a little tiny little malformation there. Most of the time we see the veins, but we don't see the malformation. It's a tiny little one. So what did we do for that? We did vaso-CT, we understood where is the malformation. We navigated from the venous side. We got access to the nidus. Here is the nidus. We occluded the nidus. Very good. Everybody is happy. And this is a post-op. The malformation is gone. The vein has disappeared. Everybody is fine. So the next patient comes with rather the same malformation. Tiny little, where is the malformation? Here it is, we see the veins. And where is the real nidus of the malformation? Here it is. So we navigated from the venous side, we got access to the tiny little AVM, we occluded the tiny little AVM and the foot of the vein, everything is fine. And this is exactly what we do at a complete occlusion of the malformation. But the patient bled. Why? What's the difference between this case and the other one? There is probably a difference, maybe a difference of doing, maybe a difference of understanding, but we don't know why. Let's have a look at this case. This is an insular left-sided malformation with a big venous drainage. We did an occlusion of the nidus from the arteries, and we navigated inside the arteries there. And in order to get access to all those tiny little perforators, we occluded the vessel, and then we got a reflux in the nidus. And let's have a look at this. This is the beginning of the injection. The artery is occluded. Then it starts refluxing in the nidus progressively. And finally, we got a complete occlusion of the nidus and a complete occlusion of the veins, understanding that the venous occlusion has really helped us to get a complete occlusion of the nidus. And the patient is fine. 40 minutes of injection, rather occlusion from the very beginning, then we got reflux in the nidus, and then we have this wonderful result. Everybody is very happy with that. Look at this. And the patient is fine. Exactly the same AVM. We did exactly the same thing. And what has happened? This is where we were for occluding the nidus. And this is the progression of the liquid material that we have been injecting. Look at that. It gets in the nidus. Progressively, we enter the vein. Progressively, we occlude the vein. And then suddenly, the blood pressure raised for point. We did a control angiogram, and we saw that the patient is bleeding. What is the difference between this case and the previous one? Nobody knows. We bet that it will be okay, but nobody knows that it will be okay. Because he's lucky, it's because of us, because he's better in treatment, and we don't know why he bled. This is a big concern. Let's have a look at this patient, dislocated AVM from the vein, occlusion of the nidus, complete occlusion of the AVM.
Recording in progress.
Deep occlusion of the venous system, occlusion of the nidus, and the patient is cured, but the patient is fine. What's the difference between this case and the other one? What do we understand better in this case compared to the other one? Nobody knows. We bet, we think that this is the way to do, but we don't know finally. Let's have a look at this one, dislocated AVM, first occlusion of part of the nidus, and then we move to the venous side to occlude completely this malformation. We did an occlusion of the venous side. We have been using the so-called pressure cooker technique, coiling everything and occluding the venous system. And we got this occlusion of the nidus and the venous system, and the patient is fine. Why? Look at that. Wonderful. But the patient is fine for us. The patient is fine 12 hours later. This is a CT that was performed because we were a little bit, anxious to know what's going to happen. But the patient is fine 12 hours later. And 16 hours later, he bleeds like crazy. And he bleeds like crazy, so he got a neurosurgical flap. Massive bleed, another bleed, bilateral flap. And finally, MRS3 6 months later. Why? I don't understand why. Is there something wrong? Definitely, we don't understand this. Let's have a look at this patient, ugly looking, dislocated AVM. In May 2015, we started first to occlude part of the nidus. This is the reduction of the size of the nidus without touching the venous side at the first session. And then the patient came back and we started doing compartmental occlusion using the venous access. This is one of these venous access, second session of treatment. And this is finally what we got after this second session of treatment. This is after, and this is before. Significant reduction. So we told the patient come back for the third session. And this is the third session. Look at that. Before, after, massive reduction of the nidus. We have very good access from the deep venous system. And this is what we did. We went from the deep venous system, we did occlude, we did inject the liquid embolic material, and we did get this wonderful result. And the patient is fine, but fine. And some hours later, he bleeds like crazy. Why? I don't know. You don't know. And nobody knows. This is the big question. And finally, he died 10 days later. Let's have a look at this case, cerebellar AVM. Patient, all those patients bled, because otherwise we don't touch it. So we did a reduction of the nidus, first session of treatment. Look at that. Look at that. There is zero modification of anything except the shrinkage of the nidus itself. Do you agree on that? Of course you agree. The vein is intact, nothing inside, just in the nidus. The patient is perfect. This is before and this is after. You can even difficultly, you can see that there is some shrinkage of the nidus, but nothing has really changed after this first session of treatment. 12 hours later, massive bleed. And then we had to do a flap, surgically speaking, to decompress the posterior fossa. Why? 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 Nobody knows. Let's have a look at this patient. This is a spontaneous bleed of a cerebellar AVM. She is 65 years old, and 4 months later, the patient is fine. And finally, we decided to do a treatment. This is the angiogram. The treatment went very nicely. very simply, good occlusion of the nidus, good occlusion of the venous side. Everything went absolutely perfectly with a perfect result. Everybody is very happy. Look at that compared to what it was before. And this is pre and this is post. Wonderful. And this is 6 hours later, big bleed. And now the patient is glial 2 or 3. Why? Why? I don't know. You don't know. And nobody knows. It's not only brain AVM, it's also vein of Galen malformation. This kid had multiple occlusion with coils from the nourishing pedicles, and when he came to us, he has developed this so-called neo-AVM that has developed after the occlusion of the main arterial supply of this vein of Galen malformation. So what did we do? We went through what was left. We did occlude most of the malformation, and at the very end there was a little bit of the vein which was still visible. We went from the venous side, we did occlude everything, and this is what's going. The patient is cured, anatomically speaking, but more, the patient is fine, clinically speaking. Look at that, this is what it is before, and this is what it was after. Patient is absolutely fine. So this is another patient. We did exactly the same thing. We went through the venous side. We occluded everything. We did a perfect occlusion. Everything is perfect. And everybody is happy. And we are all happy. And the result is wonderful. So we did another one. Exactly the same thing. We occluded the whole thing. And everybody is happy, except the patient is bleeding like crazy. Why? What's the difference between this one and that one? Don't claim that this is because the vein of Markovsky has been occluded. There is no relationship between the vein of Markovsky and the internal venous system. So there is no true explanation of why this patient bled and why the other one didn't bleed. We are far away from having the line. All what we know is the cure rate is increasing for the last 30 years. But the Instagrammers speaking about AVM, claiming that we all know that what to do for an AVM, is definitely increasing at the same time, but the understanding is very, very slowly increasing. So basically, probably yes to the question, is endovascular treatment going to close all AVM? Yes, if we accept our poor understanding, but more if the patient accepts our poor understanding. Thank you. Hello?
So thank you very much for this interesting talk. Who wants to comment? René?
Somewhere from the universe. Hello, Jacques. Great presentation. But you showed many procedures, many very nice procedures. Do you hear me?
I hear you. I am waiting for true scientific answer. That's all.
I mean, that you know the answer better than me because you're longer in the field than me. Which studies have been done? No. So there is no scientific answer, but I think that we should be cautious. You said it too many times in your presentation that it was a perfect result and that we're happy. No, I don't agree with this. I mean, there are a certain number of patients where you wonder, is it really occluded or not? I don't pretend not to have problems because I've got a lot of complications and that I show my complication, I think, to find a solution. And I think it's important to look what we do wrong. I'm surprised that I did not see any image of MPR. Okay, you cannot hear?
I can hear now.
Very slowly. Okay, so I will make it very short as a comment. I'm not sure that when we think that our result is perfect, it's so perfect. Obviously, we're missing things, and we need to learn on how to see better what we do. And probably I learned in my practice in the last 5 years, I changed that I never stop embolizing an AVM before I've selectively accessed to each of the feeder to see if it still goes. Making an all-over angiographic view is of zero interest. It just gives the impression that it's cured, but it's not. But of course, we must remain very modest in what we say.
That's good. I love that. We have to be modest.
Yes, Professor Murad, thank you. Thank you for participating and sharing your It would be for you very long day, and we are in the afternoon, 5-hour difference. Yes, thank you, Professor.
Okay, okay. Have a nice meeting. Have a nice meeting.
Thank you. And Professor Chapeau, Marcus, if you allow us, Zagreb group are waiting. They already coiled some part of the fistula. If it's possible, we will connect to Zagreb.
Please.
Thank you, Paris.
Thank you. I'm closing.
Thank you.
Thank you.
Okay, now we will switch for Zagreb. No, not just a second. Could you see the Vlado?
Yes, we see the
Zagreb.
room.
Zagreb. Could you see the Siemens angio suite?
Yes, we see
Vlado.
from the room.
Vlado, now we are in Zagreb. You see the hats? It's a Croatia team. Vlado, can you hear me? Vlado, can you hear me? Vlado. Vlado. Vlado, can you hear me? Hi. Zagreb. Vlado, can you hear me? It's a nice system. It's a Tegus system, and
hello, NEUROADDICTS again.
Hello.
In 1998, severe head trauma with in car accident. She got hurt, so and then the workup at that time didn't show any pathological vascular malformations, and throughout the years she got severe vertigo with episodes of losing consciousness, and then in fall of this year she got worked up by MRI, which showed this lesion, which we characterized as a vertebral traumatic fistula with the shunt point was to catheterize the fistula, the venous pouch, and then to place a balloon across the neck so we can coil the inflow from venous side towards the arterial side, and that we did. So where are the images? Here is the balloon. Balloon is Eclipse L 6x20, and this is the echelon 10 inside the fistula pouch, and a balloon across the neck, and then we started to place so and now we're gonna see placement of the first coil inside the venous pouch. The first coil was 8x30 hydro frame. Then we can move on. So these are control runs, and then we place some more coils into the venous part of the fistula, and then we move back to the proximal part. You see the coiling of the orifice of the fistula. We used combination of the hydrogel and Optima coils. So we see here that there is some tension inside the system, which we released by pulling the micro more proximally. So this is the coiling. And then we can move, Brian. So towards the end of this part of the procedure, on the control angiogram, we see significant reduction of the flow in. Are going to place a flow diverter stent across the neck, across the entry of the fistula, so to be sure that fistula does not fill anymore, because there is no demand, shouldn't be no demand to the fistula. Now we see anterior spinal artery, which arises from the basilar artery towards proximally. Okay, so now we are going to remove the balloon and to place a Phenom 27 microcatheter, and we are going to place 5.1 inch flow diverter, 4.5x20.
Мы можем их
поставить на второй экран и продолжать презентацию. Это возможно? Да, без звука. Marcus, anybody in the room?
Yes, yes. Minchil.
Yes, Professor Chapeau. I think we can put Vlad.
Yes, we're looking at Vlad now. He's handling a balloon inside the...
Now it's clear, and Vlado is planning to place the FD, and this is straightforward procedure.
Okay, now he's okay.
Or we will continue the procedure.
Why not adding some liquid embolic in the coils and avoid the antiplatelet?
Yes, I cannot hear you. I think you asked why not a couple of liquid embolic inside the coils, yes?
Absolutely.
There is no voice, is not voice from the conference room.
We'll text you.
Не слышно, зал. Звук из зала можно будет?
Another option here would be first to stop, and if it's thrombosing, you don't need to do anything more now. You can control the patient the next 2 days, and probably you avoid liquid embolic and flow diverter. I see Luisa who is moving the head from up to down.
Yes, I agree. I agree, but the initial plan of the Vlado and the team, and I think they are doing great job, and we can continue to watch on the second screen without voice. If you agree, we can continue with the presentation on one screen.
Yes. Sound is coming back.
Yes, okay. And also, Professor Chapeau, Silk Road FD stent in ICA supraclinoid segment. If it's okay, we can switch to operating room for a couple of minutes and then continue with presentation. Is it possible?
Okay, who has the next presentation to do here? Who has a program? Charbel, is Charbel online?
Стенд внутри?
Нет.
Do we know if Professor Mounayer from Limoges is online for the next presentation?
Minjil, this is Anil here. So you want us to go ahead with the next speaker, or would you prefer us to watch Zagreb.
Yes, we see the deployment now of, I guess, the pipeline.
And then we will switch for the presentations.
And then we switch to Charbonnier.
Okay?
Yes.
Understand. Stop.
Okay, Guglielmo, we're glad to listen to you after we saw Vlado placing a pipeline in the vertebral artery.
Do we wait Vlado is finishing or? Okay.
Mitchell suggests that we go ahead.
Okay. We go. Okay. I think I don't. Okay, connection is so bad. I start. Okay. What we do usually, I'm talking about what we do usually when we have difficult aneurysm, and which is my background. Some aneurysms have very high procedural risk, both endovascularly and surgically, because we have some problem to treat some aneurysm, and surgeons have some problems treating the other aneurysm, and sometimes aneurysm can present both problems. Combining the two approaches reduces the global risk in most of these cases. One of the most common strategies is doing a bypass in the arteries coming from the aneurysm, and without touching the aneurysm, and occluding the parent artery and the aneurysm endovascularly. It's something not new, it's something very, very old in our job. This is a typical case, a big cavernous aneurysm with no compensation from the other side. And here the surgeon did a bypass, a venous bypass, working perfectly. And after a balloon, a small balloon was placed there in the cavernous carotid. And then the artery was completely occluded with another gold ball balloon. balloons are perfect to occlude the arteries. This is another case. The first treatment, the endovascular treatment was done in another hospital, positioning some coils, but the patient had a very tight stenosis in the carotid in front of the aneurysm, so no endovascular treatment was possible, and he had no compensation from the other side or from the vertebral vascular system, and another venous bypass was done, and this is the results with complete, and then we occluded the artery. So what we usually do is occluding the artery immediately after the bypass, at the end of the bypass the same day, so probably most of the times during the night. Another patient with a big aneurysm, a giant aneurysm of the middle cerebral artery, partially thrombosed, and here the aneurysm has two branches coming from immediately from the neck, and the planning was to do a double bypass, two bypasses with both the branches of the superior temporal artery, and clipping proximally the superior branch of the MCA. This is in the angio immediately after the surgery, and it's interesting because here we can see something washing the contrast in the bypass. This is a radial artery bypass. No, sorry, it was a superficial temporal artery, sorry. And this is the angio from the internal carotid artery. And the other thing interesting is that we see this branch, this vessel coming from the MCA, and it was the bypass refilling from the ICA to the ECA. After the occlusion of the vessel and the aneurysm, we can see both the bypasses working perfectly. And this is the results, and the patient had a very small ischemia of the caudate nucleus. It's something that can happen when we occlude the MCA in the bifurcation, because at the bifurcation there origins frequently some perforators. But normally the patient will recover very well. This is a huge aneurysm, very bad, with the posterior communicating artery coming from the aneurysm, and both anterior cerebral artery and middle cerebral artery coming from the aneurysm. And it's very difficult to understand what to do, and what to do probably is a bypass. I'm here to show a bypass. So this is without compression on the left side, and on the right side with compression, so there is no compensation occluding the artery, also from the left carotid artery. And this is the bypass. This is a radial artery. This is, and this is from the internal carotid artery, the control. So what it seems that we have also, or we have still the posterior communicating artery coming from the aneurysm, but the surgeon did also a bypass with the superficial temporal artery on the PCA. So when we occluded the carotid, we can see the superficial temporal artery going to the PCA and the radial artery going to the MCA. So, and the anterior cerebral artery came from the radial bypass. From here to, we can see the carotid bifurcation above the coils. And this is the MRI with a very small ischemia, probably coming from the choroidal artery. Another case, this case was previously treated in another hospital and they placed a stent, 2 stents, and this patient had a big aneurysm in the carotid, terminal carotid, and the aneurysm was growing and partially thrombosing. And this is the CTA with progressive thrombosis of the aneurysm. And when the patient arrived in our hospital, it was the last situation, this one. And this is what happens. This is our angio before the surgery. We can see the two stents, one inside the other, and the first one is an enterprise stent who was twisted, and the problem was there, here in the tight stenosis of the enterprise stent. So the surgeon did, in this patient, the surgeon did as first treatment a radial artery bypass, but the patient had 2 weeks before COVID, and the radial bypass didn't work immediately. So the patient waited some weeks more, and then came back to do a venous bypass. And everything is good. And what we did was to occlude the artery. Immediately we did a test with a balloon here. And everything was working perfectly. And when we occluded the artery with coils and we occluded also the aneurysm, we had a surprise. Because everything was occluded, we didn't see the anterior cerebral artery, and there is some collateral circulation from the MCA, and from the left side, from the right side, there is some collateral circulation, but not so good. We didn't do nothing, and this is the CTP with no perfusion defects, and we just kept the blood pressure, high blood pressure in this patient, and 3 days later everything was open. So probably what I think is that there was a progression of the clot that occluded momentarily the A1 segment, and 3 days later it's perfect, and the patient was perfect. And this is the carotid bifurcation, intracranial carotid bifurcation. We can see here very well in the left. Yeah. Okay, the patient has no problem, but sometimes we can have other problems. This is a two huge aneurysms, one intracavernous and one carotid ophthalmic. The patient had already been treated for another aneurysm on the left side, and venous bypass. This is a venous bypass, and everything was perfect. We occluded the artery, and at the end everything was perfect this time. But the day after, she awake with ischemic symptoms, and this is what happens. The bypass was occluded. We don't know why. And we started immediately Cranglor, and it didn't work. The bypass was still closed, so the neurosurgeon wanted to see what happened, and he opened the bypass, and they did lots of things, but probably unuseful. And the bypass was still occluded. The patient came in our angio suite. And this is the point of the bypass. And what we did was passing inside the bypass. And then after a run, we did tirofiban in the bypass from the microcatheter, through the microcatheter. And then we put, this is a stent retriever just to open the artery, not to do a thrombectomy. because we were afraid to break the surgical points doing the thrombectomy, and the bypass was full of clots, and I don't know if you can see here. So what we decided was to put some stents where the clots were more prominent. First stent, second stent, and another stent at the origin of the bypass, because of the proximal origin of the bypass, because there was a tight stenosis there. And this is the result. And we kept the patient under Kangaroos for some days, and she recovered very well. She had this ischemia. I think this ischemia are due to surgical movements of squeezing the clot inside the bypass when he revised it, when the surgeon revised it, but I don't know. The patient now is MRS1, and this is the CTA 1 week later. Oh, another patient, this is an old case because I want to show this one. It's strange. In 2007, she had received a bypass for this aneurysm, and everything went well. And this is a two years later control. But 12 years later, the patient came back with TAAs, and she had this tight stenosis in the bypass just before the entering in the intracranial. Oh. Do you want to see there? I didn't see. Okay, I go on. And what I did was to put a coronary balloon, a coronary stent with the balloon. And the stenosis was very, very straight, and also inflating the balloon several times. I didn't reach any good result. It's more interesting there.
No, definitely no, because usually bypass is said to be the good solution for everything, and you show the problems related to bypass, so please go on.
Yeah. And 1 year later, the patient is very good. So she had just TAA, and we solved the problem with the stent. So concluding, even now that we have very good devices for almost all aneurysms, there are some aneurysms that are difficult to treat, and parent artery occlusion can be a terrific or the best option. Sometimes to achieve a parent artery occlusion, in my mind, we need a bypass. But sometimes bypass don't work, and we have to recognize them. Thank you.
Are there any questions to Guglielmo?
Nice presentation. What you showed, the grafts were all venous origin, right? None of them were of radial or other accesses. The graft that were used were of venous origin, or from radial artery also it was used?
Sorry?
So the graft, you had the bypass.
Yes.
So they are of venous only, or radial as well, arterial side?
Also with radial arteries.
Radial artery. So my question is...
the oldest one are venous, and now they prefer the radial artery. The last one was a short patient with short arms, so the cardiologist didn't want to get the radial artery because it was too short, too tight, and so they preferred the saphenous vein.
So the question is, what is the long-term patency of the venous graft?
You see, we had just one case of stenosis in the bypass, in a venous bypass. The other went very well, and the other one was the one that occurred acutely. but other bypasses work well.
So, but our experience with the venous graft is not so good.
Yes, in the literature is so. The venous bypass is not so good as a radial artery bypass.
Yeah, but amazing stuff. Thank you very much for sharing
Thank
this.
Do you do systematic long-term follow-up after bypass?
Not always. Not always, also because in our center, patients can arrive from all around Italy, and then frequently we lose the patient. But when they have problems, they come back.
So I've got a proposal. Next ALICE is in November. If you can collect all data, the long-term result, it would be great to have it presented for ALICE.
Okay, I will try.
Yeah.
Thank you.
Any further questions? If that's not the case, so the next speaker will be Vladimir, and he's going to talk about complex anterior aneurysms treated with low-profile flow diverter. Please, Vladimir.
Okay, I don't see the presentation, just... Could we start the presentation? Gavrilovic? Okay, perfect, thanks. Thanks. This was the title of the presentation, but my aneurysms are just little babies compared with those of Guglielmo's. I'm Vladimir Gavrilovic. I'm working in Italy, in Udine. And if we start with the concept to cure the aneurysm, means not to have it anymore. And it should be also in follow-up. These results could be obtained also in this way. So, for the treatments that I will present you, I've been using this small flow diverter, Silkvista Baby, using or with his two best known advantages, like stent visibility and navigability through 017 microcatheter. So for this opportunity, I retrospectively evaluated 21 patients with 24 anterior cerebral artery aneurysms that have been treated from 2018 till 2022. So in this group, we will have 11 patients with 14 complex ACOM aneurysms. What does it mean? Large, wide neck aneurysms of ACOM that involved angle A1, A2. 9 patients with a distal ACA aneurysms and 1 patient with a dissective A1 aneurysms. These patients were mostly symptomatic. Some of them had a previous bleeding. From the bleeding, from this acute situation, I usually bring them with few coils, and then in a subacute phase treat them with flow diverters, so that they were coiled and completed flow diverter. We also evaluated the baseline patient aneurysm characteristics, all the procedural technical outcomes, and modified the Rankin scale at the end. 11 patients with those ACOM complex aneurysms were treated in this way. So 5 patients were treated with the flow diverter deployed in cross. So from contralateral A2 through A1 till ipsilateral A1 segment. 3 of these patients were treated by 2 parallel flow diverters, and the other 3 patients were treated by 1 flow diverter if it was not sufficient, the second one was agent. The follow-up was done with the magnetic resonance, 36 months, and the idea is to follow them till 5 years, and geography is done 6-12 months after the treatment. So what's happening? We didn't observe mortality during these treatments. If we had the intra-procedure complications, yes, and this is the case that we see on the first slide, first picture, that I had intra-procedural occlusion of the stent while it was deployed in cross. So from contralateral A2 to ipsilateral A1, that was resolved in that moment with the Reopro. At the end of the procedure, patient was completely asymptomatic, stayed asymptomatic. In some 4 patients, I had some minimal hyperplasia intrastent. But if we compare it to how it was while the stent was deployed, there were very different diameters of this artery that was treated with 275 by 20 stents. So this intra-stent hyperplasia was just like the lining of the intrastent. There were no significant stent morphology, so I didn't have fish mouth effect, but I've noticed, this is one more intrastent hyperplasia that I've noticed in the curves, but that I wanted to say that this stent I've noticed under the neck of the aneurysm, or maybe at the origin of the ipsilateral A2 segment. These stents, like the other DFT stents, tend to get a little bit wider. And as a consequence, in the proximal or on the distal part, there is some small, minimal deformation, but this deformation didn't bring any significant changes. But this is just to note. Deployment and the follow-up on 6 months also showed the same effect in a stents that I've noticed in pericallosal artery, where by the side we can see that it is a little bit wider with a minimal deformation of the distal tip of the stent and proximal. Of course, if we take a look, we can see that the inner side of the curve of this stent is a little bit darker, so it's a dense mesh, and from the other side we can see the so-said sleeping coils by Dodi as a shrinkage of the sac. One more case, this is the A1 aneurysm treated by the single 275 by 25 silk vista baby, and the same thing, the dancing of the mesh was observed, but this dancing of the mesh I observed by the, I know that it was caused by my pushing of the stent under the neck of the aneurysm. So on a follow-up, if we push this stent, it will react also. How it will react? It will react by the changing of the caliber. It was not the problem in this case, but in a short cases with a wide neck aneurysm, it could be a very big problem. In dyna reconstruction, dyna CT, MPR, we can see it just like this, the dancing, just like the artifact. So the results on a 30-month follow-up, what was happening with this? We were covering a lot of branches. It was like in total 18 branches, side branches that were covered, but no one of these on DSA angio was not seen as occluded one. Occlusion rate was 87.5 of the aneurysms. We used the OKM scale for evaluation, and of course, Interesting thing was the acting of the side branch covered in a cross. We didn't see the ischemic area on MRI follow-up, and all patients were, or still they are, asymptomatic on the clinical follow-up. So the question would be, why would somebody treat in cross the aneurysm like this? Maybe to treat also this side of the neck. The stent is deployed from the left A2 segment till the right A1 segment. This is how it looks like, and this is the follow-up. This was the severe reducing of the caliber of the ipsilateral A2 segment with complete occlusion of the aneurysms. This is 1 year follow-up, but all the vessels are patent. They are reduced caliber, but they are patent. This was one of the first cases done by this flow diverter. It is 2018, and it is the 25th December. So it was the bleeding, a young lady with a lot of different options how to treat this aneurysm, and the idea was like, let's do the coiling, charge it during the night, and order the flow diverter for the following day. The stent was deployed in cross, and this is the deployment of the stent. Just to see if it's possible, I brought the video, but it's not working. No problem. My idea it was, while I was deploying it, I was pushing the stent to cover this side of the wall that was exploded. It was just like a blister aneurysm. This is how the stent is at the end of the procedure. And it is very important to be visible, especially if we are doing the acts like this, under the huge branches, so we can see the density of the mesh. At this stent present the density of the mesh. Why is that important? This is the first angio after, and this is the ipsilateral less perfusion. So what we're going to do now, I'm becoming a little bit panic, wait for a while, ask to raise the pressure. From the other side, there's nothing happening. 20 minutes later, nothing's happening too much. And I decide to wake up the patient. Patient is asymptomatic. A few days after, she was discharged as asymptomatic, but of course, I start to wonder, is it really necessary to compact the stent on the aneurysm neck now that we can evaluate its deployment? Does it work better? Comparing with the possible consequences, is it worth being so aggressive? She remains asymptomatic, and let's see how is her follow-up on 6 months. On 6 months, the contralateral A1 almost does not exist, but ipsilateral A2 segment is good perfused. And this is how looks the stent. There, where I've been pushing this stent, it's a little bit wider, as I showed before. The aneurysm is completely excluded, and the origin of A2 segment is patent. This is how it was before. So, this was the recent case of the giant pericallosal artery with the calcifications. And of course, if we are trying to treat something chronic or change the different flux that was chronic, is something like pretty dangerous. We have a lot of vessels, they're hypertrophic here. The idea was to put few coils and under it to deploy the flow diverter, and it was deployed. It was like 225 by the diameter, so distally, and it is the regular diameter that I used to put in this vessel. So why not 275? This is the first run after. And we see the hyperperfusion of the So the callosal margin and pericallosal, pericallosal is patent. Callosal margin and the frontopolar have difficulties, but they're patent. And we have retrograde flux. Antegrade flux, retrograde flux, but what is here? Is it clot? Let's wait. We have dominant retrograde flux, so it is patent. So how to solve this situation? Where we have slow antegrade flux and dominant retrograde. Ask to raise the pressure. Decide to wake up the patient, and patient is asymptomatic. I don't have the follow-up of this patient because it was treated 3 months ago. One more interesting case. This is the large ACON complex that I've been telling you before, that there were something like 3 patients treated like this. Strategy. So we were playing with Lego as a kids, so we can play and make a lot of different forms. Put the stents in X, double C, parallel, or what. So the decision was like 2 flow diverters and additional coiling. That was the preferable treatment. If we fail, to put it in a cross. So I started from the more difficult side that I tried and that I taught, from the right side. Deployed once 275 by 20 Silvista baby. Then I went on the easier side, and on the easier side I spent 1 hour trying to catheterize it. So it was necessary to loop the sac. Loop the sac, getting out of it, and deploy the second one. So this is the flow diversion just after the deployment. Stents are like this. This is the run just before the deployment, and this is the follow-up 6 months after. How are the stents? Here are the stents at the deployment and 6 months after. They're kissing. Recent case, similar. One more time, it was necessary to loop the sac, and from the left side and from the right side. And here, 070 microcatheter makes a difference. Navigation with this device through 017, and in this situation can change the result completely. These are the stents deployed. This is the run, and this is the follow-up on 6 months. Stents are completely kissing, so as a result of the shrinking of the stack. So thank you for your attention.
Thank you, Vladimir, for this nice talk.
Hello,
Mitchell?
conference room.
Yes, continue.
Marcus, sorry for interrupting. We already finished 2 cases. The one case was intracranial stenosis, might be, but finally we did just extracranial carotid stenting. And this case, we took the patient with multiple aneurysms previously coiled for the ruptured one on right MCA. And we scheduled this patient for the new FD from the Mariel company. IC aneurysm. She has also the aneurysm in ACOM segment. And then we did the catheterization for this aneurysm, and we placed the Vasco 10 plus, Vasco 21, and we started to open the stent. The name of the stent is Silk Road, and it's less visible than we needed. We discussed with the engineers, and the stent is not opposed to the wall of the artery. I think the sizing may be an issue. That's why we discussed with the engineer and decided to take it out, this stent. Then we placed the headway 21 and we opened the Silk Vista. And you can see it's fully visible and the position is okay. It was some luft, some space here, and then I pushed a little bit the stand and the position is okay, and you can see the nice stagnation inside the small aneurysm. And after that, I did a massage with the wire, and after massage, stent became more opposed to the wall, and we finished the case with the control CT is okay. And now we finished 4 cases already. And Zagreb team also placed the pipeline vantage and patient is okay. And I hope to see you in nearly 1 hour in Swiss Hotel in conference room. Please continue the discussion. And Vlad Gavrilovich, nice to see you in the conference room. Sorry for interruption.
Thanks.
I think there is a lot of questions about the placing flow diverters in the anterior cerebral arteries. Please enjoy the conference. See you in 1 hour.
Thank you very much. Minchu, one short question.
Okay. One question.
What was the first stent you used? What was the name of it?
Yes, Marcus.
What was the name of the first stent you used in this case? We didn't hear it clearly.
It was the Silk Route.
And what is the name of the company?
Company is a Indian company, Merrill. They're producing Menox. Menox is a great product, and this is attempt to produce the stent.
Okay, thank you
but
for
I think it's the first step. Yes. Okay.
Okay, thank you for the clarification. All right, see you soon.
Okay. Thank you. See you. See you.
Okay, Vladimir, I'd like to ask you, we have made the same observation that with DFT flow diverters, that there is a change of morphology over time. Not in all cases, of course, but it seems that it's more often compared to the old generation.
Yes.
Yeah. Do you have an explanation for this phenomenon?
Marcus, thank you for the question. And thank you to Sublime DFT stents. So, what's the fact? We've been working with the stents that were made completely different. DFT stents has different characteristics, and these stents are opening completely differently, so they're opening almost immediately. To put the stent like this is my explanation. I didn't have it directly from the company. I asked for this information, but I didn't have. So the idea is to put the stent like this in some small microcatheter. You have to have the wires that are thinner, but there with a more radial force. This more radial force is deployed in one new segment that we don't know how is acting intracerebral. We are speaking above the siphon. So the idea is smaller wires, more radial force in a short stent could make a problem, or in acute curves. Acute curve, let's say, put some DFT stent in a T carotid and it make it short. That make a problem. We saw it, Guglielmo and I, we saw it in a previous conference that we had. So this could be a problem with the DFT stents, but not just with this particular stent. Yes, yes. And I think it is connected with the radial force of this device. But, you know, working with these new stents and teaching the semiotics of these stents is very important. So you know where a dancing mesh is. You know how are you deploying it by the markers that are moving. You're pushing one marker, pulling back the other one. So we can learn these semiotics, which can help us to deploy this stent in the precise way. And the precise way would be less we touch it, better it is.
Yes, that's right. But the problem is you cannot foresee in which cases you have
Of course not.
change of the morphology
yes.
or not. That's the
but
problem.
as you noticed, for that A1 segment that I had that dissected huge fusiform aneurysm, what have I done? I didn't put the short stent, knowing this acting. I had to deploy. I wanted this stent. Why? Because I wanted to cover all the line, and I know that this stent will not change me the anatomy. If we put the other stents, minis, could change the angle of A1, A2. This stent is respecting the anatomy, but if I put it the small one, I know that I knew that I could have a big problem.
Okay. Any other?
This is my idea, so just nothing. And speaking with Dodi was confirmed, something like that.
Thank you very much for your presentation. And regarding Marcus, what you've said, one of the things that probably explain what we saw regarding the fish mouthing at both ends is our tendency to overexpand. I mean, we used to place larger stents that, I mean, in order to cover the possibility of implanting a small stent in an artery, we tend to oversize the stent. And at the end, what usually happens, because you saw it perfectly there, it overexpanded in the middle and then is fish-mouthed at the ends. It's like regular, simple mechanics. I mean, every single filament remains with a certain tension that after is freed in the middle, it becomes fish mouthing at the end.
Agree with what you say, absolutely agree, which means that oversizing of the stent is not a good thing. Do we agree on this? No oversizing and no pushing of the stent in front of the neck, because all stent with a high radial force, if you compress the stent at the level of the neck, then there will be a fish mouthing potentially. Do we agree on this?
Agree completely.
Can I? A third thing is the length of the stent. If the stent is not long enough, it will do fish mouthing because it will shorten, and the shortening with widening will do, I agree with you, also the length of the stent. It should be a longer stent.
Yeah. I think that's a good point. But my feeling is that the tendency of morphology change with the DFT stents is higher, the rate, compared to the older generation. I think we have different versions available, for example, for the pipeline flow diverter in the past. I think for the pipeline flex or shield, it was not very common. And for the Vantage, we see it more and more.
And could it be related to the higher radial force? Because it seemed that the new generation, a lot of efforts were done to make them very strong radial force. All physicians want radial force, we too, but now we discover the negative aspect of high radial force.
Just like
it could be, because there is always a tendency that at the neck of the aneurysm there is an over-expansion of the stent, and at the end this can create a fish mouth.
Yes, we saw it also with the first generation of Surpass. When they used the 92 wires, they used to have a lot of fish mouthing because of the number of wires was too much.
Okay, but have you seen an overexpansion at the level of the aneurysm as well, or just a fish mouth?
No, the fish mouth, not overexpansion of the aneurysm.
Because I think this is different.
Yeah.
Here with this stents, you see that overexpansion at the level of the aneurysm neck.
Which stent did you say?
The first Surpass, the old one.
Surpass? What is this?
One comment from my side. I recently had a conversation with an engineer, and we looked in a very detailed way on the hysteresis curves of all those flow diverters. And they were quite different. So I think we all agree that it's the common thing of the DFT flow diverters. Yes, this is our observation with several of them, but it's not the radial force alone, because they are different in their radial force distribution. There must be another reason. And one question to you, Vladimir. You mentioned this density section.
Yes.
What I didn't understand is how did it behave over time? So as far as I understood from your presentation, it got denser over time. Is this correct?
No, no. The fact is like it was clear the segment where the stent was deployed by more pushing it. So the mesh was dense. That dense mesh, on a follow-up, showed the consequences that René said, deformed the stent in a proximal part.
But the density was there right from the beginning because
yes,
it was your intention.
Yes, it was right from
okay.
was right from the beginning. So density also could be the positive thing, or learning how to see this stent in particular can be very, very useful. So we know while we are covering some segment with a lot of side branches, we will not push like this. Yeah. So that could be very useful.
Thank you.
Thank you for the question.
Any additional questions? If it's not the case, so we continue. Anil Arat from Ankara.
Thanks.
Turkey will continue with the aneurysms.
This is not mine. That's someone else's presentation. Anyway, as they put it up, I hope mine comes in. So it's nice to be here in the steppes of Central Asia. It's interesting that how many people have attended. Okay, here we go. Today I'm going to talk a little bit on a flow diverter not so commonly used. It's the Derivo mini device, and it's a single center case series from my institution. So the Derivo mini device is one of the smaller sized devices. It is made up of nitinol, and it has 3 markers on both ends. It spans from 2.5 to 3 to 3.5. And does the pointer work at all? That's fine. Anyways. And it goes through a 21 catheter. So it has a TP version and a tipless version. And the porosity of the device is very similar with the upper range, with the upper porosity starting from 72 going down to 63, and the lower one from upper 81s to lower 65s. It's very similar to the regular Derivo device. And the amount of wires, that's a different subject because ordinarily the Derivo has 36 to 48 wires. The Mini has 28 to 32 wires, and the company says it has double wires, so the angio, I mean not the angio, the architecture of the wire architecture is different and peculiar. So basically it is something not tried before. So our procedures is a routine general anesthesia procedure with IV heparinization, and the company has some specifics about the catheters, but we use an unapproved catheter, which is the Prowler Select Plus. It is not approved for this device, but it hasn't let us down until now. And our antiplatelet therapy is the usual clopidogrel plus aspirin. If it doesn't work, we switch to prasugrel. Before the procedure, emergency cases with tirofiban, and we do an early follow-up, non-invasive, and then DSA 3 to 6 months, and then yearly MRAs. So we have 29 patients with 43 aneurysms, mean age 49.9, and the aneurysm size is a mean of 6.9, ranging from 1.5 blister to 22 millimeters. 5 of them were ruptured, and 2 were remotely ruptured. The aneurysms, a little than 1/3 was in the ICA because of sizing. Most of them were distal aneurysms because it comes in small sizes. Additional coiling, because they were distal, was performed in about 1/3, and stenting additionally in 1/3. It may be with or without coiling, and I'm liberal in using stents within flow diverters. In terms of clinical results, at about 15.5 months, one patient died. There are 3 events, clinical events on follow-up. One patient died due to severe subarachnoid hemorrhage. One patient had a frontal hematoma. You're going to see it. And then one patient had a hemiparesis. I'm going to go into it. It was because of negative pressure pulmonary edema. Basically, the subarachnoid patient died, and then one patient with subarachnoid improved, so that constitutes the whole change in the MRS in this 29 patients. So 6 adverse events, significant adverse events. One of them was a slow flow in the jailed branch, which is not of consequence generally in our practice. However, this young gentleman went into a negative pressure pulmonary edema as he was being awakened. It's the first time I've seen it. It is drastic. It is life-threatening. And he crashed literally on the table. He became hypotensive. So at the level of the jailed branch, when they were able to wake him up a couple of days later because of the pulmonary edema, he had hemiparesis, but that improved on follow-up. Actually, as of discharge in 1 week, he was MRS2, and on follow-up, he was MRS0. One patient was discharged without problems, and she came back 3 weeks later because she said she started having headaches, and we discovered a removed hematoma. One patient had a distal device migration. It was our fault. We pushed too much, so we played a second one. One patient had a constriction of the proximal end of the device. I'm going to show all of them except the first one, which is a medical case. This patient had vasospasm, so we opened it up with an enterprise stent. There was one asymptomatic severe stenosis on follow-up, and one patient had a half parent artery occlusion. I'm going to show you what I mean in a moment. So the overall mortality is 3.3%. Overall neurologic morbidity is 6.6%. Procedure-related neurologic morbidity is none, and procedure-related death is none. All devices except one was patent. So this is the one, I'm going to go through the adverse events. This is the one with the recurrent aneurysm after coiling, after subarachnoid hemorrhage. So with the arrows, you see the stent on follow-up. It is proximally occluded, but on the injection of the left side, you see the right distal anterior cerebral artery. So basically, the device is occluded proximally, but not distally. The patient, we discovered this during the follow-up angiogram at 6 months. This patient has had this relatively large aneurysm, so we put the device, but since the distal artery was irregular, I opted to put an enterprise stent distally. She had also a contralateral giant aneurysm and visual loss secondary to it, field restriction. And this is what we had at the end of the procedure, a decent amount of stagnation. And the patient called us 3 weeks later saying she started having headaches. She was discharged 2 days after the procedure. We had this hematoma of the frontal lobe. We admitted her again and watched her for 5 days. Her verified now level was 1%, so we put her on half a Plavix instead of 1, and she recovered without problems except for her visual loss, which stayed. This is the 6-month angiogram. And this gentleman came with a ruptured aneurysm. Actually, he came with a ruptured aneurysm and myocardial infarction, severe congenital heart failure, and pulmonary embolism. And his both internal carotid arteries were occluded. The right side, as you see on your left, was partially filling from external carotid artery. This gentleman had something rare. He had bilateral true PCOM aneurysms, which we didn't know which one bled, and he was in very bad condition. We were told to finish the procedure in half an hour. So we opted to place 2 flow diverters. The one on the right would be into the PCOM. The one on the left, the plan was to put it into the PCA. But because it was tortuous, we couldn't handle the device. We pushed too much and it jumped forward. So we placed a second one. This is the 2-day CT angiogram. So all devices are patent. The aneurysm on the right is gone. The left is persistent. But this gentleman, needless to say, expired a couple of days later because of his severe comorbidities in addition to subarachnoid hemorrhage. So this gentleman also had a bleed And this is the rotational angiogram. He had a blister-like aneurysm of the distal ACA. And the next day we went in to treat him, but there was vasospasm and stagnation of contrast. So I coiled the aneurysm as safely as I could, placed the device, but proximally where there was vasospasm, it tended to kind of fish mouth. So I opted to go in and placed an enterprise stent during the procedure, and this is what I had. So a week later, we repeated the angiogram. If you see whatever is happening proximal and distal to the enterprise stent, he had severe vasospasm, as all the frontopolar arteries, the early branching callosum marginal, all of them in severe spasm. Fortunately, he did well, and this is the 2-month follow-up angiogram showing a decent result. This patient, I put the flow diverter because I thought it was prone to recurrence ICA tip. Below you see it after treatment, and she developed severe intimal hyperplasia. Again, this was noted on follow-up angiogram. We kept her on Plavix and aspirin. So in terms of imaging follow-up, out of the 43, the patient with 3 aneurysms and the patient who expired, he had 2 aneurysms, they don't have a follow-up angiogram. So a follow-up angiogram is available in 38 aneurysms, giving us at 7.8 months an occlusion rate at about 73.6%. Now, if you get all imaging modalities, angios, MR angios, and CT angios, the 2 first patients come into play, and then we have, at about 13 months, we have an almost 80% occlusion rate. However, this is with stents and coils. So then we go and look into all those aneurysms treated with derivominis plus minus stents, which is 30 aneurysms, again for the same reason, 5 aneurysms missing DSA. In this group, at about 8.6 months, we have 68% occlusion rate, and when all angiograms, all the imaging is included, at about 15 months, we have 76 to 77% occlusion rate, which is acceptable in terms of what we have in flow diverters today. Now, when we go into aneurysms treated only with derivomini, again, we have those 2 patients without angiograms. We see at the early follow-up at 7.2 months, it is only 44.4% occlusion rate, which is lower than what we expect. However, as the patient with 3 aneurysms comes in, we have at about a year almost, again, an 80% occlusion rate. How about coils? DSA is available in all 14 aneurysms that were coiled, and only 1 has Raymond 2 occlusion. The rest, 92% occluded at 8 months and 14 months. So a couple examples. This is a kid with rapidly enlarging aneurysm after fall from a height, and on your right you see the device after placement and the stent, and immediately after the procedure. And this is the follow-up angiogram, which is classical for flow diverters. A distal ACA aneurysms with the branch coming off the aneurysm. I coiled it and put the flow diverter. Again, I'm not shy of placing stents in flow diverters. And this is what we had. We had recanalization at 3 months. So we said, okay, let's wait. And at 6 months, we had further recanalization. We were tense. By that time, I discontinued all aspirin and Plavix because I was scared that this was going to rupture. So I scheduled him at 9 months for a follow-up angiogram, and we have this. I actually scheduled him for an intervention. So we awakened him up because practically the branch was gone, the aneurysm was gone, he was not symptomatic. This is a patient with triple aneurysms, the one without the follow-up angiogram. And at the bottom, you see the follow-up MRI, which clearly shows none of the aneurysms are persisting. This is a young lady with bilateral P1 aneurysms that are fusiform in nature. I went to the right side, placed the flow diverter, and coiled the aneurysm. It was not dense coiling. I got pushed out, couldn't go back in, obviously. It's loose coiling. And this is at 6 weeks, the MRA. So it shows some filling on the right, the larger one, and full filling on the left side. And this is the 4-month angiogram, showing persistence of the left-sided aneurysm, and this is 16 months Again, this is 16 months showing that both aneurysms are gone. So when we come to flow diverters, Lieber and colleagues years ago said there is no flow diversion that is one size fits all, that it does everything. We don't have a value of flow diversion that we can say, okay, below this or above this, there is flow diversion. And Jean-Claude Jantric also published in a book, and he says there is no quantifiable definition that differentiates a braided stent from a flow diverter. Again, Vaclu's work from years ago, they say vessel wall coverage of about 24%, that is proceed about 76%, should be enough to occlude aneurysms. And this is echoed in recent articles talking about a maximum porosity of 75%, preferably about 65%, and another yet more recent one, they go down to 18%. They say 18% of vessel coverage may be enough for flow diversion. So how do we decide if something is a flow diverter? What is a flow diverter? Which we don't know, but how we decide if something is a flow diverter? There are so many variables related to the flow diverter itself. It's not only the vessel wall coverage, it is not only the pore density, it's the braiding angle, the braiding pattern, the diameter of the wires, the deformation capacity, well, the anti-capacity of the device, its volar position, uniformity of the pore structure. I think that's one of the most important things. Availability of appropriate sizes, and on top of that, we have the patient and aneurysm-related factors. Putting a flow diverter in an MCA aneurysm is clearly different than putting in a flow diverter in an ophthalmic aneurysm. So it all boils down to clinical performance. We accept the current flow diverters just because the pioneers did so, say, 20 years ago, as the standard of flow diversion. So to conclude, flow diversion may be regarded as a continuous rather than a dichotomous variable. It's not actually that something has flow diversion, is a flow diverter or not. Everything diverts flow to some degree. The outcome set by the current flow diverters has established a threshold against which the new devices should be tested against. In this regard, the Revo Mini in our series has an unconventional design, yet enough flow diversion, as you will. It was also safe in our hands without a significant problem. And it is different, its different architecture was not a problem for us in pushing the device across the aneurysms. Thank you.
Thank you, Anil. Questions from the floor? Everybody is sleeping? No? If it's not the case, I think for the sake of time, we continue with the next talk. And this will be given by someone from the group from Kirill Orlov. Unfortunately, I do not know your name, but... so maybe you can announce.
So please, Vadim, if you could, Vadim Berestov.
Hello, my name is Vadim Berestov. I work in Orlov's team. Unfortunately, my chief was delayed in Moscow by urgent events. And if you allow, I can make our report in English named, can you put my presentation on the screen? Our talk named that stent-assisted cooling in the acute period of subarachnoid hemorrhage. I can represent two big centers in the Russian Federation. First off, at Meshalkin Clinic, one of the biggest cardiovascular centers in Russia, more than 10,000 procedures per year. In this center, for 10 years, we made more than 3,500 of aneurysms and 362 aneurysms in acute period of subarachnoid hemorrhage. Radicality all cases was 94%, unfavorable outcomes 3.5%. Second one, in Moscow, Federal Center for Brain Research and Neurotechnologies was founded on 17 November 2020, had is Kirill Orlov. For 2 years, we raised up from 50 cases to 860 cases per year. 41% of aneurysms cases in all amount. Our tactic for cerebral aneurysm based on 2 big trials, ISET and ISHUA, and we prefer endovascular tactic for all aneurysms. But some aneurysms can be difficult for endovascular surgeon. Unfavorable conditions is vascular tortuosity, negative angles of branches, and wide neck. For these cases, we use balloon assistance and stent assistance. Stent assistance can change aneurysm thrombosis, but need a long-time double interplated therapy. It's better assistance methodically for aneurysm treatment, and we use it in more than 50% of all cases in patients with aneurysms. But we can't use this tactic in acute period of rupture. We made internal research in Mishalkin Clinic and compared 2 groups of patients with stent assistance calling and balloon assisted calling at acute ruptured cerebral aneurysm. The goal of this trial was to show efficiency and safety of this methodic. Anatomical results we showed find similar rate of the total occlusion in both groups at the final in the end of the operation. But at the follow-up, the total occlusion rate in stent assistant group was significantly higher than in balloon assisted group. It's because on high rate of recanalization in balloon assisted group. 6 cases, increasing the packing of the coils. Reoperation in almost 40% of cases in balloon-assisted group. Complication rate was similar in both groups, and we know hemorrhagic complication in cases with stent-assisted coiling. Condition for this is reliable closure of all possible sources of hemorrhage, multiple aneurysm, arterial dissections, and other. Absence of indication for operal surgery on the aneurysm or on complication of intracranial aneurysm. And good tolerance for double antiplatelet therapy of patient. Stable condition, hand has rate 0 to 4 and the modified ranking scale from 0 to 4. And we use this scheme of antiplatelet therapy. We use eptifibatide intraoperation and for 12 on 24 hours after surgery. Then after extubation, we use clopidogrel or ticagrelor for all patients with aspirin. Some examples. First, ACOM aneurysm. 2 days after rupture, we use coils for close this aneurysm, but at the final angiograms, we saw bad visualization of right ACA. We put microcatheter and deploy stent through the narrowing part of the artery with good angiographic and clinical outcomes for this patient. Another example, acute ruptured aneurysm of the MCA, M2 branch. It's look like fusiform. We use semi-gelling tactic for this aneurysm. We first put microcatheter in the lower branch of the MCA, then put some coils in aneurysm and the artery, and open it stent. Showed us good angiographic result with good visualization of the of the M2 branch of the MCA. What the source is, we use also use stent-assisted coiling in the case of the vasospasm. This example, segmental spasm of the M1 segment of the MCA. We put the stent to assist coiling of the these aneurysms. And in next angiogram, we saw better visualization of this segment. Doppler showed a reduction of speeds from 3 to 1.5 meters per second. And in summary, sometimes stent-assisted coiling become a good alternative to balloon-assisted coiling, significantly expanded the possibilities of endovascular surgery in treatment of cerebral aneurysms in the acute period of rupture. Спасибо за внимание.
Any questions for him? No? René?
Yes.
Please.
So now today, obviously, complication rate after stenting at acute phase is very low, which means that you're in practice, you're increasing the rate of stent placed at the acute phase?
Maybe yes, but not significantly. We use stent-assisted coiling in the very close group of the acute ruptured aneurysms because it high risks of the hemorrhagic complication in the complex patients.
So what is the rate of hemorrhagic aneurysms that receive a stent? Is it 10%, 50%? Or any idea?
Maybe 10%.
Okay, thank you. So we switch from aneurysm treatment to stroke treatment. And the first speaker will be Jose, and you will start with the topic of, you can use my microphone.
So for some reason we will start with ischemic stroke. It's going to be at least a change after so many aneurysms. Let's start with the presentation. So what we're going to do here, we're going to present a couple of, first of all, the preset thrombectomy device. Let's start with a couple of cases. We are going to describe the device, our experience in brief, our impression, and the rescue strategy. Okay. Disclosures. What I decided to do is to show you a classic week. Yeah, this is a week, Sunday. It's there. Okay, it works funny. Okay. Sunday, yeah, 80-year-old male, last time seen normal 2.5 hours before admission, NHSS 8. You see the near total occlusion of the lower trunk of the left MCA. Every time you see a clot there, it's because there is a bifurcation and the clot gets stuck there. You see the markers of the stent trigger, proximal marker, a single one, and two markers distal, a 4/20. Time to recanalization 7 minutes from the femoral axis, TICI 3, one pass, simple. This is what we like. This is what we all like. The same Sunday, 64-year-old, NHSS 17, complete occlusion of the M1. We cross with the preset 540. This is a very nice stent reaver. This measure is my favorite for M1s. We tend to deploy the stent reaver distal to the clot as much as we usually were placing. We don't center the stent reaver in the clot. We just go more distal. One pass, 5 minutes from the femoral axis, TK3. This is what you like. One day afterward, Monday, those are sequential cases in the same week. M1 occlusion, 540, the same story. You see the proximal marker, the distal markers. You don't see the stent so well. One pass, 16 minutes, TK3. Tuesday, one day afterward, NHSS 15, left MCA, proximal temporal branch. This is the 420 Lux. It's a preset with a little higher radiopacity. I don't really think that we need to see so much the stent if it makes things a little bit more complicated in technical terms. It's a stiffer stent reaver, and I don't really see the need for more radiopacity. But in fact, this 420 worked well, one pass, time to recanalization 11. We were really happy because, again, you see that sequential cases with excellent results very rapidly. You don't have to stop doing what is programmed for the same day. You don't need to cancel cases because sometimes it goes so nice, so rapid. Tuesday, the same Tuesday, NHSS 25, left MCA, carotid occlusion. You see the intracranial carotid occluded. You go with a 540, distal 2 markers, proximal marker, deployed across M1 and carotid, one pass. On top of it, you see that the recanalization was successful, and then you see the upper part. The marker is not very good. You see that there is here a distal A2 clot. It's always necessary to remove those clots. Plenty of cases with distal emboli on A1 don't do well despite the good recanalization that you achieved on M1 or carotid. I mean, sometimes the ACA is the one that decides the fate of the patient. So you go with the 420 more distal. Imagine the tortuosity of this artery and how far you can go with a 420. And the result, as you can see, with only a sequelar ribbon of ischemia, but preservation of the ACA and MCA. So those are sequential cases. Thursday, the same week, this patient, an alcoholist patient, was found with a traumatic dissection and occlusion of the carotid on the right side. He came with an aspect 5. We recanalized the artery by crossing the artery with the intermediate catheter or a Sophia in this case, through the Sophia that was crossed across the carotid that was occluded and dissected. You don't want to lose the position. You just go through the dissection and then you do the thrombectomy on the upper part. 650, 420, and this is the result. And on follow-up, you will see that we recanalize the artery with a couple of flow diverters and a wall stent. I mean, sometimes when you have a very tortuous artery, I recanalize not with stents, but with flow diverters, and then I expand them. And this is the final result where you see a good recanalization, good reconstruction of the artery. You see filling defect on the right carotid, and this is in relation to the original aspect 5 that he came with, but the patient did really well. At 30 days, he had an MRS of 2. That is quite remarkable. The good thing about this preset, because again, there are close to 12 stent reavers in the market, but the preset has something very nice that I think it deserves to be described. You have two different cells. One of the cells looks like a mouth. The second looks like a duck. The vast majority of cases when you succeed to remove a clot, you will see that the mouth is the one that grabs the clot. The duct doesn't do anything. And on top of it, you have this helical slit. The helical slit is this construction of the stent that allows to maintain the integrity of the cells despite the fact that you are deploying a stent retriever in a smaller artery than the nominal of the stent. So you implant or you deploy a stent with a nominal of 5 in an artery of 3. What happens is that you collapse the helical slit and you maintain the integrity of both cells that continue to be effective in order to integrate clot. This is something that is quite remarkable. On top of it, you see also this proximal ring that is the one that allows the stent retriever to remain patent and expanded and fully expanded at the proximal part. Sometimes you can use this proximal ring in order to grab fibrous clots. It means don't deploy, if you happen to deal with a fibrous clot, deploy the stent retriever a little bit more distal or even past the clot and try to grab it as a lasso with this helical structure. So you see the cells. The cells can be quite large. Pay attention to the dimensions of the cells of the preset 6, close to 5 millimeters, and the cells of the preset 4, also close to 4 millimeters or 3.8. So are quite big cells. And the family of preset, as we mentioned, 420, that is a very common and used device. 540, that's probably the most used now. The rest are just different measurements that we don't usually use. There is another version that is the preset light, that those are the stent retrievers that can be navigated through a 17, that sometimes is necessary in order to go distal, you go with a 17 instead of a 21, and then you just can use them. Are quite, the deliverability of them are quite good. The lux is more radiopacity. We are not going to waste time on that. If we check the performance of this stent retriever in comparison to others, you will find Paolo Macci did a very good work comparing the preset with others, and realized and proved that the preset has a very good capability of removing soft clots, close to 100%, and in comparison to others, a much better performance. And even with tough clots, close to 50% capability. Again, comparatively better than the competitors that we all know the others. Yeah? So soft jelly clots are the ones that we remove with relative simplicity, and the firm clots that are the bad ones, yeah, the ones that sometimes we cannot remove. For the bad ones, remember the possibility of removing them with the proximal part of the stent retriever. Clot integration, another characteristic that can be checked in different papers. Preset light penetrates significantly deeper into clots. This is basically a laboratory confirmation of what we already said. Okay? Longer stents, we know that longer stents work better than shorter stents. Nogueira published it, and we already knew, we had this impression. That's why most companies are now developing longer stent retrievers. In addition to the 540, there is a 650. I think it's not so necessary. The 540 is doing a very good work. I think that one of the most important things, especially for the youngsters that are starting to do a stroke, is that you need to recanalize the artery. For some reason, we started thinking that sometimes you need to try 1, 2, 3, 4 times, and then you have to stop. It's enough. We asked our residents to do like this table, showing the different performance of different stent retrievers. It's impossible to take any conclusion because the range of every single one of these stent retrievers is so wide. The only thing that you can say from there is the NEVA is an excellent stent retriever, but again, I mean, take this with doubts. For preset, we didn't have so much data, and that's why ARTIS study was done and showed 84% of recanalization of TICI2B3. That is an excellent result in comparison to the others. When we checked our own study of 234 MCAs, our TICI3 was 87%, with first pass effect of 54%. That is a good number. The general strategy, as usual, we are not going to waste time on that. You try to remove your clot and you fail. This is a common question. What do? You try once, twice, 3 times with the same stent retriever. Improve aspiration conditions. A. Select another branch. This is a very important thing. I mean, don't go to the same branch if 2 or 3 times you try with the same stent retriever, the same branch. Probably go to the straightest or the artery is the largest. Sometimes the J wire is the one that will guide you to the largest. Sometimes you are wasting your time with a temporal branch and not with the larger frontal. And reposition the closed stent retriever. I mean, sometimes go a little bit more distal, wait a little bit, or change the stent retriever for another one. Yeah, those are different things that has to be kept in mind, because sometimes there is a tendency to repeat exactly the same maneuver once after the other. If you don't change anything, nothing is expected to be different. Okay. So balloon guiding catheter, yes. And again, it's not fair to check the efficacy of a stent retriever if we are not dealing with another important part of the equation, that is the use of balloon guiding catheters. There are new balloon guiding catheters now. I basically use, or probably every single one of us has its own balloon guiding, but there are new players in town today. So we will see more advances in this field. The important thing in balloon guiding catheters is that sometimes balloon guiding catheters, those balloon catheters, at least the first ones that we started to use, were not ready for the task. See there the crimping that sometimes happen at the level of tortuous arches, yeah, and this happened with cello. Sometimes it happens with the others. Yeah, flow gate is a little bit more can avoid this crimping that sometimes occur at the level of the arch. Where to place the balloon guiding catheter? 3 different types of artery, type 1, 2, 3. Type 1 is the artery that we all like. Try to place the balloon guiding catheter as high as you can, to prepetrous. At prepetrous, you will achieve the maximal effect, the maximal aspiration effect. If you leave the balloon guiding catheter low, the aspiration effect is going to be very reduced, and sometimes it's not going even to be effective. When we compare different types of carotids and different types of positions, we realize that type 1 with an aspiration position type 1, meaning very high, works much better than a tortuous carotid with a balloon guiding catheter in a lower position. So try to go with the balloon guiding catheter as high as you can. Here you see a carotid occlusion. We tried 12 attempts. We failed. The only thing that we did here different was, in the 13th case, was to go higher with the balloon guiding catheter, and 1 pass was enough. The patient didn't do well, but the recanalization was achieved despite all the attempts that at the beginning failed. So carotid type 3, more tortuous, leads to a more relative aspiration position type 3, that means lower, and this is problematic because it affects negatively to the mechanical thrombectomy. So why this happens? Why, if you have a balloon guiding catheter low, it aspirates less, or it's less effective? First of all, longer distance, and second, and look at this, it's nice as an example. You see a guider into a wall stent. Look what happens when you have the guider into the wall stent and then you aspirate. It's the same condition that you have when you have a balloon guiding catheter and you do negative. Look what happened with the stent, it collapses. So in my imagination, many times when we have a balloon guiding catheter very low, by the time that we do negative, we are collapsing the artery and abolishing the negative effect or the negative or the aspiration effect that we are willing to have. So try to go as high as you can. The prepetrous carotid is not collapsible, and it's much better in terms of the effect of the negative aspiration. So type 1 is much better. Tortuosity is a complicated stuff. Tortuosity causes us complications such as dissections, etc. We are not going to go into that. Tortuosity, sometimes you have tortuosity and you lose clots. That's a problem. You just go for the clot again, wherever the clot is lost. You see here the clot that was lost, and then you grab it. Sometimes you have extreme tortuosity, for example, in this kinked artery. So you go, instead of going with the balloon guiding catheter, just go with the Sophia high, and then you do Solumbra as usual, and that's it. So target vessel recanalization as the objective. I mean, nobody wants to come at night to try and to fail. You want to leave the artery patent as much as you can. Yeah. Sometimes we ask, or we talk between us, we really don't care what happened with the patient afterward, but we feel a very nice sense of duty that was accomplished if you succeed to recanalize the artery. And on top of it, the data also supports that. Sometimes you say 4 passes. If you failed 4 passes, I mean, you try once, twice, 3, 4 times, and you failed. 30% of the patients in whom recanalization failed during the first 4 attempts will still benefit from subsequent centrifugal passes if recanalization is achieved. No matter if you tried and you failed, if at the end you succeed, this patient has higher chances to improve clinically. So you need to continue trying. Sometimes the preset can be used as an angioplasty device. You see the post-centrifugal spasm. You deploy again the preset, you wait a little bit, and then you have this result. Despite the fact that the radial force is not so high, sometimes can be enough to angioplasty, despite the fact that we tried nimodipine for a long time there, like a couple of minutes and nothing happened, and then with the stent retriever again, it helped. So why this stent retriever is my first choice? First of all, I would say because it works well, probably better than others in my view. I've been using this for the last 8 years, and it's absolutely atraumatic. It's the most atraumatic stent that I've ever used. There are new stents that are comparably more effective, but by far more traumatic. Yeah? Example of success, you see this small branch, this right MCA branch. We try to recanalize it with an embotrap in this case. You see the markers of the embotrap there. Once, twice, we failed. Spasm, inability to recanalize. Preset once, and this is the result, complete recanalization with the preset in 1 pass in comparison to the other 2 failed attempts with embotrap. So this is what we call rescue. 1 device rescued a second device. So this is just to show you, in order to show you some of this experience. So Solitaire, I mean, just pay attention to these numbers for a second, and then we finish. Solitaire, out of 220 cases that we did with Solitaire, we recanalized 80%, 20% we failed. Those who failed were treated with preset or embotrap. And preset rescued Solitaire better than embotrap. So preset saved Solitaire in 22% of the cases, embotrap only in 10% of the cases. Preset was effective in 83% of the cases and failed in 16% of the cases. And Solitaire rescued preset better than embotrap. In 15% of the cases, Solitaire assisted the preset and rescued it. Embotrap was not very effective. Embotrap was, in our comparison, in our series, the worst. And embotrap, in fact, was rescued by Solitaire a little bit better than with preset, 50% versus 40%. So my question was, in what percentage of patients the addition of a second stent retriever as a rescuer will allow us to recanalize the artery? So in 16%. So by adding a second stent retriever, we are increasing our recanalization, our failed recanalization, we are improving it in 16% of the cases, meaning that you tried one stent retriever, you failed, you tried the second one, and you have the chances in 1 out of 6 cases you will recanalize, you will succeed. This can be just coincidence or it can be not very scientifically, but this is what we saw. And here are the conclusions. Solitaire was effective in 80% of the cases, preset in 83% of the cases, embotrap in 65% of the cases. Preset rescued solitaire better than embotrap. Solitaire rescued preset better than embotrap. Solitaire rescued embotrap better than preset. The combined successful recanalization rate after single retrieval was 81. If you add a second one, you add and you increase to 84.4. We played, because it's nice to play with different devices, yeah? We are using now the NEVA as an option for the ones that are absolutely refractory to the use of preset and ENVI. ENVI is a new device from another company. And NEVA, it's a good option. Yeah, it's a very good option because it's marketed as the stent retriever with the highest chance of recanalizing tough clots. Yes, but I will not go into that. What we've seen is that it recanalizes better the tough clots, no doubt, but it's by far more traumatic. I will hesitate to use NEVA for patients with atheromatosis, with atherosclerotic arteries, because the higher radial force make them get entangled or entrapped in those arteries, and sometimes this is what we see. Just to finish in cases, MCA occlusion, preset 650, solitaire 440, nothing happens. Then you have a relatively good result, but there is something absolutely dirty there in the M1, so you try again with the solitaire, and when you try again with the solitaire 440, this is what happens. This is what we need to be ready, despite the fact that it doesn't happen a lot. The artery ruptured there. This was my first rupture. It never happened before. And what do you do there? So you inflate the balloon, you wait and you wait and you wait. In this particular case, we had to wait really a long time. I thought the rupture was going to be something that will be treated rapidly. It took like 10 minutes and then another 10 minutes, and at the end, it was a little bit better. This is the turbule subarachnoid that you see. The patient died after a couple of days. It was a turbule complication that was managed with the balloon, because again, you cannot stop the procedure if the patient is still bleeding there. So it's something that doesn't look nice, despite the fact that you know what's going to happen. The second case that is, for me, a case that taught me a lot, you see here an MCA occlusion that looks unusual. You see some reed there, some signs of chronic occlusion, but in fact you cannot prove that this is a chronic occlusion. The patient presents with an elevated NHSS. You need to recanalize the artery. 650 was the stent. Recanalized a little bit, but there's still some dirt. You try the ENVI, same thing. You go with the NEVA into this artery, the small one that you see there. I deployed it from the M2 crossing through A1, and then you see this leak of contrast there, this hemorrhage of this small vessel. So what do you do there? So again, I thought that I learned from the previous case. So you place the balloon and you wait, a gateway, yeah, and then you wait and nothing happens. Nothing happens. So there's continuing bleeding. So what do you do there? The thing that I found very useful was just to navigate the microcatheter. The microcatheter mechanically occluded the artery, behaved like a mechanical tampon, and I was going to inject some whatever. You can use thrombin or whatever you want to inject. I didn't want to occlude the artery because of its eloquence on the left side. And then only by placing the microcatheter and rectifying the artery stopped and stopped leaking. And this patient that bled significantly from the very beginning, we placed an EVD, a ventriculostomy, waited a couple of days, and then was discharged with an MRS of 3. So this showed me that sometimes, especially for distal ruptures, only navigating again the microcatheter can do the work. For all the ones that love to write, every single case that you have of an unusual ischemic stroke case that you've done, please send us to me or to Hans. Yeah, we will be pleased to add it to this collection of cases that we are writing. I think that this collection of cases is going to help to every single one, especially to those who start doing those interventions. And this is me, yeah, being happy after Argentina will win the Mundial. And thank you very much. Okay.
Thank you, Jose, for this nice talk. Actually, I like your idea of ABC. And I would add a D for dual stent retriever. So to use 2 stent retrievers at the same time, at least this is our rescue approach if we are fail, or for some.
No, it's, you know, I love the idea because I've heard first time with you, with but again, for some reason, you know, sometimes you see, I mean, if you want to do you want to cook, you know, asado, I will do it better, you know, because I was born with that. Sometimes I read papers from others, I don't really know why it doesn't work with me for some reason. What would be a case where you would choose to go with the double from the very beginning?
All.
With a double, yeah.
But my answer is all. All carotid T, all M1s from first pass. We've been changing our way to treat, so since 3 or 4 years now, I mean, we've been doing it as rescue. After 15 times and 5 different stent retrievers, you're exhausted, you stay many hours, and then you take 2, and in our experience, it's the most efficient. So in the scala of efficiency, it's the top.
So from the very beginning,
progressively, within the years,
you place one from M1 to carotid and the second from...
And then within the time, we've been progressively using it earlier and earlier, according to the concept, why should I wait more to have something more efficient? I would like, I enjoyed your presentation. Well, Argentina and France, not sure that Argentina will win, but this will see.
Just kidding, just kidding.
Of course.
No, we waited for him, but he came late. You know.
Concerning the efficiency, which stent retriever is better? I think it's a very subjective topic. I see that in the department it's free which one to use, and in the end they always use the same, but I don't tell them use this one or use this one. And I'm surprised to see that the publications in the literature show always better results. And our results are not getting better. So each time there's a new paper, it's 50%, 60, 70, 80, 90. Today, if you don't make 90%, you're stupid. No? I mean, we have a turnover. I do agree that the one that have been doing already a couple of hundreds or a couple of thousand are not many, but there are. They do better than the one that start. So there is a 2 years period with a lot of complication, with a failure rate which is high. But after a couple of hundred, it works better. But the success rate is not more than 70. And I'm surprised to see that the first pass rate now, it seems to be an important commercial argument to have a first pass rate. So the first results, when Osama Zaidat published, it was 25% and 23%. And now if you don't achieve 50%, it seems that you're completely stupid. No, the first pass rate is not so good, and our results in this are not as good as expected. But indeed, you said embotrap is your worst result. I mean, I don't dislike any stent retriever, but I find that there is no one, since all copied the Solitaire, which by the way was a stent for aneurysm, there is no one where you say, wow, it changed everything. No. You try, you say, is it the better or is it a Me Too? Usually the answer, it's a Me Too product. So let's see if some technical evaluation can enter.
But I think that the results are multifactorial. And I know that, you know, it seems so obvious, but the point is that it's more difficult to deal with a tortuous carotid, with a lower balloon-guiding catheter. There are people, I mean, not using balloon-guiding catheters. There are so many different variables. But again, probably most of the stent retrievers are the same. Yeah? But you need to choose one.
Thank you. So in the meantime, I was asked to continue with the last presentation. Sorry, Jens. So maybe you can continue.
I was already deeply relaxed. Now this. Okay. So actually, content-wise, it's not that bad because I have some of the points that we just discussed also on my slides. So I hope you are still with me because I'm more of a numbers guy. You won't see so many angiographies, but a few colorful drawings and a lot of numbers. Can you pull up the presentation number 1? 1? Yes. Yes, excellent. Yeah, this is what we discussed just a few seconds ago. Subject is highest first pass effect, and I will have a very, let's say, superficial view of things. These are my disclosures. I'm very much interested in doing imaging core lab work, comparing, for instance, different stent retrievers in a very standardized way, and you need to have a lot of data to do this. So this is the outline of my talk. First, best first-line therapy. We need to define the problem. Then I'm going to discuss with you the 3 reperfusiology randomized controlled trials that you might know, ASTA1, ASTA2, and COMPASS. Then the meta-analysis on different methods for reperfusion and some very detailed application scenarios to finish the whole talk. Let's start with defining the problem. And this is what we discussed just a few seconds ago. It's not about which stent retriever is better than the other. It's about many, many more things, like stent retriever type, okay, distal aspiration catheter, which diameter, which vendor, where do we position the thing? What we just discussed, lower, higher to the petrous bone, aspiration of the distal aspiration catheter. Do we need a contact to the thrombus or do we go wherever you want? The retrieval, how do we do the stent retrieval? Do we pull it back all the way to the hub together with the distal catheter, corking, pinching? How do we place the stent retriever? Do we push the whole thing? How do we position it? And what's the length? So we heard that longer work better than shorter ones. What's the right diameter for the right artery? Aspiration, only through balloon guide catheter, only distal catheter, both, no aspiration. Talking about aspiration, syringe, pump, pulsed aspiration. When do we start with the aspiration? When we are up or when we go up? What you see here, I'm pretty sure each of us has maybe 1 or 2 more ideas on what's the variable for thrombectomy. And all of this can influence, this works in my hands, this whole thinking. And the bad part about this, probably this is different for each individual patient what would be the best method. So let's start with the assumption that there is no best method. This will be my summary of the whole thing, but we don't need to be nihilistic because we know a few things, and this is what I would like to share with you. But then I really would like to share with you another idea, because when can we say that one method is actually superior to another one? And this, we need to define what does superior mean. Clinical outcome, technical outcome, perfusion frequencies, fewer complication, or do we also take economic variables into consideration? Let's say one method is 2% better but costs half as much. Is it then the preferred method? How do we measure it? Do we only use randomized controlled trials, or are we also okay with single arm registries, surveys, whatever? Then the final question, and I think that's a relatively new concept, when is something superior? Is it superior only when it's statistically significant? Or do we define a margin how much it needs to be superior? So for instance, it needs to be 10% better than the older method or somehow better. So this is all very much a study thing, but I think it's important for us to understand all these considerations when we make our assumptions about what's better and what's not. This is from the original publication from, oops, that was a bit too quick. That was too slow. Okay, upper left side, this is the original publication from Sam Zeidat about the first pass effect. So if you achieve TICI2C3, this is the first pass effect. We see a lot of TICI2B3 first pass, and this was the 95% for the NEVA device, for instance. It's not strictly first pass effect because this has been defined by Zeb as TICI2C3 in the first pass. And then there is publication from the Barcelona group. We did a publication, and on the right side, you see the largest publication on this per pass analysis, and this is from the German stroke registry. Okay, thank you. And what you see here is that, does it work? Yes. That with the first pass, okay, this is the first pass, and the green are the good ones, so MRS 0, 1, and 2, and this ugly brown things is the mortality. So you see that per pass, the outcome gets worse and worse, and tomorrow I'm going to talk about the other subject that you already mentioned, this whole bailout stuff. So it's absolutely clear that the first pass is really the best pass, and the question is how can we achieve a very high rate of first passes. And this is just another analysis that we did recently. So the reference, this dotted line, is TICI2B first pass, that's the outcome. If you stop after the first pass, if you achieve TICI2B, the comparison, the green one, is if you achieve TICI3 first pass. So that's the first pass effect. So it's obviously better to have TICI3 than TICI2B. But then it goes on. TICI3 in the second pass is still superior to TICI2B first pass. But then, after 3 or more passes, TICI3 is not better than stopping after TICI2B. So the practical summary would be that if you move on after TICI2B, you need to be pretty sure to achieve TICI3 with the next pass. Apart from them, you're getting just worse. But does this answer the real clinical question? I don't think so. That's the same thing. Okay, so this was just the definition of the problem. This was no answer yet. I'm going to talk about this per pass thing a bit more tomorrow. Then we have 3 actual randomized control trials on reperfusiology, how I would call it. And that's not so easy to understand. So number 1, the first trial adapt versus stent retriever. What is better? That's the obvious question, aspiration, stent retriever. And then we had the ASTER study from the French colleagues, 2017. It was negative, it was a superiority trial. So aspiration was not superior to stent retriever, but actually this was a very bold assumption that it's significantly better than stent retriever. The other trial published 2 years later by our American colleagues, COMPASS, was positive, meaning that there was no non-inferiority of aspiration versus stent retriever. So in simple terms, they are the same. And then we have, the next question was ASTER-2 study. This study compared stent retriever with stent retriever plus aspiration. And this was negative again, and it's a kind of disappointment because I personally would have expected that the combination therapy is actually really better than stent retriever alone. René is not surprised, I suppose, but all the others are well. So ASTER, primary outcome, TICI-2B3, primary outcome was aspiration success, 63%. Stent retriever success 68%. This is after the first method. It's not first pass effect, it's first line strategy, so up to 3 attempts. And the problem with this kind of trial is it's really difficult to run such a study. Let's just assume we have here in this room, we have a person who is a stent retrievist. And this poor person needs now to participate in a randomized control trial against aspiration because this man is not very experienced with aspiration, has inferior results within the trial. But then we have another person. She is an aspiratrice. She's really very well trained in aspiration, gets every catheter very distal, very quickly, everything perfect, and has inferior results with the stent retriever. And in summary, if we combine all the centers and all the interventionalists, we end up maybe with this study result. But what does it tell us? All the results are on average worse than the individual results with the preferred method. So still, even if the trial shows that stent retriever is superior, which is not necessarily the case, the aspiration specialist will have better results than the stent retriever in this trial. So if we go even further, what does it mean for the study? Let's assume you run a study with 15 centers or 30 centers here, and you have a predominance of stent retriever centers. The result will be very easily preferring the stent retriever. And if you have an aspiration-focused trial, you will have better results with aspiration. But I think the conceptual problem here is that maybe if you introduce a new method, let's say 2012, 2019, you will have a different outcome for a study if you run it early or late. If people have not enough training, the new method will lose always. And I think this is a huge problem that many people don't understand who want to start with a randomized control trial right away. So the COMPASS trial, the US study, aspiration versus stent retriever, did exactly that. They had a center preference balance, so exactly the same number of aspiration centers and stent retriever centers, and the results were exactly the same. So 50% MRS 0 to 2 in the aspiration group, and 52, and 50% in the stent retriever group. And the TICI-2B or greater on first pass, again, this is TICI-2B, this is not TICI-2C3, 57 with aspiration, 51 with stent retriever. So there was definitely no difference between both methods. And this is what we already had. And it seems to be that with aspiration, we are actually quicker to achieve revascularization, which is a good signal. But then the question is, how does it turn out in the long run? So this other randomized control trial, the ASTER-2 study, they found that the combination stent retriever plus contact aspiration versus stent retriever alone, that the combination was actually sheer number-wise inferior to stent retriever alone, which was, as I said, for me quite surprising. but it had also something to do with an unbalanced patient population with poorer premorbidities in the combination group, which made the interpretation of this trial very difficult. But if you look at the technical results, TICI-2B, 52C3, we have a superiority and really significant better results in the combination therapy. 86% final good e-TICI versus 72 in the stent retriever group, and the very good final result, TICI-2C3, also 10% better and significantly better in the contact aspiration plus stent retriever group. So the combination therapy in this randomized control trial seemed to be better technically, but this didn't translate into clinical outcomes. We will find a lot of explanation why this is the case. Yeah. So finally, meta-analysis, LVO, DMVO, posterior circulation, which method is better? This is what I would call a mega-analysis. It's a systematic review of meta-analysis. So you have several meta-analysis and you combine them and you compare them. And the best one was this here, published in March 2021 with more than 4,000 patients. And what they found was very, let's say, yeah, sobering. The TICI-2B3 was the only angiographic outcome favoring ADAPT. There was no difference in TICI-3 between ADAPT and stent retriever. Functional and safety outcomes also similar. Rescue therapy more frequently after ADAPT. So approximately 25–33% of patients would then be treated with stent retrievers. I will cover this more tomorrow. And ITT analysis led to non-inferiority of aspiration versus stent retriever. So probably that has also to do with large numbers. So if you have you focus just on the distal method, stent retriever aspiration, you end up with no differences at all. But I think it's still important to run these analyses. Basilar occlusion, it seems to be that in basilar occlusion, aspiration is associated with a better outcome if you start with aspiration. There is also a systematic review where you have, let's say, mixed results for aspiration versus stent retriever in the posterior circulation. I will skip this. This is what we did. We compared our relatively large group of patients with distal and middle vessel occlusion, so the more peripheral occlusion, aspiration versus stent retriever, also no difference in the first pass effect. Systematic review, again, it's severely focused on M2s here. The more peripheral occlusions are profoundly underrepresented. And if we look at this, again, aspiration, 74, stent retriever, 75, and combination, 84%. So it seems that for distal occlusions, the combination therapy is superior if we look at these numbers. But again, this is heavily focused on M2s, so no really distal occlusion. So it's a bit of a fake summary. So some maybe detailed application scenarios. Very recently published, very interesting from my perspective. They had a look at Mr. Clean, no IV data, randomized control trial. And you see aspiration above, stent retriever below. Combination therapy, 51% good outcome, 50% good outcome. And then you have a difference. So in aspiration, additional IVT improves the outcome by 5%, but additional IVT in the stent retriever group doesn't improve the outcome. It's not significantly inferior, but at least it definitely it didn't improve outcome. Interesting observation. So maybe, to translate this into practical suggestions, if you have contraindications for IV, probably it's better to use stent retriever because aspiration works better together with IV. And then we did an analysis ourselves on aspiration, which is not delivered not very, let's say, surprising results. We calculated the ratio between the diameter of the aspiration catheter and the vessel. And the closer they are, so the tighter the aspiration catheter fits into the artery, the better the aspiration result. Same thing is, if you get contact with the thrombus, you also have better aspiration results. So it's both not really surprising, but we did it in a very standardized way, and it really confirmed highly significant that this is really the case. And then we have this shape consideration, so you can have different occlusion types, not from the localization, but from the shape of the occlusion. You can have this regular cut-off occlusion and this claw-shape irregular occlusion. There have been plenty of papers, different names, claw sign, clot meniscus sign, whatever, but they have in common that it seems to be that with this cut-off, you have better success with aspiration, and with this claw sign, with this irregular, you have better success with the stent retriever. This is just the first study from Arturo Consoli, and they confirmed it in larger observations later on. Interesting thought, at least. They are running now a randomized controlled trial on the subject, so we will learn more about this in the future. So if I may summarize, this whole question, aspiration versus stent retriever, is just one of many technical variables. You remember this drawing, probably there are many more. Randomized control trials suggest aspiration has the same effect to stent retrievers, and please consider the limitations what a randomized control trial can actually do. Meta-analysis show as well similar results between both techniques. And aspiration needs to fit tightly, and you need to get to the clot, and probably works best with IVT in a regular clot, and the other way around, it applies to stent retriever, of course. I just selected aspiration here. And from my perspective and from the numbers that we saw, the combined therapy, aspiration, distal aspiration plus stent retriever should work best. But yeah, the case is still open, and the only randomized controlled trial on the subject didn't show superiority of this combined approach in clinical outcomes. Thank you.
Any questions?
Jens, it's not a question, but thank you very much, because, you know, I was really impressed by the topics that you touched, and it was not biased towards a technique, it was not biased towards a device or a particular company, and I think you touched upon many, many aspects which we routinely don't look at, and we just go running towards, you know, more and more recanalizations, and which is giving me the first pass and second pass, and I think it was very, very general, basic, at the same time, a very high level of conceptual talk. Thank you.
Thank you. That's very nice of you. And just one more comment. What René also mentioned, that what I observed over the years. So, for instance, with balloon coiling, stent coiling, the outcomes improved and improved and improved, and then we had suddenly flow diverters, and suddenly the stent coiling was not so good enough anymore, also in absolute numbers. So we decreased again. So probably we need to work harder with this scientific stuff. Yes, sorry.
No, this is also not a question. This is a comment, and again, thank you, because this is a topic that's very close to the heart of many of us, and it comes on a daily basis, and trainees that come out of fellowship frequently ask this question. I very much second what you said. I think what these studies neglect to mention or to take into consideration is the individual comfort and the technique of how somebody does unsheath or push and fluff a stent retriever versus aspiration. Do they do proper contact with clot? Otherwise, this is an argument, do you more like left bank Bordeaux or right bank Bordeaux? Do you prefer, if you're a car racer, do you drive a McLaren or a Ferrari? they're great techniques. They're only going to get better. Choose whatever works in your hands and do that. I think that's a very important aspect and a piece of advice to the people who are beginning their career to choose that.
Absolutely.
Thank you.
100%. Thank you.
Thank you, Jens. And it's just a comment also for this topic. The important is, and you touched when you said that aspiration.
Can you use the microphone? I think.
When you said you presented that graphic that was stent or aspiration and the results. The important, in fact, is to control both techniques and to know how to combine or not. When we start, now that we have much more than 1,000 strokes, we can have some experience and know a little bit more about the subject, because this is technical. It's only technical. It's not conceptual. It's the clot comes out or not. And we start with stent, then we switch to aspiration. And now we do aspiration. We have very good results. But what I do before, I insist 1, 2, 3, 4. Now I aspirate 1, 2, and then I switch. I switch to combine. I do both. And if doesn't result, something is wrong with the vessel. Maybe there is a stenosis. Maybe there is something. And I pay much more attention now to the morphology of the artery, because when we see some like this affiliated artery, it can be a stenosis, and then sometimes is the reason why it doesn't work, because now we dominate the technique, so if it doesn't come, it's not because the clot is stubborn and doesn't come out. Maybe it's the problem of the vessel.
Yeah, absolutely. Thank you.
So Jens, of course, it was great as usual. I did not expect less, but I found out you raised very good point. Is it possible to rationalize the treatment? In the end, no, because there will be different recipes a different way. I think you were completely objective, except for the last sentence where you put in green. Probably a combination is better, after showing results that says exactly the contrary.
It's a very good observation. Yes, if we just take Asta 2 as combination versus stent retriever, was no difference. And you are absolutely right. I was also considering all the meta-analysis, LVO and DMVO. That's why I did it. Probably I shouldn't have made it green. It should, maybe black would have been enough.
No, so it's good to have your own opinion.
Yes, but I should label it as more opinionated. But you are absolutely right. But still, there is evidence, even if this single RCT didn't support it. Thank you. But I think this whole standardization thing and better measuring what we are doing, this is what I'm really passionate about. Even if we can never standardize everything, but at least how we measure things, should be standardized. Thank you.
Okay, thank you, Jens. And then for the next session, I think you already had a coffee, and we can continue, and Guillermo taking the Red Bull, and he's ready for the next session. Merwert asked to put her presentation for tomorrow's session with neurologists in Russian-speaking group, and Rapid Eye couldn't come, and we will move forward. And now we have 4 presentations, 2 from Siemens and Philips and General Electric. I'm asking if it's possible to do 7-minute presentation, because 6:30 p.m. we need to leave by bus to the restaurant for the gala dinner. Okay, Siemens, Alexander. The presentation would be in Russian, and I asking our interpreters to translate from Russian to English. Презентацию. Наталья, можно будет переключить презентацию?
Could you please start it all over again? Good evening, distinguished participants of this conference. The intervention neurosurgery indeed was a kind of driver of the technologies that we are presenting and developing in our angiographic complexes back in 2004. For the first ever time, we have developed the flat CT of the head angiography as well as flat CT, but the requirement of the X-ray surgeons to the angiographs are still the same, very low beam load, ergonomics, and friendly interface, and availability of the expert options.
Of what we can offer currently. The artist icon and artist fan generation icons have been introduced, a new system for processing the image of optic when we have 300 million images, so kilovolts, milliamperes, milliseconds parameters. Then, depending on the radio opacity of the patient, the water equivalent of the patient in that plane, the individual algorithm will automatically select one of the 15,000 parameters to obtain the maximum resolution of the image with minimum radiation load. Formally, the dependence of quality of image on the radiation density looks like that. The larger the object, the more obese a patient is on the desk, the worse was the image resulting. So there was insufficient quality of image was partially the death, and partially it was not inadequate. So we say we need the X and Y, Z quality of image, and by reducing the radiation load where it is excessive and improving the quality of image where it's necessary. So I will skip several slides in order to save time because I have only 7 minutes to talk. So next, let's skip. What we achieve. Thus we can visualize on the left panel is the former one, and the right is the modern one. You see the level of reduction of the background noise, and you can see the better visualization of the vasculature, and the distal vasculature is much better visible. So next one is the imaging of the roadmap, optic roadmap, and current roadmap visualization. You can see there is no background noise, high quality of imaging of instrument of device, and the vascular map. As for the flat detector, so we can CT, thanks to the 16-bit CT detectors in most recent generations, and using the modern algorithms for processing the images, as you see on this slide. So there's the MSCT, and then below is the MSD, the same patient. Also, we taught our devices to provide CT scanning using this special trajectory. when there is not only raw and low directions, but the C-arm also in the, can be tilted caudally and vice versa. So we bypass the bones of the skull and thus visualizing, imaging the pathology in the basal and next to the dense bone tissues. Also, I would like to note the twin spin function when parallel to the floor C-arm can the ceiling arm rotate. They would rotate simultaneously when doing the 3D image CT scanning. And thus, we can save 60 to 90 seconds of time during per each single examination. So we can save a lot of time if we have several exams a day. Skip this slide. In general, we managed to shorten the PD-CT scanning versus 8 seconds currently versus 20 seconds before. The 3D scanning also became much quicker. So in the ARTIS Cycon and ARTIS Pheno, so we increased the key slow system to switch from femoral access to biplane imaging. We had to put the both arms in required position and have put the table in the required position as to make some 17 clicks and iteration to interlocute the device. As we use the ARTIS icon case flows, we can use this in 1 to 2 clicks and the device does it all for us. Also, we save time in one case flow. We can preserve many parameters, the position of the table, imaging mode, and many other functions. So these parameters are set up individually for each user, for each clinic, and used during the procedure. The next option I would like to mention is the DynaCT multi-phase, scanning using the one dose injection of the contrast media, and during the 60 seconds we can do this, and thus 50 seconds. So the contrast is injected intravenously 40 milliliters, then followed by 40 milliliters of saline. So we can visualize all phases of migration of contrast native, arterial, venous, parenchymatous, and so on phases. So we can detect the status at early phases. So we can image, as you can see, the occlusion of the medium cerebral artery and visually so the status of collaterals at the remote phases. Moreover, these 10 reconstructions can be sent by rapid server using DICOM protocol, and then the perfusion charts are produced and penumbra areas are generated and sent to us back. And this is a new approach to treating the patients with ischemic stroke, direct angio to angio when this patient is received in clinic. So in the at the score we have more than 10 bells and plus heart rate. This patient goes directly to the cath lab. Okay, we have only 30 seconds left. Okay, so next presentation we'll talk about this new technology. Thank you for your attention. If you have questions, we can ask them after the second presentation. So Alexander Petrovich, Mr. Polkovnik will talk from St. Petersburg, Russia.
Коллеги, добрый день.
Dear colleagues, good afternoon. Can you hear me? Yes, we can.
Тогда я поделюсь с вами своей презентацией.
I would like to share my presentation with you.
на необходимость поговорить о теме директ-ангио, конечно, нас навел ряд публикаций. Одна из последних 2021 года, в которой четко показано, что когда выбрасывается или игнорируется КТ, а пациент сразу поступает в рентгеноперационную, то клинические исходы значительно лучше, чем в ситуации, когда пациент проходит традиционный путь, выполняя компьютерную томографию или МРТ. Я не слышу перевода. Это у меня проблемы или просто перевод отключился?
Есть перевод.
Слышно ли меня? Скажите, пожалуйста.
Да, слышно, слышно.
Спасибо. Сейчас, извините. Соответственно, и результаты метаанализов также говорят о том, что функциональные исходы при использовании такого подхода, прямой трансфер в рентгеноперационную, лучше при сопоставимых показателях безопасности. Как можно преломить эту ситуацию на условия, которые есть у нас сейчас в городе Санкт-Петербурге? Ведь у нас есть формально клинические рекомендации, которые не позволяют избежать такого этапа, как выполнение КТ или МРТ для исключения геморрагических проявлений и оценки распространенности ишемии. Но, тем не менее, сравнивая результаты в региональных соответствующих центрах Санкт-Петербурга, более 2000 человек, мы посмотрели время от ввоза в лечебное учреждение до пункции бедренной артерии. Среднее время составило 69 минут. В одной из работ, происходящей не из России, это время составило 69 минут. То есть мы видим практически полное совпадение. Прямой трансфер в операционную, в рентгеноперационную позволил сократить это время до 16 минут, поэтому мы полагаем, что вполне можем сократить при использовании в перспективе этого подхода время до тех же значений. Безусловно, не можем упомянуть о том, что только наличие соответствующего программного обеспечения технической возможности дает нам возможность в операционной несколько расширить свое восприятие пациента с ишемическим инсультом за пределы традиционной ангиографической картины. Но прежде чем использовать рентгеноперационную таким образом, надо решить несколько проблемных вопросов. Первое, если мы привозим
we have to solve several organizational issues. If we take the patient to the, so how was in St. Petersburg, in the ambulance research institute, almost 90% of stroke patients requires thrombic evacuation, thrombic extraction. If we would take every patient in, so we would have 91% of angiographies will be void of thrombic extraction. So the literature says, so NHSS should be more than 10 points. So in more than 75% there is a occlusion of the large intracranial artery where thrombic extraction can be performed. But another question is, if we load this X-ray cath lab with these procedures, we have to postpone endovascular procedures, which otherwise could be performed at the same time. At the same time, if in the cath lab there is another ongoing procedure, so direct to angio mode is impracticable at all. So the first practical outcome comes. First, we have to maintain the working condition or both ways as to direct and to traditional conventional ways through the MRI or CT units. In the Russian Federation, there are three clearly protocols for clinical recommendations which say that it's mandatory to have native MRI or CT to rule out the hemorrhage and the nucleus damage lesions. So we have verified the occlusion of the main intracranial arteries. Any specification up to 6 cases, or in other cases after 6 hours, the CT perfusion should be performed, quantifying the volume of the nucleus and using the clinical signs. We should make a clinical decision. If we talk about the direct to angio, then we can replace the modality instead of CT and MRI. Of course, as of today, the direct to CT, we can rule out the intracranial hemorrhage. It's so adequate specificity and sensitivity according to literature is quite enough. So at least one of the requirements is ruling out the hemorrhage can be done in the cath lab. The second important issue, how to define the nucleus of the ischemia. Because even today, using the most advanced angiographies, we cannot achieve this goal to quantify the ischemia zone. There are two options here. One is to ignore the volume of ischemia. This is understood by those who are familiar with Soviet cinematography. If you cannot do something, just ignore it. So current Russian clinical recommendations prohibit us from doing this. The statistics says that the group with the NHSS more than 10 points during the first 6 hours, only 4% of those patients who underwent CT, so there was less than 6. So if this is in the operating room, the aspects will be the same. And the second thing is that in a big ischemic zone can be also visualized during the conus MRI. So if the aspects over the 5 points over the first 6 hours is preserved more than in 90% of patients with ischemic stroke, then thrombus extraction can be conducted. So the issue of the quantification of ischemia can be postponed because virtually most patients will have the aspects more than 2 points. If you look at the St. Petersburg statistics, we can use the data provided by neurologists. They have different cutoff values, 4.5, not 10, but less, because those cutoff values are adjusted for the thrombolysis, not for the thromboaspiration. But the 2.5%, more than 4 points, have more than 21 points, which is more than 10, and then others have the more than 25. So which makes a total of 30-40% of patients will have the condition which we say, talking about during the first 6 hours, they will have more than the NHSS score, more than 10 points. After the patient was examined and the lab test and visual imaged, so they go to the cath lab, and the other day I saw the database, 2,800 patients, and the carotid region, 74%. Those are patients during the first 6 hours with the NHSS over 10 points. So if we are to implement the principle direct to angio, so the workload for the cath lab will be extreme, and the number of patients who will undergo this expedited thrombo extraction will increase considerably, at least twice as much. So secondly, how we can handle the ischemia if we cannot quantify it using the MRI and CT. It cannot be quantified in the MR gleam early So in this, the first part was estimated by the and the ischemia nucleus was began to be evaluated only after it was over the 1/2. So the same principle was used in the ESCAPE trial when they used the multi-phasic CT computerized tomography. Now it can be replaced with dynamic CT scan, multiphasial, which in essence helps to emulate the conventional CT with obtaining the same results. Moreover, the modern protocol, which can be implemented in the 90 cycle, enables it to use the rapid processing algorithm and obtain the same calculated parameters about the volume of the ischemic nucleus and the interrelationship as is provided by the CT. This is a 100% solution of the problem. What are the other options to the same problem? The alternatives can be found to the conventional CT. We have the recent publication in 2022 for neuroimaging when the native CT was compared to quantifying the ischemia nucleus using CT, calculating the collateral circulation as a golden standard. They solved the infusion-weighted MRI. So the aspect calculated using native tomography was correlating worse with the MRI perfusion than using the CT angiography and CT perfusion. So the aspects can be easily replaced by the conventional, by other methods of estimating the nucleus of ischemia. Thus, in the CAT lab, using the Siemens products can easily quantify the ischemia volume and give the more precise quantification of the ischemia nucleus and so on. As for the occlusion of the artery itself, it is difficult to using the cerebral angiography. It is impossible.
But nevertheless, even during the preliminary test, when we are carrying out perfusion and multi-phase CT, we can evaluate not only the volume of ischemia nucleus, but also the main artery. That is to say, we can obtain the answers to all the questions we are interested in according to the clinical recommendations, and we can take a decision taking into consideration the opinion of the neurologists and the radiation therapy experts on the vessel thrombectomy. As to the conclusions regarding possibility of use of such, I would say, organizational maneuvering as direct transportation of the patient to the operation room, actually we believe that it will give us less complications in patients with ischemic hemorrhage. However, the direct to angio will require modification of the protocols and the clinical recommendations, as well as the legislative basis of the Russian Federation, because they can be changed not frequently than once every 2 years, and therefore we will try to discuss it with the specialists. Direct to angio does not change the rerouting of the patients. I would say that it is a kind of bypass and a fast track for implementation of extraction of clots. And finally, the advanced angio complex will enable us to find an equal alternative for neurovisualization and clot extraction. And it will be probably a very equal alternative to the ways that we are using today. Multi-phase scanning, CT angio and CT will exclude the sequential hemorrhage, intracranial arteries, and it will also enable us to evaluate the perfusion. And I would like to say that this information is more than enough to take the decision. And direct to angio will also replace the place where the decisions will be taken, to the pre-op room where the neurologists will probably be moved as well. Therefore, the operation room will be a perfusion manipulation room for such patients. Thank you very much for your attention.
Александр Викторович, огромное спасибо за доклад. Я знаю, что вы торопитесь, и мы тоже.
No, I'm ready to discuss it, and I still have time for discussion and the questions.
Быть готовым, и я думаю, что мы можем поделиться вашими контактами ребятам. Вот Александр Капралов здесь, и если возможно, вот, ваши контакты ребята могут запросить. Я думаю, вы не против. Ага. Все, тогда вопросы через...
К сожалению, нет такого продвинутого аппарата, как показано здесь. У меня аппарат попроще, но все равно оценить перфузию и получить эмуляцию, надеюсь, будет и такой, и я смогу делать перфузию.
Ну, дай бог, дай бог. Спасибо, что уделили время. Вот, очень жаль, что не могли прибыть персонально. Вот, надеюсь, в следующий раз.
Надеюсь, увижу лично вас всех, смогу пожать руку. Спасибо.
Все, спасибо. Спасибо. Next speaker, Alexander Lensu from the Philips company. And 5 minutes.
Уважаемые участники, добрый вечер.
I will be very brief because I'm pretty sure that the technologies that are implemented by Philips in its practical work demonstrated in the operation rooms much better. And we have seen it more than once. And thank you very much, Zhilke Sailawich. And our mission, the mission of Philips, is to provide support to your everyday routine work and to help you do magic that you are doing every day. And today I just wanted to show one option to you, which will make your life easier, and it's a smart city, a possibility of... Okay, so the video is about to start. It's an option which will enable you from the operation table in the operation room will enable you to have all the 3D images and reports next to the operation table. Therefore, you are reducing the time of movements between the control room and the operation room, and the decisions will be taken much faster. In real time, you see how this option is actually used and how we are collecting city-like images, after which the surgeon will get back to the operation room, and during several minutes at the control dashboard on the touchscreen module in the operation room, the surgeon will be able to make all the necessary computations and will make sure in the surgical intervention. The video is only 1 minute long, and actually in real time, this is exactly how much time it'll take you to take your decision. I also wanted to draw your attention to a step-by-step tool that is presented by Philips that jointly with our good friends and doctors who are during their daily routine work use these innovations in their practice, and they're improving the well-being of their patients. We are discussing during webinars all these techniques and all these advanced tools. You can scan the QR code, get registered, and get all the updated information on various webinars during which we are analyzing all the options and available technologies. And less than 1 month ago, jointly with Dr. Andrei Petrov and Manzhelke Sailovich, we have conducted an intervention. You can actually reach this presentation if you scan the QR code, and tomorrow Mr. Petrov is going to talk about aneurysm flow tomorrow. Therefore, let us save our time and see in our clinical practice how the innovative technologies of Philips work. Thank you very much. Okay, thank you very much. Perfect timing. Thanks a lot to Philips company, because you are really facilitating our life. You are making it easier and more comfortable. Heljuk. Thank you very much, distinguished colleagues. And my role is the simplest because I'm going to speak only for 5 minutes, and it will be the last presentation of the day. So I'm going to skip some of the pages in my presentation, and you can contact me later for more details, what GE can propose in terms of intervention angiosurgery. First and foremost, I'm going to talk about the monoplane equipment as to biplane machine IGS line of equipment. Last year, we updated this family of equipment, and 2/3 of the programmed functions were updated, and we integrated AI here. I will mention it a little bit later. As to the advanced applications, some of them are present on this slide, others were updated, and the whole portfolio for the work with any nosology of the intervention microsurgery is available in GE. 3D fusion, for example, and several doctors were talking about 4D angio, and such applications are available with GE. We also have a possibility to work with any nosology which are typical for intervention microsurgery. I would like to show you lateral gantry machine and the new images that we generate with the help of AI. It's probably a little bit different from what you are used to in GE previous generation equipment. And I will skip several slides. But as to the applications of advanced visualizations that have been updated in the new line of AI integrated equipment, these are 3 DCT HD, and including for the direct to angio implementation when you are bypassing the radiotherapy department. And we are also conducting 2-phase venous scanning, and we can take a look at the brain with high differentiation of the active substance. Here you see the new devices with the suppression of the metallic artifacts, and in the left part and the right part, you see the option of suppressing of metallic parts, and in this particular case, it was a clip. And there is also a visualization of CT integration of direct and lateral, and embolization of the patient with aneurysm rupture. So we segmented the vessel volume, and for better control of the manipulation, we also extrapolated the angioscopy with Here is SAH with the use of the fusion navigation and for embolization and implantation of stents. This is what I mentioned at the very beginning of my presentation. Auto right is the chain of the AI and generation of images, which is fully automated, minimalization of manual adjustment by the operators, and maximum quantity of various parameters that are delegated to the machine itself, and they are present in all the last generation angio machines. And let me skip the hybrid operation, and the customization of visualization will be present on slide, and the doctors can actually adjust the images depending on the interventions and the needs that the doctors require for certain cases. I will skip several other slides. Let's take a look at the new quality of visualization that I'm pretty sure many of you haven't seen in GE angiographs, including AI. In the left part, you see the previous generation visualization, and on the right part, you see the updated and renewed visualization, which is secured by auto right. And there is also the automatic segmentation of arteries, so automatic computation of aspects, which is also available at the workstation at the GE. It is multimodal. It's exactly the same as in radiation or MRI departments, and it accelerates the work with acute ischemic strike. Therefore, aspect, angiography, evaluation of laterals, perfusions, and generation of full, complete report, and its distribution via email. Thank you for your attention. Anton, thank you very much for keeping the timelines. Thank you very much, Anton. And in Tashkent, we were operating on a patient, and Anton demonstrated how the network base is used, and GE calls this function 3D CT. And therefore, I think that all the companies are moving ahead, are progressing, everyone in along its own lines, and everything depends on the IT experts working in different companies.
Participants, now we are planning to go to the restaurant for gala dinner, and I want to say special thanks for speakers online with Walid Brinjiki, Adnan Siddiqui, Charbel Monayer, Professor Jacques Mouret, Demetrius Lopez. They spent time and they shared very great experience and knowledge. And I think everything is available now on YouTube, and you can go to the YouTube and you can look again, and if you have some notices, you can see. And the brilliant part of these technologies using YouTube, all our colleagues from abroad, especially from English-speaking countries like India, they participated, and at the end of the day, we can see how many people was online and was together with us outside of this conference room. Thank you. Now we will go to the buses to go to the gala dinner. See you tomorrow morning, and there is some changes in the program. The live case will start at 10:30, maybe 11, because conference in China, OSIN conference, asked at 12:30 in Shanghai. It would be 10:30 in Almaty. That's why we will start our presentations at 9. We plan to do
4 cases for tomorrow, but this change in the program. In China, it's also shifted our patients, and we plan to do 2 cases tomorrow. Maybe if we'll have time, we will do 3, but more realistic 2 cases. And both of them would be transvenous AVM embolization cases. Thank you. Let's go for Galadina. Всем спасибо. Все собираемся и дружно, у кого есть пригласительные, едем на галоужин.
Precise in terms of
and we did a CT program, and what we saw was